I apologize for the lateness. We had some trouble on some of our folks that needed to be in on Zoom to be with us. So I think we've got everybody aboard. So we'll go ahead and open up our meeting today. The first thing that we have on our agenda today is a follow-up information for the October 5th. And I believe that Marissa Bayless, who will be our new staffer, because David has decided he wants to go into bigger and better things. And he's going to do this, but Marissa's going to take care of us very well. So welcome to the committee.
Thank you. Good morning, committee. Marissa Bayless, KLRD. Before you in your packets, you should have a folder within a folder. For organizational purposes, we've tried to put all of the follow-up memos into one folder so that you'll have them throughout the entire committee. So if you look for the salmon colored sheet, that will have the follow-up questions from our last meeting. One of the first questions that was asked was the difference in requirements for clinical hours for licensed clinical social workers in surrounding states. So we provided some information there for you. For Kansas, last year in Senate Bill 15, that was passed, this changed the required hours for specialist clinical social worker from Kansas from 4,000 to 3,000 hours. And there's a bit more information there. Another question that was asked was
You're on the salmon color.
the salmon color, yeah. Another question that was asked was what data Kansas is tracking in the foster care system. So we had some follow-up information from DCF, and they've provided a couple of different links. One to a KLRD memo that was from the Special Committee on Foster Care Oversight about tracking educational outcomes for foster care youth. So we provided the URL there. We also linked to a presentation from DCF to the Special Committee on Foster Care Oversight on the Family First Prevention Services Act. So there's a lot of good information that they provided to that committee. And then the first attachment that you will have is the Kansas State Crossover State Policy Team document. So this provides some more information on the model that they talked about last meeting. And then lastly, we provided some testimony from the 2019 Senate Subcommittee on Social Services from a member of the Governor's Mental Health Task Force that was concerning his experiences navigating the Kansas behavioral health system. So after this meeting, we will again compile any follow-up questions that any of you had and then put them in this folder so that you will have them for next meeting.
Marissa, do they, I mean, it's good to have the link so we can get down into the weeds, but is there a list of the tracking criteria that is used?
So this was just the information that DCF had, but I can ask them for that tracking information as well.
Other questions?
That was it, so thank you.
All right, now we are ready for updates from our working groups and visioning exercises. And Hina, I believe you're up first.
Thank you, Madam Chair and members of the Special Committee and working groups. Good morning. My name is Hina Shaw, and I'm a senior analyst at the Kansas Health Institute. With me this morning is Carly Houchin, who's facilitating the three working groups. So during the October 5th meeting, the three working groups discussed their barriers, challenges, and also the high-level overview of recommendations related to workforce prevention and education and data systems. After that, there was a robust roundtable discussion regarding goals or vision for some of these topic areas. So since that meeting, each of the working groups has met twice to review recommendations for their remaining topics, and they used that rubric that Carly shared with you at the last special committee meeting to characterize these recommendations. And next month, they're going to go through and finalize their list of recommendations to present at the December meeting. So I'm going to pause there and see if anyone from the special committee or even other work groups has questions about the process that Carly could address. All right, that was my 10-second rule. So let's get started then. We're going to use the same format like last time. The chair of the work group will provide a high-level summary. They'll only provide it for their second topic area, address any questions that the special committee or work group members may have in this virtual roundtable that we're in right now. And then we'll do the visioning exercise for that topic area. Then I'll invite that chair again to present their next topic, and we'll go through the exercise again. So first up, we have Greg Hennon from the Finance and Sustainability Working Group, and he's going to present an update for the topic on funding and accessibility.
All right, thank you. And I will start out by apologizing for my camera always cutting out. For some reason, Zoom doesn't like it very well. So if I disappear, I'm still connected and you'll be able to hear me. But at any rate, there's a one-page summary document of our working group meeting that was held on October 14th around funding and accessibility. There are actually 30 recommendations from the prior work groups that we were evaluating, but what's on that document is again kind of the high level summary of the 4 or 5 topics that kind of percolated to the top as the most relevant in the sense of both ease of implementation and high impact. I would also invite Dr. Will Warrens to offer any feedback as I go through this if I misstate something or if I miss something. But at any rate, first recommendation surrounded allocating resources based upon data-driven decision making, and specifically looking at local suicide prevention efforts and promotes support groups in fundraising efforts and building capacity for those suicide prevention efforts. This recommendation was actually kind of melted together with 2 that seem very closely aligned. The committee's conversation was that not just in relation to suicide prevention efforts, but we wanted to keep the recommendation that data-driven decision-making be at the forefront of whatever we did with any and all of these recommendations. So that was certainly held on to and emphasized. Second recommendation you'll see there is to facilitate a detailed review of Medicaid reimbursement rates for behavioral health services, including mental health and substance use disorder treatment. There's a lot of discussion about just the history of unchanged behavioral health Medicaid rates. We believe strongly that needed to be reviewed if we're going to have a modernized system. And I don't know exactly what subcommittee member brought this forward, but felt like a new recommendation looking at, when doing that detailed review, looking at a 10 to 15% increase was what was expected to be necessary for that to truly be sufficient. Recommendation 2.3, Excellence in Mental Health. This is a federal initiative, the Excellence in Mental Health Act, supporting expansion of that federal initiative is something that was recommended and strongly supported, but also coming from that was a new recommendation that the group consider a state plan amendment or a change to the 1115 waiver, so that interested individual providers could gain access to the Certified Community Behavioral Health Center model. We're going to hear later in the day a group from Texas that approached getting into the CCBHC model through that 1115 waiver. The reason that's important is the Excellence in Mental Health Act had only so many open slots for entire states to embrace that treatment model or that clinic model. And there are now opportunities for individual centers, independent of a statewide effort, to get that CCBHC certification. So the committee felt like it was worthwhile to promote additional states being added to the federal initiative, but if that wasn't possible, to absolutely let individual organizations chase that certification because of the enhanced outcomes that can be achieved for patients. The last recommendation in terms of highest impact and ease of implementation had to do with assuring adequate funding for Senate Bill 123. These are individuals that are in need of substance use disorder treatment, particularly offenders that are convicted of drug possession and nonviolent crimes. That is a pot of money that has been perceived as kind of static and inadequate for a long time. And the kind of finer point of the recommendation from the group was that the state increase its maintenance of effort, the state general fund dollars for providers in the Beacon network. We've got a certain network that's already out there operating with, again, finite dollars kind of on a grant basis. And most of those providers are serving in excess of what their grant allocation is. So the thought was to certainly make that existing provider network whole for the work that they're already doing, and then also evaluate the potential expansion of that provider network through additional funds. It was noted that Medicaid expansion might be one mechanism for additional funding. So those are the top 4 recommendations. There were several others that were discussed. Of those 30, some got combined. We ended up scoring those through an online survey, Qualitrix, I think was the name of the survey. And we haven't had time to discuss as a group all of those recommendations that we scored individually. That's something that's going to be happening in the next week or 2. So we'll report more on that later. The only recommendation of the 30 that was removed was in regard to the suicide prevention work group. That was combined with the earlier recommendation, the first one that I spoke with. And then the barriers surrounding funding and accessibility had to do with the Medicaid reimbursement rates. Very difficult time attracting and retaining provider and workforce members, and then the high cost of Medicaid expansion. The recommendation there was simply for that to get additional discussion with a larger group, and not something that we as a subcommittee felt like we could really have any significant impact on. So anyway, that is the summary of the Funding and Accessibility Subcommittee.
Thank you, Greg. Committee members or other work group members, are there any questions for this work group?
Are you going to go through the October 28th one as well?
If it's okay with the chair, I think what we'll do is go through topic area by topic area, so you can see what recommendations they've been discussing, and then do the visioning exercise, and then invite Greg to present the next topic as well. We can also do them both combined. I will leave it to your discretion.
That's fine.
Any questions specifically on funding and accessibility? Otherwise, we can jump into the visioning exercise. All right. Go ahead.
Well, I just want to say, I think in general, what I've seen coming out of this discussions in our group is really looking at defining and observing the appropriate population with the right service mix. And I think that's a general thing across everything we're doing in the finance and sustainability group. That's all, just that comment there.
Thank you, Don. And that segues nicely to our kind of goal setting and visioning. As you've now heard about some of the recommendations that the working group has thought through, it's a lot of problem solving and setting up for success in the future if the right codes are addressed, and thinking through what finance would look like. I also want the roundtable as a whole, so both the special committee members and those that are on the work group, to think through, you know, what accessibility looks like as well. So while you're thinking about, is it sustainable funding streams or is it local versus federal funding? What about the accessibility side? Is funding tied to accessibility, or is there something different you're looking at? Is that a separate piece? Dr. Warrens, did you want to make any comments as well?
No, I would just support what Greg has said in what we've been working on. I think some themes I've noticed from our work group for a modernized mental health workforce has been trying to expand inclusivity, trying to understand that there's differences between rural, frontier, and urban counties, and how to include differences in recommendations to expand our reach throughout the state. I know there's been lots of talk on making sure that our workforce is diverse with race, sexual identity, and language. I know that there's that a lot of these projects appear to try to, in a good way, try to follow a member through gaps in care, and when their symptoms take them into special populations. There was a lot of talk on foster care, families, veterans, crossover youth, the legal system, and substance use disorders, and trying to make sure that our services in Kansas can follow the member wherever go within this system. I know that we've talked a lot about strengthening our workforce and recruitment and training. I think a lot of these projects require cooperation between MCOs, state agencies, and providers, which I think this committee itself is indicative of, and trying to leverage new technologies and telehealth to increase access. When you actually talk about funding specifically, I think that a common theme, perhaps the number one theme, is the ability, the amount that Kansas can participate in the Excellence in Mental Health Act seems to be a very unifying concept of how that would benefit the funding in Kansas. Now, when it comes to Medicaid expansion, that one, everyone has a different kind of opinion. That certainly would increase access, but that does not mean everyone is supportive of that. I do think that later today, there's going to be a talk by Keith Rickard at 2:45, because one of my biggest thoughts on the funding and sustainability work group is, what if those don't happen? What if we're not able to participate in the Excellence in Mental Health Care Act? And, for better or for worse, what if Medicaid expansion doesn't happen? What is our funding plan with a structural logic, specifically for the Medicaid and the uninsured populations? And I feel like the best way to start that part of the conversation is, Keith Rickard, who was my executive director for the last 10 years at the Guidance Center in a CMHC system, is just going to try to outline the history of the structural logic of the funding and how that structural logic may be tripping us up now at this point in time. And so I feel like that's a huge issue yet to be addressed. But those are just some of my thoughts about what the work group's been working on and what we're trying to move towards in a modernized mental health workforce.
Thank you, Dr. Warrens. Again, I'll pose to the committee as a whole and the roundtable, what are other people's thoughts? Is the future really looking at these sustainable funding streams? Is there a different funding stream that should be thought through as we're building a strategic framework here? Local versus federal funding is another theme that has been picked up. What are everyone's thoughts on that? I think another comment that has come through a lot is, how do you legislate resources that, again, the sustainability, but goes beyond each administration, so you're not recreating the wheel every time? What are people's thoughts on that?
I think one of the things that we need to look at as we're doing this is some of our, we got 3, I believe, CMHCs that are government-owned entities. And it would be good to look at those and see how much community buy-in, because those are in big urban areas, to see how much community buy-in is actually money's being put into those programs. And then maybe reaching out to some of our rural partners out there and finding out what they might be able to participate in as well. And then we might be able to figure out a way to maybe maximize that and help match those dollars somewhat.
Madam Chair, this is Kyle Kessler.
Okay.
I was going to ask you, are you referring to a possible, like an intergovernmental transfer type arrangement?
It could be along those lines. I don't know if we have that flexibility to do that, but it could be something along those lines, yes.
Okay, thank you.
Representative Ballard.
Thank you, Madam Chair. Would you explain that further? I'm not quite sure what you mean by that. I'm sorry. I'm sorry.
Kyle, she wants you to explain intergovernmental transfer. You brought it up.
Well, and I have a pretty cursory understanding of it, and I think it's something that the Texas folks could probably talk about a little bit more as well, because they were able to look at some of their state and county funding and then look at using that towards Medicaid match in a way that allows them to maximize their federal funding. So, and the chairwoman's right in terms of what you see in terms of county contributions or county investment in community mental health centers. If you've seen one, you've seen one. Johnson County's the largest in the state in terms of how much that they invest, and then there are smaller rural counties that do the very minimum amount, which would probably be $10,000 or $20,000 or something like that. So it really, there's not an exact formula for it by county.
Ma'am.
Yes.
All right. So Kyle, does that mean that that's more grants, or would it be match for match, or is it just a partnership? How does that money come into play? Because that can be county money, which our county gives to Burt Nash.
Right.
So I don't know that is that the model you're following?
Yeah, well, some. I mean, I think that when you look at the manner in which counties and county commissions give to their CMHCs, usually it's a mill levy amount, 1 mill or a couple mills or something, and then others will just do a flat appropriation. And so like Greg Hennon and Don Jordan have a much better understanding of how that works historically than I do, and Lisa Southern for that matter. They're all they understand the financing pieces of CMHCs as it relates to them specifically, but the potential for it wouldn't work so much as a grant as it would trying to figure out what the amount that could be matched would be, and then move that to the state government.
It gives me a better idea. Thank you. Thank you, Madam Chair.
Madam Chair, this is Denise Sisman.
Yes. Go ahead.
I strongly support that approach. One of the things I think that's really good about that is it does help us to leverage the local and state dollars and increase overall funding by drawing down that federal Medicaid match. In addition, I think to Hina's comment about, or Hina's comment, I'm sorry, about sort of how do you avoid legislatively determining how much funding is allocated on an annual basis. When you do have local or state funding that draws down federal Medicaid match, it protects it in some sense, because if you were then to look at cutting that funding, you're also then looking at cutting a significant amount of federal funding. So I think it makes it less attractive when budget cuts need to be made to look at that source of funding. So I wholeheartedly support that. And from what I understand, it sounds like Kansas isn't doing that to the extent that it does have the possibility to draw down additional federal funding.
Anyone else? Back to you, Nina.
All right, then I will invite Greg Hennon to present the community engagement update.
Yes, so also in your packet, there is a summary of the Finance and Sustainability Work Group's October 28th meeting on community engagement. There were fewer recommendations for us to discuss, and we got through those a little more efficiently than the list of 30 we had prior. But the ones, again, that kind of percolated to the top in terms of ease of implementation and highest impact are listed there as the top 4 recommendations. The first one surrounds justice-involved youth, and there are 3 pilot communities that the original work group had identified to work with Kansas Department of Corrections, community mental health centers, and SUD providers. And the discussion around that was that those pilots would certainly need to be continued, and data gathered from those with a look at how that might be expanded, assuming that the outcomes are favorable and creating the impact on the youth that is desired. The second recommendation had to do with foster homes, both recruitment and retention there, with an increased funding for supplemental training, and we modified the recommendation to be specifically supplemental training on behavioral health needs, and providing additional financial incentives to support SED youth. Foster families that can get additional training and support around those high needs youth, believe that helps maintain that placement as opposed to experiencing disruptions, and felt like that was a very important investment for the state to make in making sure that those youth get everything they need without disruption or movement from community to community. Another recommendation there has to do with actually a supported employment program for veterans and veterans' family members to increase engagement of stakeholders, consumers, families, and employers through the Kansas Department of Health and Environment implementing of that supported employment program. There was a belief that by not leveraging all that is available through those programs, we're leaving some federal money on the table, and that is obviously to the disadvantage of the veterans. And it's very widely known that getting individuals of any walk of life engaged productively in an employment setting is an important part of recovery and is a key social determinant of health. So being able to build that program and make it sustainable, we felt had the potential to really have a ripple effect that would have a large impact on not just the individual, but the communities in which they reside. The community-based liaison, the 4th recommendation there on the list, was to fund and improve resources for community-based liaison, specifically around justice-involved individuals, help their re-entry into society on their pre-release planning. That would involve both mental health and substance use disorder and any co-occurring conditions. There has been at least some initial discussion with KDADs and the community mental health centers about conceptualizing what a community-based liaison for justice-involved individuals would look like. There is reference to that in the current year's participating community mental health center contract. However, from a treatment model approach and certainly from a funding perspective, that has not been further developed, but we believe that it's certainly worthy of doing both of those things, developing that model and ensuring that there's funding for that liaison activity to occur. There were a couple of recommendations that were removed. Two of them simply because they read a little more like a mission statement. They were very appropriate and good values or ideals to pursue, but the recommendation themselves didn't have a particular action item necessarily attached to it. And so those were not acted on. We also had one recommendation that we did not score simply because it was already being implemented by KDADS, and that had to do with increasing collaboration with community partners around local prevention efforts for opioid and other substance use disorders. There were a couple of recommendations that we thought simply needed to be deferred or tabled. One was around court-appointed special advocates, the CASA advocacies. That was discussed at length and obviously was something that the group valued highly and thought needed further development, but did not feel that we were probably the subject matter experts to put that together. So there was a recommendation to defer to the Foster Care Oversight Committee the development of that CASA recommendation. There was also a recommendation on treatment navigators, develop a statewide treatment navigator, but that was the extent of the recommendation, and we didn't have any previous committee member to speak to that, so we tabled that subject just because of our lack of knowledge of what was really being asked for, and if that was a single statewide navigator or a system of individuals that would work in that regard. Then you can see on the document there's a list of kind of barriers that we discussed and encountered as we talked about community engagement, and I won't read all of those to you, but certainly addressing stigma was an important part of that community barrier for communities to have a working knowledge and have widely available information about mental health treatment. Dr. Warrens has already talked about the importance of diversity in our communities and in our treatment provider network. County level funding is an important part of what we're doing, not just today, but if there's some sort of certified match possibility through a CCBHC arrangement, we certainly want to leverage that. One of the gaps that was talked about briefly, and Kyle mentioned this, is the statutory allowance of counties not to participate in funding a local mental health center. The statute from its very beginning back in 1964 allows for a county to provide between 0 and 2 mil in funding community mental health. So there's a 2 mil ceiling for the local dollars to be put toward community mental health, but there's also the option of 0 mil. And I don't believe there's a county in the state right now that is not giving at least something to the mental health center for that mental health agent work that they're doing. But that allowance again is there, and we did have one mental health center 4 or 5 years ago that did experience 0 funding, which makes it very difficult to address the uninsured. Next barrier is a large uninsured population. We'll obviously have a lot of discussion around how to address that. The importance of regional crisis centers got a lot of conversation, but funding and location and staffing for those are all very large barriers, but they do have the potential of being a relief valve for state hospital beds that are not available for patients in need. One of the challenges has been the loss of community psych hospitals or psych units. Just in Southeast Kansas, as an example, for our catchment area, we lost 47 inpatient psychiatric beds when 3 community hospitals stopped delivering psychiatric services. So youth and adults have very few options. Most of our individuals have to leave the state or travel 2.5 hours to get to a hospital. because the state hospitals, again, are not available. So affordable and accessible care is pretty key, but that community engagement really hinges on stigma and local funding, and then any additional local services we can provide, such as those crisis centers. Anyway, that's all I've got.
Thank you, Greg. And so, so you've heard kind of the action plan or some of the recommendations around that. And I will point you to the recommendations removed, because maybe that's what we can start our conversation on, the visioning or goal setting part of this. As the working groups are going through these recommendations, it's nice to shape kind of what the vision is so that it can help them through prioritization later. So when we think about community engagement visioning, you know, are we thinking about a one-stop shop where everyone's there, community-based organizations, behavioral health services, primary care, and I know this crosses a few different topic areas. Is it engaging new partners and stakeholders? Is it that greater cross-sector collaboration? So I think that's one of the community collaboration recommendations that was removed. Is that more of a vision than an action plan that this roundtable wants to consider? Do we need to think about other partners or other providers, like community health workers have been mentioned? Are they your liaison or building that new workforce there? Is it wraparound services such as housing and things? I think it would be helpful to hear, what does community engagement mean to everyone in a modernized system, and what does success look like there?
Now, can we get it's on the list of the barriers discussed on this topic section. It referenced Sheriff Easter's report. Is that something we can get a hard copy of sent to us or emailed them?
Can you state that again, Chair? Which barrier?
It's on the barriers discussed on this topic on the back page. You go down 3 bullet points, and then you get into the little open circle bullet points, and the second one is Sheriff Easter's report. If we could get a copy of that report.
We can send you a copy of that.
Committee, this is Representative Elizabeth Bishop. In terms of community engagement, one possible rallying point is the criminal justice system in a locality, especially those that are more in the urban type. I know that, you know, the Sheriff Easter certainly was the spark plug for a highly collaborative system that took effect in the Wichita area. So the partnership between the criminal justice system and all of the other parts of the mental health system in a locality is crucial.
Thank you. And again, I'll pose the question of, again, with community engagement, and when we think about her comments, is it fixing some information void that's going on between community members? Who are the stakeholders that really need to be engaged, and are they being engaged?
I mean, I think you have to look at your county, county definitely, because that covers in all the cities, and then, maybe it's a discussion that needs to be had with the League of Municipalities. Because this is not an issue that the state can be solely responsible for. There's going to have to be a step up from the communities, and I think that it's going to have to be in a financial way. So I would look at counties and cities.
Are there any instances that those in this roundtable are at where there are community state partnerships that work really well to improve community engagement? Another question I'll pose is, what would success look like? So if we are building the strategic framework and community engagement is one of the topic areas, what do you want to see in the future? Is it that what does that mean? What does it mean to have the community engaged in a modernized behavioral health system? How do you define that?
I mean, I think that one of the ways that we can do that is to take a look at what services that we currently have in our community, because you start to find that you've got maybe several small organizations that are providing some services, but if they were brought together perhaps in a bigger group, and that doesn't mean them to lose their identity, but to know what all services are available so that when people are trying to navigate this system, that we have, maybe basically one shop that can, direct them to some of these different organizations, and you don't overload just one part of your system.
Representative Elizabeth Bishop again. I believe that the instigation, the motivation for the collaboration that took place here in Sedgwick County started, in a sense, with finger pointing. If you have a system and different parts are saying, well, if you would do something better, then we wouldn't have this problem. And instead of finger pointing, they sat down and worked through those and then expanded it to wider community engagement.
Carpenter?
Thank you, Madam Chair. Representative Carpenter here. I think that, for instance, the recommendation removed the treatment navigator. I think that those are very important. All of these things, what you're talking about is a one-stop, a sheet of phone numbers or access to different agencies. I think the reason that we tabled that was because how big is this going to get? Some of the discussion was, is it going to cover private insurance and this kind of stuff? I can't see us hiring an entire room full of people to do this, but I do think that it's a very important part of this process of being educational, as we talked about the other day too, being not only educational, but also, like the chair just talked about, who provides what and how can you get that information. So, and I really think that's probably one of the cheapest alternatives to this whole program is just getting that information out there. And how do we get access? How do we allow someone that has a mental health issue, where do they go? Where do they turn to? And you guys, we all deal with that every day when we have calls, not every day, but we have calls like that. And it's complicated. So I think we need to work on that part of it. It's not that we didn't want to tackle it, it's just a great big issue.
Well, it's real easy to, as Representative Bishop brought up, is, finger pointing can start. I think there's always the issue of turf, and you're going to try to, demean my little small group and, bring it into a big group. And that's not the intent that we're looking at. It's just like, what do we have available? Because we do know that we have a major issue on workforce shortage. And there's no quick way to overcome that. We wish that we could. We're looking at some alternatives on that. So I think that if the communities would look within, okay, what do you have and how can we bring this together? And that's, definitely it's going to be a little bit easier, I think, from some of the larger communities, but it's also going to be a little tougher for them because there are a lot of groups that are out there. But if we overload, let's say we just overload on our CMHCs because they're setting the capacity, but there's another group out there that we could have been referring people to that would have made sense for that to happen, especially if they're, on the private pay or the Medicaid or on the CHIP program. And, the CMHCs, they do have to take everybody who walks in the doors, regardless of the pay, but some of these other groups don't. So it's going to be a balance which we're taking. Senator Allen.
Thank you, Madam Chair. If I was reading a little bit of what you said there, and that is duplication services. We have different groups that do the same thing that maybe they need to expand, or maybe they need to contract and only concentrate on those that can do best. So, and then identify, and like you said, a list of where this service is available, and they go to the expert in the field. Not everybody's an expert in that field.
Well, the thing surrounding mental health is that it's not always just dealing with the mental health disease itself. You also have the substance abuse, and then you may have, some stresses that are causing the mental health of, being able to find a job, get the skills to be able to find a job. I mean, it follows the whole gamut. So that's one of the things that makes having case management a large part, I think, of whatever we do in this, so that if an individual's on several different tracks, those tracks are being kept track of, and we know that they're participating in this and this and this and this to improve it. Because no matter what we do to try to help an individual until they're ready to be helped, we can't help them. And there's going to be sad times where we have to say, okay, we're done until you're ready, but we're here.
Madam Chairman, Representative Bishop again, along with the value of looking at possible duplication that a truly collaborative process brings about, is the illumination of where the true gaps are. And I believe one of those very likely is where housing is concerned and the issue of homelessness. That when you start to collaborate, you widen your circle, and the circle needs to be widened to the housing programs and those entities in the community and in the state that could possibly be helping with that need.
Representative Lynn.
Thank you, Madam Chair. I'm curious to know, I know in Johnson County, we were looking at starting a family justice center, and I'm wondering if those are some things that we might see throughout the state, where granted most of that is criminal justice, but it also brings together, mental health workers, social services, child welfare, and I'm wondering if we can collaborate with the criminal justice to bring these together to make it kind of like a one-stop shop.
Right, we also have, I believe, Denise Sisman has a comment. Denise?
Yeah, so thank you. I think this was a little bit related to the earlier part of the discussion, but what I really love is the idea about bringing the various community partners together wherever individuals with mental health illness or concerns go to either seek treatment or assistance, that those partners are then brought to the table to identify what services they have to offer, how can there be collaboration, where some of the gaps are, and what additional partners need to be brought into that discussion. And that is going to vary as what was said by community and community. So it's going to be very unique based on the particular community needs as well as the services.
Thank you, Representative Ballard.
Thank you, Madam Chair. Denise just said a few things that I was going to say, but I would like to comment on whenever we talk about duplication of services. One of the things when I was a doctoral student and I was doing my interns, I found out that sometimes what we think are duplication of services are not, because people go to places that they feel most comfortable. And there could be 3 places there, and you say, gee, that's a duplication of service, but they'll gravitate towards one because they feel comfortable. That's where they go. That's where they'll continue to go, and that's where they feel comfortable. You could say, well, no, but why don't you go to that one and we'll eliminate one of them? Well, maybe the one you're eliminating are the ones that was helping them the most. So I don't think it's always a duplication of services. It's that when you collaborate, sometimes you lose a little bit of your identity because you're trying to make sure that everybody's getting a little here, a little there, and a little there. So sometimes you have to look at it and say, who is my target population, or who comes here the most, and am I providing those services that keep them coming, and we're providing that service. So I think it's a delicate matter. I think people like to help each other and do it, but they want to make sure that maybe if they have a particular area that's working, that they don't have to give that up because of the services. And I don't know if that's really clear, but that became clear to me, that people don't go where you want them to go. They go where they feel most comfortable, and that they think that person or those people are helping them the most. Though those other ones may have excellent services, they have to choose. And as you heard Madam Chair say a few minutes ago, that they have to want to go there. You can't make them accept these services. So I just want to put that out there, that it may seem like it's a duplicative service, but they may be serving people that otherwise would not receive service.
Madam Chair,
Yes.
Senator Petty, I have to agree with what Denise and Representative Bishop mentioned about collaboration, also about housing. I mean, at Wyandotte Center, that's one of the things they've done is involved housing. But I'm just curious as to, did I just miss, or I didn't ever hear any mention of our health departments. And it seems that often our health departments are also a partner in when it comes with mental health, and possibly not providing this so much service as being a first stop. So could anybody answer that question about whether the health departments were ever mentioned in this community engagement?
Tina, do you have an answer, or the chair of that working group?
Yeah, this is Greg with Fort County Mental Health Center. County health departments weren't discussed. Not sure what everybody's experience has been in our small communities. Our interaction with the county health departments is they will help us with, say, getting some injectable medications for somebody if we don't have an injection nurse in the community that patient resides at the time they need that injection. But as a front door for services, we see our primary care clinics and the federally qualified health centers as being probably a far more robust referral source in terms of that first contact with someone from the community. But that's not to say that county health departments shouldn't have a greater role there. It just hadn't come up in our conversation.
Senator Petty?
Well, thank you. I just think that certainly they should be, and they are, they are a resource that are being funded at the local level. And even when it comes to the medication that was mentioned, they are playing a role. So I think that part of what as we're looking at this question of mental health modernization and reform, it is important to consider all of those local partners. And I really do think that the health department should be included in that thought.
Further comments?
Madam Chair?
Yes.
Deb Stidham, Kansas Association of Addiction Professionals. I think some of my comments just have to do with the fact that I actually live and work in Johnson County. And I didn't really grow up there. I'm kind of a newcomer to that area, and I'm continually struck by how much I don't know of the resources that exist. And in Johnson County, and I'm sure in other places, there's a plethora of support services even provided by one of the local churches that is quite large. I mean, I could not even possibly list for you all the ways that they help support folks in recovery or, struggling with mental illness and a whole host of things that people struggle with. I just happen to know about that church. I just happen to have stumbled onto that. And I think what happens, and this is people of all income levels, when they're in crisis, they just call somebody or they just present somewhere. And I remember, 20 years ago, the federal government issued a whole kind of new way of thinking, and they called it no wrong door. And I think that's really what I hear us talking about. And the other theme, at least in my work group, which we haven't gotten to yet, is around access. So how do people know how to access even, like, for example, these local support groups, church, if there's no one, who do you call? So if I'm in crisis, I may call someone from the mental health center, or I might just present at the ER, or I might go to my school counselor, or I might walk into the health department and I might tell somebody, hey, I'm really struggling with XYZ. How does that person at the health department know who to call? Well, they know who they know. I know who I know. And people have to end up calling 10, 12, 15 people. And sometimes they're way involved in the law enforcement system or some other system that's much more costly. And maybe we could have prevented some of that from the beginning if we would have known who to send them to. So I do think that takes some concerted effort because, my shop can't figure out who all those resources are. So I think if we can figure out a way, and that I heard treatment navigator, I don't know what you call them. I don't know how many we need, but some entity that's responsible for figuring that out. And that's who they call. So that I say, hey, if mental health center can't deal with it, call this number. They will help you.
I think that, you've explained it probably better than some of us have speaking earlier. That's exactly what we're talking about. Because you do have a lot of little small organizations. I know, some people don't even think about, necessarily calling Catholic Charities for, mental health services, or even we have providers with our family therapy counselorist program out at Friends University in our area. And people don't think of, about calling them. So that's kind of where we're getting at, is how do we find out who all these providers are of the services that would be pertinent to this, so that we would have that information in one location to share with individuals as they call
them. Madam Chair, this is Andy Brown with ks.
Mm-hmm.
And I do want to point out that we do have, in terms of modernization, an opportunity coming up to the state where we will be able to have the 988 number available for mental health crisis issues. That 988 number can be potentially a statewide one dial, get connected to resources in your community type number. It also allows for people to receive direct crisis counseling services at the time of their call. But we do need to, if we're going to move in that direction as a state, to have that single 988 number be more than just a counseling number. We're going to need resources to do that. And I feel like there's a strong opportunity for us to link that into our after hours calls that we do with the CMHCs and a number of other things as well, so that there's really sort of one number that the state can fulfill its role in community engagement by doing public health awareness campaigns around that number.
So Andy, are you saying that each individual state is probably going to have to set up some sort of a system to tie into the 988? And that is probably a priority that we need to make for next year to look at and how we do that?
Yeah, I feel like it would be important to get legislation introduced this year so that if we're able to pass it, there would at least be a year for us to accumulate some funds for that purpose. It's supposed to go live July 16th in 2022. So if we were able to start accumulating funds in 2021, we'd have some funds to use for that purpose.
Okay, it would probably be good. I don't know whether, Andy, we start with your department, or if we've got some folks within our working groups that have the experience in this, but it's, definitely a piece that needs to be resolved as we go into our report in November and December.
Yeah, we'll certainly be working on that. I'm working right now to try to identify some consultants that can help us with model legislation for it.
Because that would definitely be, because a person can call in, I perceive this as they call in there and then the decision has to be made. Is this a crisis situation where we have to find the people that can send a team out to this home? Or, is the person able to actually go to a location and who's the right people to call? So and then those that they could wait until tomorrow, but we just got to make sure we follow up on them. So, yep, something that wasn't on my list. So I'm glad that you brought that up.
Yeah. And then I would also add that one of the roles that I think the state can play with community engagement is really around just offering technical assistance to local communities. So to city and county government. That's a role that I feel like is something that we've been building KDADs, and we also are working in partnership with KDHE in a lot of those regards. And I do feel like we are standing up a number of TA center type programs that will be able to support local communities, both with the justice involved individuals and also around things like suicide prevention.
All right. Sounds like that there's quite a bit of work to do to figure out what agencies need to be involved and then how we translate that down into our local units of government, into the counties and into the cities, and what that looks like as well. So this may also help us to expedite along with the conversation we're talking about, is we need to know who all these services are that we have available in our community. And it's not to eliminate someone providing services. We just need to know that they are providing them.
Yep.
Madam Chairman, this is Representative Elizabeth Bishop again, and I would just mention that the philanthropic community, of course, would be a main hub for a lot of this. Locally, for instance, there's the number 211 that you dial for the front door for social services of almost any sort. And I know that other communities have something similar. Sometimes it used to be posted frequently in the phone book of the different social service agencies, but usually there is a hub, a resource for accessing almost any sort of social service agency. I don't know that, I think the 988 number, when it goes active, will be much more focused on the mental health side of things and will be extra helpful in that regard.
Anyone else?
Madam Chair, this is Kyle Kessler.
Okay, Kyle, I'll recognize you, and then I'll have Reverend Ballard, and then I've got Senator Alley after that. So go ahead, Kyle.
Okay, I'll try and be quick. I was just going to make a couple points. One, going back to what Representative Carpenter said earlier, I thought it was really important, and several others have alluded to it in terms of referrals at the community level and being able to follow up with people. I think that that's something that, whether it's 988 or it's now some of the other pieces relating to mobile crisis stabilization and referrals, we'll see more of that. And that's a really important thing that's been mentioned by several of the previous task forces. And along that line, even with community engagement, one of the things that we are taking more advantage of now, I think, than previously are the different boards. And that's not just community mental health center boards, but even the government affiliated CMHCs like ComCare in Johnson County, Crawford County, all have advisory boards. So those people bring things to them from the community, maybe either having served on the board of directors for Higher Ground or Wichita Children's Home, or in Johnson County, maybe it's TLC for Children or KBC. So those are the kind of connections I think that are also very important when you look at trying to connect service arrays across the community. And one of the last things I was going to mention was that we are seeing, I think, more references nationally to interagency and agency, state agency communications. And that's actually, again, not to beat the Texas drum over and over, but that was one of the gaps that they had identified that their CCBHC lookalike model was trying to address, was different interagency communication barriers or gaps that had existed. So I appreciate this conversation a lot.
Representative Ballard, then Senator Allen.
Thank you, Madam Chair. I don't know if this is the proper place to do it, but it seems like I'll bring it up. I'd like to know what role or how do we link the police into this? Because it has been reported that if there's an emergency or someone is acting out or something, they call, say, the emergency service and police show up. Or they call the police to de-escalate something and then it's out of control. So how do we work the police into this so that they are getting the training that they need to handle mental health services? Because I don't know if they're been covering it, and it's sort of putting them in a very, it's a dangerous position for them. And if they're not prepared to handle a mental illness at that point, how do they handle that? And that's where I think things get out of control. So whatever we do, I think we have to think in terms of police will be more than likely to show up either because people call them directly or because someone has intercepted that phone call and they're there. So do they have the training that they need in order to deal with a mental illness and not just a police matter? And I don't know which one of our three groups are working on trying to maybe resolve that and give the police the help that they need in order to be able to effectively handle that situation.
Well, I think Representative Ballard, it's, some communities are attempting to do that. First of all, you're probably not going to, well, not probably, you're not going to turn law enforcement into social workers. That's just not going to be a peaceful thing. I can tell you the experience in our community where our Wichita Police Department has put together teams that do have social workers on them, so that if a law enforcement officer is called out to an event and it's determined at that time that they're dealing with a mental health situation, that they can bring this team in and then they can help to de-escalate it and bring it down, because it is, it is a major issue and they're just trying to figure out how to address it so they have those teams. So I just wanted, do we have, of the three groups, is there one group that's doing that, or will that be sort of like a final recommendation?
Madam Chairwoman, this is Rachel Marsh.
Okay, Rachel.
This is actually something that will be coming up in our next presentation from the policy and treatment group.
Okay, thank you. Well, then we'll further our discussion into that. Did you have a question you want to ask now or before Senator Alley? Okay, Senator McGinn. Okay, that's fine.
I don't know if there's somebody that's here or on Zoom, but a few years ago, there was a training program for police officers that had to do with recognizing whether the individual had a mental health issue or not. And I'd like to kind of know if that program grew and developed or went stagnant. And so it's more of when they walk into a situation, being able to identify whether it's mental health or whether there's some other kind of threat going on. And so again, and if there's no one that can answer that, I'd like to find out. I wish I could remember the name of the program, but it was a training program provided with officers. And it may be through the peace officers that have that program, but I just think that ties into what Representative Ballard shared. Thank you.
Madam Chair, this is Andy Brown with ks. And so I think the program that you might be referring to is the CIT program, or the Crisis Intervention Training Program. We are still running that program in partnership with the Kansas Law Enforcement Training Center. So we do provide funding for 3 sessions of that training each year. And then we also have recently developed a 8-hour law enforcement officer training on mental health issues that we are distributing to communities that have smaller police forces or sheriff's departments that may not have the staffing available to send to a week-long training. So we are working in that regard, but there are recommendations coming that will further support the expansion of that.
Senator Allen.
Thank you, Madam Chair. Representative Ballard brought up an issue a couple of discussions ago, and that was the people that have these mental health issues sometimes go to the place that's most comfortable for them to make that discussion. And I visited with a clinic in both Dodge City and Garden City, and I asked, do you have mental health in your, and I think it was a direct primary care clinic. He said, we are trained in identifying mental health issues. And we don't always have the expert, we're not always the expert in that deal. And that's what I'm talking about, a duplication of services. In that direct primary care clinic doesn't need to be a mental health clinic. They don't need it, but they can identify those services. And then if we can have a referral or was it 811 or 8988 number that they can call, says they gain their confidence of the person who has mental health, then they take that and say, we want to move you, we want to get you some help in this area. And they go that way. Same way with the police. If the police identify an area, they can then say, they're not the experts, they're not social service workers, but they can say, we can get you help in this area. And I think that's what we need to move towards. But the duplication of services doesn't mean that they have to do everything and be everything at the same time to every situation.
Yeah, and I think that's kind of the direction we're headed. I think in order for us to kind of get back on track with where we're at is I'm going to turn it back over to Hannah so that she can continue with the work groups because I believe that they were allowed at an hour.
Thank you so much, Chair. I will turn to Rachel Marsh now to present for the Policy and Treatment Work Group, and she is going to first present on the topic of treatment and recovery, and after that discussion, she will present on special populations.
Thank you. Yeah, the treatment and recovery conversation we had on October 13th, and then that carried over to October 23rd. I've tried to take the document that you have in your packets and group it by the scoring that we didn't get into the narrative that you see in front of you, kind of by how the impact would be based on our discussion. So actually the very first one is at the end of your list, and we thought the highest impact recommendation that we could make would be to explore options to expand the behavioral health service array available to individuals across the state, such as CanCare enrollees, those with private insurance, and the uninsured. What we're finding in all the discussions that we're having is a consistent theme of the need for the services to be, as we discussed in the very first committee hearing here, accessible and available and targeted to the populations that are most in need in Kansas. So this, I think, service array recommendation took a number of different recommendations from the different groups and really unified it into the one, saying we just really need to make sure that we have the appropriate service array in the state. And if we did, that would have the highest impact that we could make. The next highest impact that we talked about was continuing ongoing work to improve care delivery and expand capacity at PRTFs, such as through reductions in the PRTF waitlist and incentivizing reductions in readmissions. We thought that that would not only be have a high impact, we scored at that as an 8, but that it wouldn't be too terribly difficult if we just continue the work that we're doing, particularly around some of the special populations that we'll be talking about in the next category. And also the conversations we're hearing this morning about the crossover youth and other specialized populations.
Rachel,
yes.
Your paper dated the 13th or the 23rd, or you're combining them in something you're looking at?
I'm sorry, I combined it in something I'm looking at because I didn't want to read you a list.
Okay. Well, I wasn't following, so I was like, okay, I need to figure out where we're at. All right.
Yeah, I went back and added the scoring, and then put it in a different order based on the higher scores that we came up with. So the next category is going to be more clear on that list. That has to do with all of the issues relating to housing. From that October 13th document, the housing and supported employment, I put in one category because it has to do with these economic issues facing the population of people facing mental health challenges. So those grouped together, I noticed the theme that there was a high impact around all of the housing recommendations. We had 3 or 4 of those scored as an 8. However, not all of them were seen as easy to implement. And so the ease of implementation score was a little lower, around 4 and 5. But there was kind of a theme of supporting housing initiatives and continuing to expand those. The next couple categories, I'm scrolling down here, have to do with expanding medication assisted treatment. There were a number of recommendations from the different groups that for the matrix that KHI presented that had to do with medication assisted treatment, both broadly and narrowly. We pulled those together and are looking at the high impact of expanding access and utilization of medication assisted treatment, which includes increasing access in jail settings, expanding it in block grant services, and expanding it for pregnant women. We thought that would have an impact of 8, although it might not be as easy with a score of 5. And the last 2 conversations that we had that we thought would be highly impactful, one was around that capacity of the frontline healthcare providers to identify and provide services to those with behavioral health needs, which I think reflects the conversation we were just having about the need for a point of contact and awareness among our providers to recognize and then refer when that's necessary. That was potentially, again, a 5 as ease of impact and an 8 or ease of implementation, I'm sorry, and an 8 for implementation impact. I'm sorry, they're both I words. And the final one we talked about was conversations with the IDD population, that we need to invest in community-based intellectual and developmental disability services and training around behavioral health. And that was scored as a 5 for ease of implementation and a 6 for possible impact. So that's really the high level. If I didn't discuss it, it was because it was removed or it was modified. What we noticed, and I think other committees are seeing this, is there's these themes that came up around the different recommendations. And so we've become more comfortable with updating those recommendations to really look at that modernization approach as opposed to sticking with the original recommendation as written. So I will absolutely need the support of the committee to answer questions around this, the subject matter expertise that will be required to answer questions related to the specific recommendations of our committee.
Questions, comments, Rachel? You must have done an excellent job.
Thank you.
I think, Rachel, it was a little bit hard for us to kind of follow. If you could take the sheet that you were working off of and get that to our staff, I think that would be good for us.
Sure, I can absolutely do that.
It's back to you.
Thank you, Chair, and thank you, Rachel, for setting that up. So now we're going to think through visioning and our goals and our long-term successes around treatment and recovery. Some things that came in mind and that were discussed in the work group were continuum of care. Again, that cross collaboration, things that are data-driven and adaptive. And I'm going to invite Kelsey to Kelsey Torres, are you on? Just kickstart our discussion.
Hi, Hannah. Yes, I am here. So I had just a couple comments that I was asked to share. So this really kind of goes off of our conversation that we've been having around like accessibility of the system or to access the system. So we want to make sure that there's a really easy to understand way to go about finding treatment services across the entire continuum. Often like families get lost along the process of applying for this or waiting for a determination for a waiver service, like the role of an MCO, like it becomes very confusing. So the more that it's streamlined and the more single point of access that there is for a family, the easier it becomes to navigate. So that was kind of one point. Another is around like crisis services. So our work group talked a lot about expanding service array. And we also had a recommendation that we pulled out directly from that about expanding the crisis services array specifically. So part of that is kind of changing the philosophy in which we are able to provide crisis intervention services. We all know that the earlier we can intervene, like the less likely it becomes to reach like a full crisis situation. And family members or individuals know themselves best. So whenever they indicate that they are in crisis, intervention services should be made available, regardless if it's like they're not at risk of hurting themselves or others, like at that certain point in time. And then like, as everyone has said, like that cross-sector collaboration and really making sure that we define scopes of care, scopes of practice within the different settings. I think that would be helpful to improve that seamless system of care.
Thank you, Kelsey. Madam Chair or members of the committee or other work groups, comments to that?
I don't have any here in the room.
Madam Chair, it's Deb Stidham.
Okay.
I think one of the things that I think about, and maybe it's being discussed in other work groups and I'm just not part of those, is that, you know, I haven't heard a ton of comments about data. And when I think about just going back to, do we know what's available? Do we know what the gaps are? Do we even really understand the specifics around the populations that we're trying to address? And I know there's data out there. It's pockets of data. It's kind of like resources. Some people know where to get some data. Other people may have different access to different data. But I just think in terms of visioning, I would really hope that we would include that we would want a data-driven system so that we can really target the resources towards maybe the most acute gaps to begin with, because we do have resources out there, but I think it's a shame when we don't even know what's available and then we don't have a good way to measure exactly the most critical services that are needed in certain areas.
Well, that's a very valid point, and it's one of the things I think we discussed a little bit in our very first meeting is how this needs to be, definitely has to be data driven in order for us to actually see what the outcomes are. And there is data that is collected. It's not always put into a usable format. And so we need to get it into a usable format, because people would be amazed at the amount of data that's collected by some of our agencies here in Topeka, but it's just not in a usable format for us. So I think that's a very good point, and that has to be a priority in what we do, because we've already tried the way of saying, okay, here's what we're saying the outcomes are, but nobody can take and prove that. And I know everyone gets tired of hearing this, but that's where we go back to the K-12 mental health pilot program, because it does show whether we're succeeding or we're not succeeding. And that's the kind of data that we have to have in order for us to take and go forward. And I think along, these lines that we've been talking about, it brought me back to the discussion we had on the 988 number where that number has to have the ability then to refer it. Let's say it's an individual call from Sedgwick County, because that's where I'm from, that they get it to whatever the designated organization is in Sedgwick County. And then you have to know, if it's 3 o'clock in the morning, we have a lot of organizations that say they offer crisis service 24/7, but that means a hotline. And sometimes that hotline person is not enough. They actually need a team that is available to take and go out. And so this goes back to knowing the proper services for the proper population at the right time. Back to you, Hannah.
Any other comments? Gary or Kelly, did you want to add to the discussion? Some of your thoughts on the vision? I think they were around service array and really treating that whole person, having the continuum of care. Is that something we want to think about in our modernized behavioral health system?
This is Kelly Hance-Reid, Director of Medicating Children's Mental Health at DCF. And I just want to echo kind of what Kelsey was saying about our crisis service array. But in addition to that, I think there are some opportunities to add additional services in our service array, such as partial hospitalization, day treatment programming, intensive outpatient services. In the service continuum, when we have those gaps, then we're forced to kind of skip over those and and people are forced to more intensive services that might take them away from their home or their community or their normal life. And it's just a shame that lack of services in the continuum would lead us to more intensive services that maybe aren't necessarily needed and are much more costly, and maybe not always the best thing for that person. And so I would just encourage, adding to our service array to really be able to provide people with the right service at the right time in the right place.
Any other comments on the vision? Otherwise, I'll go back to Rachel to provide the update on special populations.
I do have one question for you. Are we going to also hear from the capacity and transformation work group?
Yep, that's our last work group.
Okay.
Go ahead, Rachel.
Okay, thanks. So the last set of recommendations that the Policy and Treatment Working Group has discussed so far is the special populations. And we began that discussion on October 23rd. We did not complete the discussion. So what you have in front of you, Chairwoman, is a list of discussion topics that are still under consideration, and some of them are still being discussed using the Qualtrics survey method. What I've done in terms of just discussing it at a high level is grouped the populations together in basically by population. What we notice in that list that you have in front of you is that there are 2 specific topics: non-abuse and neglect, conversations related to differential response to newborns and referencing or referring them to evidence-based services, as well as education and intervention for neonatal abstinence syndrome, and making sure that we are providing the services needed for substance using women. So of course, we have a special population of pregnant women and newborns that we are discussing in the special populations group, and we'll be scoring more completely where that fits in our priority list for special populations. The next group of populations that we sort of can look at together, what it looks like to me, are women and families. We have the Women and Family Treatment Centers, increasing the number of designated women and family treatment centers and outpatient treatment programs across the state. We have access to effective practices and support for children and youth in natural settings, as has been discussed a couple of times already this morning. Parent peer support, increasing access for caregivers and families of youth in the behavioral health system, as well as making sure that we're identifying perinatal mood and anxiety disorders and providing care for women experiencing that. So women and families, again, with the newborn population is a predominant theme in our special population analysis. The next thing that you'll see kind of in grouping our themes together is the youth with high needs. We've already talked a lot about the PRTF population, and we are exploring how to describe the right recommendation related to the crossover youth population. It may or may not be a very specific need for a specific type of report, but it is a population that our committee wants to continue to look at and explore. The next thing you'll see is that we've merged the special population of rural communities as well as crisis services into one broader category. We see both rural issues needing to be continued to lifted up, but also crisis services as being much broader than the original recommendation, which was focused on only crisis services in the rural communities. So we would be scoring that, or actually we have scored the crisis services as an impact of 9. We think that would have one of the most high impacts that we could have in our conversation so far, although we recognize that it might not be as easy to implement. So looking at that right now with a score of 4. So that is when we did score as a priority, because we all agree that the crisis services are necessary. Linking to the conversation we had earlier is a first responder training recommendation. And it's currently in its form, it's expanding the 3-day crisis intervention training across the state for police and first responders. And this was focused on veterans. It is not one that we have discussed fully as a group yet, but we are scoring it on Qualtrics. And I can tell you that my response on Qualtrics is we need to be expanding that, not only for veterans, but for any persons in crisis in the state. So I think we will be seeing a recommendation from our group prioritizing how do we get at those issues raised by Representative Ballard early and others earlier. Finally, you'll see that IDD continues to be a special population that we're looking at, and we need to be lifting up and making sure the services are available. So that is the summary of where we are right now. What our plan at this stage will be is to continue to score all of the things that we hadn't yet scored, and then prioritize among all of these different final recommendations to make sure that as between all of them, we've identified the most likely impact and the opportunity for the implementation having a great return on investment.
Thank you, Rachel. Any questions from the chair of the committee or other work group members?
I'm seeing none in the room at this time.
All right, then let's turn to that goal setting visioning again, and really looking at the special populations. I'd like to invite Kelly to talk about kind of some service rates around special populations, and also have the whole group thinking about, have we identified all of the special populations to consider? Are there others that we need to think about? What's the modernized lens? What are some successes we want to see around the specialized populations?
I think just some of my ideas around special populations, especially considering maybe the IDD population, is the service rate reimbursement that is currently provided for a variety of different services is sometimes insufficient to really comprehensively provide services, or to get enough providers in across the state to be able to provide those services in order to turn a profit. So I think, you know, we do have some really great programming across the state in areas, and that if we would just enhance different service rates, it might make it more feasible to serve, you know, a larger capacity of people or expand those programs statewide. Especially when we were talking about the IDD population, I think finding services or willing providers to provide those services is certainly a challenge for families due to the low reimbursement rates.
Thoughts or comments about that?
I would agree on the rates that, as you refer to out there, and I think that's one of the things that made it really hard with that $22 million cut that happened to the IDD population.
I know we've talked about wraparound services under other topic areas. Is that something that is being thought through with this group as well? Is that something you envision in a modernized system?
Madam Chair, this is Representative Elizabeth Bishop. I believe that the future of, well, certainly the Excellence in Mental Health Act and the programs that have followed on that do point us in the direction of wraparound services. And I'll just give one example. I don't know if it's part of his report, but I know that Sheriff Easter has talked about one individual who had serious mental health issues and who ended up being arrested so many times over a two or maybe 3 year period that it cost the community tens of thousands of dollars. I'm not going to say over 100,000, but it was high. And it appeared that the secret to resolving that was housing. And because of securing that individual, and it took some work, sufficient housing, then he was able to access the other services. It's really hard to access services if you're living under a bridge over the Arkansas River. And I would just point that out as one type of wraparound services that is a key to the rest.
Thank you. Any other comments?
You know, and I think one thing that we need to do as we move forward in this with all of our groups is to make sure that we provide a clear definition of what our terminology means. Because, again, give you a couple examples. If I talk about case management in mental health, case management in other areas is different. So I'd like to make sure that we define our terminology, again, you know, wraparound services. What that means to one person means something to other people. Because I know in the K-12 program, we do have true wraparound services, and those words have been thrown around for many years around here, but it has not fulfilled the obligation of what some people believed it was. So I would suggest with all of our working groups is that we clarify what we mean by, you know, whether it's wraparound, et cetera.
Madam Chair, this is Kyle Kessler.
Yes, Kyle.
You know, just to support that additionally, I know that between you and Senator McGinn, Representative Ballard, over the years have heard this conversation a lot on different committees that you've been on, and in some of the specific terminology between the IDD, case management, mental health case management. I think it's underscored in their recommendation in that working group relating to co-occurring disorders. And that's something that we're seeing a lot more. Us and Interhab, our association and Interhab have had more conversations. It was brought to my attention yesterday by one of our staff that Wichita State has a really good program that talks about the co-occurring disorders in those populations. And this, we talked earlier about how different community partners can sometimes point the finger at each other and not necessarily trying to remove their own responsibility, but to point out someone might be more responsible in their minds. And I think that we can sometimes do that in our fields as well. And that's something that we need to remove across the state also. And I think that by doing more training and more cross training, if you will, and talking about what you're saying, the specific differences between the case management, I think will be very, very helpful in the long run. Thank you.
Go back to you.
Thank you, Madam Chair, and I appreciate that clarity. We will definitely have more definitions around our context. And while we're thinking about definitions, can the work group speak more to, or maybe the roundtable as a whole, of who are those that are in the special population? When we think about it from a modernized lens, we've talked about IDD, we've talked about children and women, but what about those who are homeless, as we're talking more about housing programs? Are there other special populations that we need to define or think through as we put our framework together?
Well, can I say something here? I think to a certain extent, when we talk about these different populations, we're really talking about different service providers. People, a lot of people have issues, but a lot of them have multiple issues. But I think what splits them up in the way they're looked at isn't their conditions, it's the way the service system is split into different parts. And so I think we need to look at it more from a thing, how do we get service providers to approach people in a broader sense than talking about, well, we have to see people differently. Anyway, that's just my short comment.
So Don, would that kind of be like, and I think it's kind of been a thing we've talked about here a little bit, is an individual comes in because of, let's say, a mental health crisis, but along the line, you find out that, part of it has to do with, perhaps they're needing to see a dentist, perhaps it's substance abuse, perhaps it's housing issues, perhaps it's financial issues, et cetera, so that the original place that they stepped into can help them go to those other services. Is that what you're talking about?
Yeah, I think that's a good way of putting it, because a lot of times, well, homelessness is a good example. There's usually a reason, and often it's more than simply being poor. And so I think it's just looking at, or when you're assessing a person and what their needs are, look more broadly than simply what your professional, orientation is. But like you said, how successful you'll be might have to do with getting them a place to live, making sure they have adequate food or heating in their house. Then you can then they can deal with their mental health issues or substance abuse use issues.
You've been around this system in a lot of different capacities. And, I know that one of the things that's been very, very important in the K-12 pilot is case management to deal with exactly what I think you're talking about here. How would you see the state to be able to, put into play a case management type system so that there would be someone that's monitoring this individual so that we make sure they're getting those other services besides just the mental health? If you're only getting 1 out of 5 needs, then you've got a problem. You're not solving the individual's issues.
I guess, and this may talk about going to universities and talk about training there. state agency expectations when they talk about funding and licensing and things like that. But I really think it's a matter of across the board, whether it's clinicians or case managers, to get them to work to have that sort of broader orientation. And that, you know, I don't know if it really helped that much to just bring in a special class of people who's going to deal with it. I think it really is coming up with some ways to expand and broaden the perspective across the whole system.
Thank you.
Madam Chairman, this is Sandra Berger.
Yes, go ahead, Sandra.
I agree with what Don's saying. I think there needs to be that expansion of awareness of other entities that are working with population. We also need to help the individual navigate through those systems. And so I think that's where we see the benefit of whatever you want to call it, wraparound or case management, whatever we're going to put it as, but they need help navigating those systems.
Una, back to you.
Thank you. The last special population I'll bring up that the work group has talked about is those that live in rural areas. Do we consider that almost a special population entity in this state?
Yeah, just want to make sure. Sandra, I'm going to come right back to you because I got distracted on something you made, because you made a really good comment when you was talking about, being in agreement, whether it's wraparound or it's case management, and then you tied something else, I thought, into that.
Well, even when we train our service providers or our community providers to understand the different needs of a population. So if the individuals working with mental health and IDD and education, they can all be educated on what each other does and where they can meet the needs of that individual. But we also have to help that individual navigate through all of that. I had a kid that was on an IEP. If I didn't understand the IEP process and I didn't have someone advocating and help me through that, it can be difficult. And then you layer in behavioral health and the complex system that it is. And then if they're in justice involved, I mean, those are very complex systems that an individual needs assistance getting through. And I think however we define the wraparound or case management, those people that are helping the consumers are the ones that are critical to their success in getting to what they need.
Thank you. It was navigate through the system. That was the key line that I didn't get written down in my notes, so I appreciate that. I think Senator McGinn has a comment or question.
I just have a question on the question before this one. On the rural communities being a special entity or population, I just wanted to hear if that was a question or a comment statement, and if so, would you define the rural communities?
This is Hina from KHI. This was something that had come up in the work groups as they're going through the different recommendations. So it's both a question and a comment of, do we think about, I think Dawn and Sandra have both talked about how we need to think through the provider side and navigating through, but do we need to think about the lens of how this plays out in rural communities? And is there a different service array or a delivery mode that needs to be thought through there?
Senator, again, go ahead.
Thank you. So the reason I asked that question is, so I'm a rural community, but I'm within 25-minute drive of services. And so I think about some of those very remote areas that do not have large cities, such as a city the size of 5 to 10,000 to access any of those services. So that's why I just kind of wanted to tighten that down just a little bit, because again, if you live close to one of those communities, it's possible. I mean, some of those that are 5 to 10,000 may not have those services, but I just think as we move forward, we should kind of keep that in mind. Thank you.
So you're kind of
Madam Chairman.
Real population, sorry, go ahead.
Madam Chairman, this is Representative Elizabeth Bishop, and I believe that this issue relates both to transportation and telehealth. I know that we have a special group that will be looking at the issue of telehealth coming up, and I intend to sit in on that because I have a lot to learn about it. I know that this will especially become extremely salient as we get closer to the 988 crisis line and how that will operate in rural areas. I do believe that rural areas constitute a special population, but what we're talking about here is looking at special populations without creating a silo and being able to look across delivery systems, across social services that are available, and meet the mental health needs and the supportive needs that an individual might have.
Thank you, Representative Bishop. I think I'd also like to just add, as they work through that, is a rural community, or rural, I'm going to say rural and very remote, could suffer from isolation just as a person in an inner city that doesn't have transportation. So I think we should think about, as we have that conversation, those individuals that could be in isolation and how do you help them? But appreciate the comment on telehealth. Thank you.
Madam Chair.
Yes.
Kathy Bush, State Board of Education. You know, when we talk about rural communities, one of the things we might want to do is take a look at how the mental health pilot for the schools has dealt with that, because they've done some cooperatives. Quite a few of the more rural areas had been pretty successful with some cooperative groups that were able to provide services to groups of folks that are pretty spread out, but they could still provide some services. So that's it's been pretty successful. So we might keep that in mind for future for this bigger piece.
Well, that would be a good path to go down, because then we wouldn't be reinventing the wheel. We can just modify the wheel, because that's taken us 3 years to build that wheel. Thank you. Representative Carpenter and then Senator Allen.
Thank you, Madam Chair. Seems to me like we have a common thread here about with the 988 and knowing how to access services, and Dawn's come on board with that. Yeah, I think it's unrealistic that everybody needs to be retrained to do that. I think it's a little easier just to get them in contact with that person. But maybe it seems like we might be talking about, and it's kind of case management or something like that, but somebody that's in charge of making sure that this happens, whether it's housing, whether it's food insecurities, and that would be the original contact person or something like that, which would require some more training. But it seems to me like it's unrealistic that everyone would have access to all those services. So, but I understand the need to have someone to make sure that whatever the process was that those folks needed is implemented and checked up on, and make sure that they've been able to access those programs, such as Food for Thought.
Senator Allen.
Thank you, Madam Chair. So I have a question on rural populations. Are they different, or are they just smaller population? Do they have the same problems? And do they have the same needs? So it's just, maybe it's not a special population, maybe it's a different delivery system to get to that, because I think the problems are the same. Like Senator McGinn said, isolationism, it's same in the rural population as it is in the urban population. But we have the same problems, just that maybe a different delivery system is needed.
Representative Ballard.
Thank you, Madam Chair. I'd like to comment on it. I think that's an interesting question. Are they different, or do they have similar, or delivery system that's different, that's needed? And I don't know if they really looked at it. We think of it as being small and maybe I'll say isolated, but because it's so small, everybody knows everybody. So you don't have, everybody knows your business, whether you want them to know it or not. But it might be interesting to see. They need a different delivery system, and I had not really thought about it that way. I think we should look at that.
Back to you, Karen.
Thank you. I think if there aren't any remaining comments, we could transition to the third working group, but I wanted to pause just to make sure. All right, then our last working group is the System Capacity and Transformation Work Group. I'd like to invite Andrea Clark to provide the update. She'll start with the interaction with the legal system and law enforcement first.
Good morning, this is Andrea Clark. So to begin with, we discussed recommendations presented to us around benefits reinstatement and suspension or termination of Medicaid benefits. When a person becomes incarcerated, KDAD's provided some agency updates on collaborative effort currently ongoing with KDAD's and KDHE on expediting this process. And work group felt that we needed additional information on impact of these new process before we could make any further recommendation. We also received agency updates regarding training available to law enforcement officers in regards to mental health and crisis intervention and substance use. As discussed several times earlier in this meeting, we also, work group made the recommendation to expand the focus of those recommendations on including correctional employees as having a potential for high impact and easy implementation. Our work group also removed recommendations as presented to us regarding the child welfare system, specifically because we felt those were probably updates needed since those reports were released on the work that has been done, as well as that those are also potentially areas of better focus in other work groups than ours. We also removed a recommendation regarding focus on high acuity behavioral health releases from KDOC and local jails. We removed this not because we felt that this wasn't important or a belief in this recommendation, but that it is likely duplicative of other recommendations, specifically around treatment and also around the need for shared definitions within the system and recommendations to be data driven. So we spent significant time talking about barriers around this topic. One, payment barriers, like mentioned, the suspension or termination of benefits for those that become justice involved, but also just larger conversation around that need for access to treatment for justice involved individuals. And potential recommendations would include expansion of specialty courts and other diversion programs. And we requested updated information on potential recommendations made by groups like the Criminal Justice Reform Commission and several others that are working on diversion in court issues. Another topic that came up that has been mentioned several times today that we discussed was the need for housing support, specifically for those with high acuity needs and justice involvement, and that becomes a particularly high barrier to housing for people. certain recommendations we discussed were housing bridge pilot programs that we've engaged in before, and the need to expand supportive housing programs. Finally, we also discussed as a barrier the burden placed on local jails and communities by extended waits to Larned for competency evaluation and restoration services, and the need to explore that as a potential area of focus. So, thank you.
Thank you, Andrea. Madam Chair, members of the committee or other work groups, any questions or comments on that?
I have none here.
All right, then we can move towards, again, that goals and visioning exercise around law enforcement. I mean, we have talked about a little bit of it around training for law enforcement officers to be more aware of mental health issues. I think courts are another group to think about, to be made aware of behavioral health issues, to really have more informed decision making. I'd like to invite, I don't know if Spence is on. As I'm seeing, Spence, are you there? Would you like to share some
Yes.
of your thoughts?
I can, and I think a lot of what I had envisioned or thought about initially on this has already been mentioned by other groups. Specifically, it's starting with police and sheriff's officers needing training for mental health issues, and I think Andy actually answered that there is training that is done for that, which was something, again, and that we've all talked about, not knowing what's going on. And I think that was one thing I learned. But then looking bigger, and just mention, looking at specialty courts, I know the Criminal Justice Reform Commission has before it a bill to help expand specialty courts. So I think that would be an important legislative process if it makes it that far, if this group could also support that. But, we think about law enforcement, it is just more, and I speak from my own personal experience as a probation officer, that, as probation, we're an important part of the criminal justice system, and more these days deal with mental health issues. And it seems more prevalent now than it did 25 years ago when I started. But, having training available for supervision officers, community corrections, or court services throughout the state, as well as DOC. I think that, having those trainings available would be helpful. And then again, like I said, the specialty courts and how does that referral process work? There's specialty courts currently in Douglas County and in Wyandotte County, and if law enforcement has good training with that and can in reports make aware to the county or district attorneys that mental health might be an issue, to make sure that information is passed on to the court system, so that if there are specialty courts, they can be addressed with that, or once it gets to probation, how do we help these individuals so that they don't recidivate in the future. So those were kind of my thoughts on the law enforcement issues.
I'd like to ask you a couple of questions, because you brought up things I hadn't thought about, and that was with the probation and the supervision officers. Do they have to operate under, okay, the court said you would have to do this, 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 and this in order to be on probation or supervised probation? Or can they say, oh, wait a minute, as you work with this individual, you realize that they need some other assistance? Are you able to make those referrals? How does that work?
Yeah, so if the courts know, specifically, I can speak, I can speak for both misdemeanor and felony, but for felony, at the pre-sentence investigation, court services does an assessment on the individual, and a lot of times through those assessments, we gather that information and can make recommendations to the court. So if it's apparent at that point that there are issues that could be addressed, then those recommendations are usually made, and the judge can order those as a condition of probation. But officers certainly usually have that discretion once an issue is addressed to say, hey, I'd like to get to see you go to mental health and get an assessment or see if we can deal with this more. So there is some discretion with that.
And I guess my other question is, and I don't know if it's for you or someone else, is there a standardized format out there for setting up specialty courts in the state?
I don't believe right now that there's a formalized process. I know part of the legislation through the Criminal Justice Reform Commission is setting up funding and helping courts to be able to set up their own specialty courts. And I would be happy to see if I could provide that to this committee if I can get a hold of that bill.
I think that would be good. Thank you. I have no further comments here in the committee room.
Are there any other comments from other work groups or other members? Otherwise, I'll invite Andrea to come back and discuss system transformation.
So this is Andrea Clark again. The main theme of our conversation within the work group around the topic of system transformation was the focus of the integration of behavioral health and primary care. We combined several recommendations as presented to us to really increase integration and care transition, best practices among mental health, substance abuse, primary care, and emergency departments across the state. We also discussed recommendations and combined recommendations to increase the utilization of SBIRT, which is screening, brief intervention, and referral to treatment, which is an evidence-based practice that is billable under the CanCare system, but not very highly utilized. So recommendations on efforts that would expand that practice within for our CanCare members, but also looking at ways that we can expand the utilization of SBIRT in other areas, such as in education and our schools, ways to support SBIRT in local health departments and clinics, and with behavioral health providers in general. We also discussed and recommended the support of evidence-based practices within the behavioral health system, specifically continuing to support the use of EBPs and the goal of working towards fidelity and really consistency with those practices. And these would really incorporate things we've talked about in this committee up to this point, in topics in areas like supported housing, and using evidence-based practices in supported employment and other programs we have currently ongoing. Our work group reviewed recommendations around the impact and potential modification of opt-in consent legislation on youth, public, and behavioral health surveys. We discussed needing additional information on that topic before being able to recommend a specific recommendation. We also reviewed recommendations on statewide needs assessment of substance use disorder treatment services in the state and the interoperability of new state hospital EHRs with other state data systems, which really falls in line with the need to be more data-driven and focused and decision-making, as well as the need for that interoperability increases efficiency amongst our systems, as well as being able to provide information. Again, when looking at this topic, we tabled discussions around the child welfare system that they were, those recommendations as presented likely needed to be updated and were being reviewed within other work groups and committees. Several barriers came up when we discussed systems transformation. One, in our system, the lack of capacity, specifically for crisis, adult inpatient, and long-term care. We also spent time discussing the barrier created and waitlist created by the inability to discharge or release into appropriate lower level or community-based services, and how that creates kind of a chain reaction effect that by creating an ability to discharge into services creates waitlists on the other end as well. For example, being able to move from the ER into an inpatient setting, into long-term care, and then into community-based services, and that the system as is really creates bottlenecks at each of those points along the way. We also discussed access to treatment and services with for individuals with criminal justice involvement or history of sexual violence, and how those often create barrier into the behavioral health system for people. We discussed transportation costs, and also finally how current Medicaid payment structure really only allows for parent support when the child is a primary client, and that how systems transformation would look like if we really supported families throughout the whole system and continuum of care. Thank you.
And I believe that we have a question from Senator Alley.
Thank you, Madam Chair. One question, and I see this brought up in many committees, and that is supportive housing and affordable housing. Can anybody define success in affordable housing? What does that really mean?
Got someone out there that can answer that question?
This is Andrea Clark with KDADS. I would suggest when considering that question that you really kind of separate out affordable housing and supported housing as two different buckets. And, you know, I can speak to, in terms of supported housing, that success really looks like maintaining community tenure, you know, keeping people in their homes instead of losing them due to incarceration or hospitalization or need for higher levels of care.
And Madam Chair, this is Kyle Kessler.
Okay.
And so I would absolutely agree with what Andrea just said, and just add to that as an example, as it relates to supportive housing, state of Missouri did something. In fact, one of our mental health centers was doing some work in the Wyandotte County area, was doing work on the other side of the state line, and talked about how successful this program was in terms of reducing the amount of state hospital utilization and dependence on nursing facilities for mental health, and reduction in incarceration and connection to recovery. So it also gets people into the workforce, and so to be more self-sustaining. So that's the supported housing model that we refer to. I know that there's a lot of talk about affordable housing that's out there as well as kind of a social determinant of health for sure, but the supported housing model is something that's specific to behavioral health, if that helps.
So it kind of sounds like to me, and see if this follows along where you were going, Senator Alley, is that we need to have a breakdown and a definition that when we talk about housing, what housing are we talking about and how will we measure that? Would that be accurate, Senator Alley?
That is correct, because I see supported housing. Think of the homeless person that's living under the bridge. What do they need? What's the definition of affordable housing to them is a lot different than it is to affordable housing in a small community in Western Kansas. So, and also then in your urban areas where affordable housing may be something under 200,000. So we need to define what that is.
This is Lisa with Compass. Can I just interject one thing? I am from Western Kansas. And so when we talked about this in our group, we also talked about availability of housing. So sometimes it's not only affordability. We can have housing grant dollars, and there are absolutely zero rentals available in our rural communities.
Senator Alley?
that also needs to be added to that is, and then if you were going to get some people, how would you get the craftsmen to build those houses in your new community? So there's a problem all through this with affordable housing. You need a definition, you need to identify success, and then work towards getting that success.
Good point. Go ahead, Hannah.
That's a really good point and vision to think about of what success looks like for affordable housing. Other thoughts on system transformation as a whole? Kyle or Denise, do you have any comments on that from that work group?
This is Denise Sisman. I can go first. And I think that the work group really focused on the fact that there's when you look at mental health, there's a continuum of needs, and it can be anywhere from, looking at the prevention aspect as well as those who need some early intervention, all the way up to those who have some pretty severe and persistent mental illness and possibly needing inpatient services. So when we look at a modernized system, it's the opportunity to think about that system as a whole, and where do you have various service providers and types of services that can meet the need for the person at that time, and hopefully keep them from moving on up into the more severe and persistent parts of mental illness. And so we're looking at it really from the patient perspective of where are they at, what do they need, and then what services are available and how to get them into those services at that time. And with that, we have a system right now where we have a lot of different kinds of providers of mental health services and an opportunity to have better coordination amongst those. And, we talked earlier about then about the resources being readily accessible and people having the awareness of what those resources are in order to get that person plugged into the system at the appropriate point of the system.
Back to you, Hannah. Oh, wait a minute. I'm sorry. Representative Carpenter has a question.
Thank you, Madam Chair. As many acronyms as I deal with, I still don't know what SBIRT means. Is it SBIRT? Somebody had mentioned that. Oh, screening, brief intervention, and referral to treatment.
That's fine.
Well, that's one that's not on my 2 pages of acronyms that I use every day. So anyway, thank you very much.
Smart. Representative Ballard, I think that sometimes she has a tendency to read a lot more than some of us do, and the things that we haven't even seen yet. All right, back to you, Hannah.
Thank you, Kyle. Did you have any comments as well?
Nothing further. The only thing I would mention as it relates to data, we have had quite a few conversations about data, everything relating to what's captured in electronic health records to health information exchanges. And I would expect us taking another pass at that in the next meeting or two.
Thanks, Kyle. And that was one topic that we didn't have time to vision on. So if it's okay with the chair, could we think about visioning for data systems? I know we've talked a lot about real-time data and things that are multi-directional and that everyone can have access to, but it would be helpful if this roundtable thought about goals and what success would look like, maybe in the 1 to 2 year span, the 5-year span, and the 10-year span of what goals would look like for a data system.
I think you're right, and one thing I would emphasize on that, the simpler the better. You know, sometimes we look at data systems as having to be overly complicated. And when we have the right IT people at the table, they can usually come up with something that's a little bit more simplistic. We were able to actually discover that in the K-12 mental health pilot program, because we had allotted about $2.5 million for that program. And the Department of Education did it for $500,000, excuse me. A lot less than 5.
Madam Chair, this is Kathy Bush. When we start talking about data systems, I think we need to decide what do we want our outcomes to be. So look at first what data we want, and then you can decide how to collect it, because you can collect all sorts of data and it won't tell you anything. So we really need to look at outcomes and then decide how to collect data. My 2 cents.
Kathy, will you be, your group, because I know you're intimately involved in the program that you've been working on in mental health and with the education stuff. Have you guys come out with some things that would be pertinent to this discussion as we move forward?
Are you talking about the mental health pilot or the school mental health advisory?
No, what was it, about a $5 million grant, I think, that you received, and I think you were heading that up.
Yeah, that's in the department, and I think that's probably the one you're talking about. And it is a grant that they've received, and we look at that at the state board level periodically.
Okay, I thought there was some actual work being done on investigating into some things, and I'm trying to draw from about 3 years ago, I think, because that came about just about the same time that the K-12 pilot started, and some of the terminology we actually used from reports. So it might be something that we can get hold of Craig and see what he can provide on that.
Yeah, I think that's within Burt Moore's department that they're working on that. I think Carrie Haig's involved in that too, so I'm sure they'd have some outcomes.
All right, thank you.
Madam Chair?
Yes.
This is Denise Sisman, if I may. I think too, when we're looking at data and the discussion that the group had about data, it is the ability to look at outcomes, and that's also, that's incredibly important. In addition, I think it's the ability to access data between service providers so that we can assure that the individual is getting the appropriate treatment and that there is coordination between various types of services that they're receiving, and that there's awareness of, for example, what kind of medications the individual may have been prescribed by one service provider, and the other service provider becomes aware of that. So with that, and Kyle, tell me if I'm wrong, but we talked a lot about making sure that all service providers are using electronic health records, and that there's the ability then for those, the data from the electronic health records to go into a health information exchange like KHIN or LACI, so that data can be pulled in and out between providers, and they can really be looking at all of the services that that individual is receiving.
Yeah, and this is Kyle. I think Denise is spot on with that. And it's something that helps us do a lot of things in the future, like recognizing hotspots and how we can also reduce the number of emergency room visits and hospital inpatient admissions. And so that's something that has been thrown around, is the idea of providing some, and it kind of ties into telehealth as well, right? Because there are more people, providers that are not organizations the size of some of Denise's or mine, or even in the Association of Addiction Professionals. But if we could incentivize behavioral health organizations who have implemented electronic health records and are participating in health information exchanges, that would be a major data accomplishment for us in improving treatment and outcomes. And I think that hospitals are, I'm trying to remember what's called, it's a specific rule, maybe the final rule for 2021 Medicare and Medicaid conditions of participation is what's in my mind. But I think that they're required to track more information. And if organizations like ours who do more outpatient work could get access to some of the things relating to our patients going into hospitals or out, then we could prevent more of those hospitalizations going forward. I think I may have jumped right off the ledge that Denise was leading me to. I think we're on the same page though with that.
All right.
Madam Chairman, this is Sandra Bird with United. What I hear in the conversation is a couple of levels of data. We have member level data or individual level data, and then we have aggregated data. Like Kyle was saying, it helps us inform where our needs are and our gaps in services. So as we look at data as a whole, we need to look at it in those stratifications and not just data.
No, and you're exactly right, because that's the problem that we have with a lot of agencies that are collecting a lot of data, but it's not usable because no one's really quite figured out, okay, why did we need this and where does it need to be plugged in at? I believe we have a question from Lisa Sutherland.
I didn't have a question.
Okay. Back to you, Hannah.
No, I think that's, we brought up a lot of different themes of what data, what outcomes do we want to look at, and kind of the access of data, individual and aggregated, makes a lot of sense. If it's okay with the chair, could we take maybe 5 to 10 minutes to think about what data would you want to see? Do you want to know the number of individuals that were served, the time to get services, how many services were provided? Does that indicate continuum of care, or does that indicate something else, that they're getting too many or too little services? What are some outcomes that those around the table could think of right now of what you would want to see at the aggregate level from the data?
You know, Hannah, I think that might be something that we put that question out there to all of our members, and then have them submit that, whether it's to you or it's to our staff here. Then that way that gives them a little bit more time to kind of think, you know, what does that look like, and then explain to us why they feel it's important. Does that work, or?
Yeah, that sounds good.
In your system?
No, we can definitely work with KLRD to collect that information from the special committee and work group members. There's a parallel effort with some of the agencies as well to see what data is already being collected. And so then we could leverage kind of seeing what's already collected to what might be important for this committee to know just on an ongoing basis.
Yeah, so they can send that stuff to Marissa, since now David's leaving us for whatever reason. And Marissa will make sure it gets dispersed to you, and then also all of the other members, so that we can take and combine that, and then maybe we just start working from that list. And as we work from that list in a discussion, the full committee, then we might be able to narrow it down to what actually is measurable.
That sounds good. Any other comments on data system or transformation? Anything else with goal setting or visioning around both of those topics? I'm hearing nothing, Chair. I think that would conclude the work group update and visioning session.
So if my agenda is correct, then, we are prepared to break for lunch. And we did set aside 30 minutes. We may kind of shorten that just a little bit because we're going to have a working lunch. There are box lunches outside the door here for committee members here, and for staff that may be sitting in other rooms here in the building as well. So let's go ahead and let's break for about 15, 20 minutes, and we'll see how we go from there. Oh, and if you are interested in having coffee, instead of running around like a crazy person like I did this morning, Jan in the Democrat office has got fresh coffee up there in her office. So please go up there and help yourself. She's always really good about that. Thank you. So we're going to recess here for about 20 minutes.
There she is. Sorry. You're fine. No, you're fine. I'm sorry.
That's about it. Yes. Yeah, it was, I just couldn't resist.
Yes.
Right back in. Yeah, we're just gonna do a working lunch. You can set out somewhere else if you want to have your lunch. We're gonna be back here about 20 minutes. So we're not gonna be doing our meeting.
Oh, good, I got you. Okay. I'm hard of hearing this morning.
Oh.
Okay.
to talk
Yeah, there we go. Okay, we're going to go ahead and get started back. I was going to have Representative Ballard do it. She's not back yet. Would somebody like to move for approval of the August 27, 28, and October 5 minutes? Okay. Motion made by Senator McGinn, seconded by Representative Adam Smith. All those in favor signify by saying aye. Aye. Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. So Dave, do we want to do you first or the, okay. So we're going to get a historical overview of the Kansas mental health system, and David Fye is going to provide us with that. I assume that's the Lavender report you handed us? Thank you. Yes, the motion covered both minutes. Go ahead, Dave.
Thank you, Madam Chair. My name is David Fye with the Kansas Legislative Research Department. And yes, I'll be speaking concerning the purple or lavender or orchid colored paper in front of you. It's labeled A Brief History of the Kansas Mental Health System in Kansas. And Madam Chair, before I begin, I'd just like to clarify something you mentioned earlier. I would be departing from the Legislative Research Department, and that is true. My last day with the office will be November 6th, so it'll be this Friday. I was offered the director position for the Behavioral Sciences Regulatory Board, so I'm excited to move to that agency. I've been with legislative research for the last 8 years, and I've had a wonderful experience working with the office and working with all of you. But I'm excited about this new change, and so I'll be just down the road, but I'll be over here at the Capitol a few times in the spring. So.
We will miss you.
Thank you.
As he called me and shared it with me, I said, first of all, I'm mad at you. Second of all, congratulations, so.
Thank you, Madam Chair.
But you will be in my office a few times, just so you know, still chair.
Okay. The document concerning the brief history of mental health system in Kansas, we have some staff members from the Legislative Research Department here, and I just wanted to kind of touch base. You know, you may only see me or a couple of members of our office in some of these committees, especially given the circumstances this interim. But we have a great team working on these topics, and I just kind of want to recognize a few people from our office who've been assisting with the committee. You'll be working with a little bit more in the future. Marisa Bayless, she's here and she's been helping out with the committee. Also, Melissa Rennick in our office, she's been in the office for several years, and she'll be playing a bigger role with my departure. Megan Leopold and Matt Moore are fiscal analysts in our office, and they'll be covering a lot of the content in this memo. Also, we have a Zoom coordinator assisting with some of those responsibilities, Jessica Farmer, and Right Over is also providing support for the committee. So I just wanted to recognize a few people that you may not see visibly in the committee, but our staff is a great staff, and we work really hard to help things work smoothly for the committee. So with that being said, this brief history of the mental health system in Kansas, our staff provides a lot of different documents for the legislature and for the public. We go ahead and produce memos when individuals request information on a certain topic. Also, each year for the different legislative sessions, we prepare a document we call the briefing book, which has a number of different topics for the legislature, topics that may be of interest because of recent legislation or topics in the news. Each year, we also analyze every agency budget, and we go through some of the historic expenditures, some of the history of those agencies, and we put that together in a publication, and we explain what the agency requests for budget information and the governor's recommendations, and we track the legislative adjustments and help with that process. But because of this role that we play in the documents we produce, the analysts on our office are exposed to a great deal of information on different topics, and we wanted to share some of that with you. Megan and Matt have been working on a document that we are preparing for the beginning of the 2021 legislative session. It will be a larger document and have more detail, but we wanted to try to summarize and provide for the information some background on the Kansas mental health system and some of the different aspects of that system. As many of you are familiar with, that system provides lots of different types of services to lots of different types of populations. And so we wanted to sort of give you a preview of the larger document and walk through a little bit of this information as it could be beneficial in your work for the special committee. We're also letting you know that when the legislative session comes out, this document will be sort of a working document that will be larger with more context and more detail. So that with that being said, I will go ahead and defer to Megan Leopold, and she's going to highlight some of the different topics in the memo. And then when she gets done presenting, Matt Moore will also cover some additional topics in terms of the Kansas mental health system. And then we can stand for any questions from the committee, or if there's additional information that you think would be valuable to include in a document such as this, please feel free to let us know. We'd be happy to add that to the document as it grows as a great product for the 2021 legislative session.
Welcome to the committee.
Thank you. Thank you. Like Dave said, I'm Megan Leopold with Legislative Research. This is a rather lengthy document, and I know you have a lot of speakers lined up to hear after us, so rather than go through it in detail, we're just going to highlight some of the parts of it that you can go back and read whatever is of interest to you. You'll see that the memo is generally organized in a chronological manner. And at the very end, on the last 2 pages, there's a timeline that highlights the dates that we have gone in more depth to describe in the memo. The memo begins with a brief description of the events that really signaled that systemic shift that the mental health system has gone through from depending more on institutionalization of individuals to more community-based care. And on page 2, you'll find some information that's regarding the Mental Health Reform Act of 1990. This was some legislation that made a significant shift in the way that state hospitals and the community mental health centers were and continue to be utilized within the mental health system. Among other things, the act required that individuals receive care in the least restrictive environment. It placed community mental health centers as the entry port for admissions into state facilities. And it also did made some changes with funding that ensured that the funds follow the individual from state facilities to community-based services so that those funds are shifting with the more systemic shift. The enactment of this legislation led to changes in the state hospital capacity and then eventually some closures. And these are outlined on page 4 and 5. As the use of community-based services increased, an elimination of beds at the state hospitals followed. And this occurred even beyond what was required by the legislation in the Mental Health Reform Act. This ultimately led to the closure of the Topeka State Hospital, which closed in 1997, and then the closure of Winfield State Hospital, which closed in 1998. On the next page, you'll see some information about the closure of Rainbow Mental Health Facility. This is on page 5. After facing some challenges with staffing and safety code violations and some changes within, Rainbow had its operations combined with Osawatomie State Hospital in 2014, and at that point it essentially closed as a state institution. One point of note on page 5 is that prior to its closing in 2007, Rainbow ceased treating children and adolescents and began referring them to KBC. And then in 2010, Larned followed suit and also began referring youth to KBC. On page 6, you'll find some information about the capacity concerns that hospitals began to face starting in 2010 and earlier. And this led to a temporary suspension of voluntary admissions. The changes that have occurred at Osawatomie State Hospital over the past year are also outlined, the past several years. And I'm going to now defer to Matt to walk you through the second of the document.
Welcome to the committee.
Good afternoon, Madam Chair, members of the committee. My name is Matthew Moore. I am fiscal analyst with the Legislative Research. I will be taking over the state hospitals and KDADs from Dave. There are a lot of issues to fill, but I hope I can meet the expectations. We'll begin on page 6 where Megan left off, kind of shifting from the kind of the state institutions to more of the community settings with nursing facilities for mental health. At the bottom there, I have a brief description of what they were and how they came about. Kind of inpatient beds based in the community, so rather than being an institution to allow individuals to receive care in the community. Going on to page 6.
Can you get into that mic a little bit more, make sure it's on?
It's on. Can you hear me better now?
That's good, yeah.
Okay.
If you need to slide it down, do that. That's just kind of a.
So saying at the beginning of page 7, a little bit more description and kind of the history of some of the closures, kind of some of the beds, as well as kind of where we're at today with 10 in 2020. It moves on to the PRTFs, kind of describing the shift from caring for children in institution settings to being in PRTFs, kind of describing what they are, listing the currently at 17. From there, we move more into out of inpatient to more community settings with community mental health centers. They're at the bottom of page 7, as Megan indicated, playing an important role as the gatekeepers for the rest of the system. Moving on to 8, a little bit of discussion towards the populations for CMHCs, and then kind of dovetailing a little into the waiver for children with serious emotional disturbances is another means to assist individuals within the community as opposed to institutional care. Then lastly, with a few other community supports, kind of an increase in consumer-run organizations to allow for individuals to take charge of their own care, and then the shift to crisis centers in recent years, starting off with about 3 and slowly increasing to 5, and then 1 in Douglas County starting up. Page 9 details some of the efforts to increase the accessibility for mental health services. Mental health parity and details both the federal and state efforts to bring parity to mental health services. It's up 9. On page 10. We're going to go into increased scope of practices. So some of the changes in licensing requirements to allow professionals to more easily reach a wider group of individuals. I guess in several categories of recent changes in these professions and what they are, the various bills that allow them. Moving on to page 11, is kind of wrapping up with funding for mental health services, kind of detailing the major sources. Number 1 being Medicaid. Describes some of the changes in the early 2000s to address a gap in funding for some cities, moving into the implementation of Medicare and how that affected the receiving of Medicaid funds. On the last page 12, we talked a little bit about local funding, mostly as it relates to CHCs, and a little bit more in the afternoon on that.
We still need you to get louder. The Zoom people are having a real hard time. I'm sorry.
Sorry,
You're a soft-spoken individual.
that's one of the things I'm trying to make sure I address. Any opportunity to address that.
Oh, we'll break you in, don't worry.
So as I said, a little bit of local funding. There at the top for student cities, as I said, we had a little more discussion about in the afternoon. And lastly, just the description of funding for the state hospitals, the 3 main sources for that, state general funds and their key funds, as well as with that, any questions or any suggestions or topics about this.
One question.
I have a comment.
Who's that? Is that Don?
Don Jordan.
Oh, sure, Don. You go right ahead to the chair. That's okay. It's no big deal, Don.
Sorry.
No,
I just wanted to say, I started in the mental health system in 1992. I helped participate in the implementation of mental health reform. I oversaw the closure of Topeka State Hospital, Winfield Hospital. And the one thing, I think this is a really good report that you put out. I'm familiar with most of it, but I think there's one significant item missing that is very dramatic in what happened to the populations. And that was in the 1950s, there was the first development of psychoactive drugs that actually allowed people to manage their mental illness if they took their drugs. And none of this would have happened without those drugs, and the impact of psychiatry changed drastically because of the medication that became available. How state hospitals operated was radically changed. So rather than someone going there to spend the rest of their life, they went there to be stabilized, set on a system that would keep them going, and then transferred to a community mental health center that would monitor it. Anyway, I just thought that would be an important piece to have this.
Don has probably forgot more about the mental health system than most of us will remember. The only other person that might have matched that would have been Representative Newfeld. So, one question that I had for you on your page 8 with the Douglas County Crisis Center, did they actually end up getting their funding to proceed forward?
I will let Dave handle that, and he's going to do the analyst for last session.
All right, thank you very much.
Thank you, Madam Chair. Just to clarify that item for the Douglas County Crisis Center. So those are different facilities primarily operated by community mental health centers that provide crisis level services. There are several that are currently receiving funding from the state of Kansas. Some of those facilities have a dedicated line item appropriations bills. Those ones would be CompCare in Wichita, Rainbow Services Inc. in Kansas City, Vallejo in Topeka, and there's one in Salina that receives a little bit of money through specific line item appropriations. There is also a facility in Manhattan that receives a little bit of money through other funding sources. The Douglas County Crisis Center is a crisis center that was beginning operations. I believe they were planning to start operations for crisis services in 2021. And the legislature did go ahead and add that to the appropriations bill. I think it was about $750,000 through a specific line item appropriation. However, that item was included in the allotments from the governor, and so that funding under the allotments would not be provided to Douglas County Crisis Center through that. I would just clarify for the committee that I mentioned the facility in Manhattan. That facility does operate through some other funding that it receives through KDADS. Some of that money can be dependent on other factors. Some of the money for the crisis centers is from the lottery vending machines. And so that is based on how much revenue they actually, the lottery actually gets from those lottery vending machines. And then some of it goes to crisis centers. Some of it is dedicated to clubhouse model programs. So in terms of other funding sources, that money from the lottery vending machine proceeds would be available to be directed through KDADS for other crisis centers. But the specific $750,000 that was put in by the legislature was included in the governor's allotments.
And that line item was done because the lottery vending machines hadn't been up and running and out there in place, so they weren't generating the income that was projected. Is that correct?
Madam Chair, that is correct. The lottery vending machines originally were supposed to be rolled out, I believe, a couple of years ago. And the first year there was going to be a cap of about $4 million to that would be transferred to KDADS for the crisis centers and clubhouse models. Crisis centers would receive about 75%, and then clubhouse models would receive 25%. And then each year thereafter, it was going to be a cap of $8 million, and no more would be transferred. But there were some issues with rolling out those machines. So there were some delays. Last year, some money did come in through that, but it was not close to the threshold in terms of the cap. Those lottery machines have been operating since that point. So they operated for part of last fiscal year, and they are currently operating in different facilities. I understand there are plans to have more machines roll out, and I understand there are some negotiations going on with those contracts to add more machines. But the current machines are mostly in places like Walmart. You might see them in places like that. I think there's some plans to maybe look at other facilities like gas stations and have more machines roll out. So there are some, but not as many as the full rollout for those ones.
Senator Allen.
Thank you, Madam Chair. When they closed the Winfield Hospital, those patients that were there, where did they go?
Don Jordan may be able to answer that, but I believe that there were actually some facilities and housing facilities that were built down in the Winfield area. They were for those individuals.
And there, I think they went into group homes, if they want to call them that.
Right, but they were brand new built homes because that was handled by Senator, oh my gosh, Goodwin. And were those privately owned homes? They're not owned by the state, I don't believe. No, they're privately owned.
Okay.
Now you're really racking my memory on that because Representative Ballard was there with this all put down.
So that money, then the money to pay for that, to pay for those homes, basically comes from the allotment for each patient that is out in those units. Is that correct?
Right, it would have been placed on part of the money fall of the individual, which was the intent when the facilities were closed.
And I will say that those homes are doing a tremendous service for the community, and so we do appreciate that. But the question was the funding source. So thank you very much.
Yeah, I think it still kind of holds out as a the best model of any of the closures that we did was what happened down there. But then again, that was the community stepping up to the plate and playing a big part in it as well. And Don Jordan, if I'm wrong, you need to clarify that for me.
No, you're pretty well right. I mean, they went different. They didn't everybody go into a specific thing. A lot of it was that we had already reduced the size of the hospitals quite a bit. And it was more of really consolidating campuses and managing cost because of the changes that were happening in the systems. But in general, they either went to, like from Winfield, they either went to K&I or Parsons or out into the community.
Thank you, John. Any further questions on that? Go ahead, David.
Okay, Madam Chair, the only thing I was going to mention, in addition, is, as Matt mentioned, he'll be doing the analysis for the 4 state hospitals and KDAS going forward. And Megan does the analysis in terms of the KDHE health part of their budget. So I think in terms of information going forward, you'll be in great hands with them. I mentioned if you have any information for the memo, feel free to go ahead and send it to our office, or any questions in general about these topics that we're going through. So I wanted to make sure the committee was aware that, you know, even though we have these committees from time to time, we're willing to help out with anything in the new file as well.
Well, I might make a comment for staff is, and I know that in the mental health task force, and I don't remember if it's the 18 or the 19 report, there was a breakdown that explained why there is different funding mechanisms for our crisis centers and how those actually operate. And it may be the same thing on some of our CMHCs. So it would be good, I think, for this committee as it moves forward. Because one of the things our goal is when we complete our work in December, that our report that will be submitted to the legislature will become a living document versus where some of the task force reports get printed and someone either does something with them or they don't. We're going to do everything within our power to keep it as a living document so that we are constantly tweaking and working on, you know, whatever changes we see in mental health. Senator Allen.
Thank you, Madam Chair. That brings me up to my question here. When we looked at this document that has all the different studies and task forces on it, they ran from 17, 18, 19, and up to 1920. Were these recommendations implemented?
Very few.
And so
it wasn't for lack of trying. I can guarantee you with Representative Ballard and Representative Carpenter for myself.
So what we're doing here with this task force is taking all of these recommendations and going to try one more time to put them in a document that we can go forward with. Is that correct?
Assuming that those are still relevant, this is why those working groups are so important. And I really appreciate the way that KHI has done it. It's a little bit of a labor-intensive process, but it really kind of keeps you focused. I think that was evident today as you looked at the reports that they provided us. Okay, here's where we're at. Here's what we dropped off. Here are things that still need to be looked at. So that's why it's, you know, because I think this world of mental health is going to continue evolving and changing. This is why we need to hopefully stay up on top of it. And that's why our goal is a 10-year plan, worst case scenario, maybe a 5-year plan. And what does that cost us to get there? Knowing that we've also got constraints. You know, it's some of the discussions we've had in the working groups. And I appreciate the professionals who are out there and they're telling us, you know, And we're saying, well, that may not fly in the legislature. Why? And that's why our role as legislators is important, is to understand the budgetary constraints that we're going to be. Further questions, comments? All right, see you then. That's it, David.
Thank you, Madam Chair.
Is that the last time I get to hear from you today?
I believe so, but I will be present.
Okay. Now, do we have, is Chanel here? Yeah. Oh, are you ready? We're gonna get you up early. Is that all right? Ready. Okay, great. This is she's with the Kansas City Regional Director of the Department of Children and Families, and what she's bringing to us is the mental health collaboration to improve outcomes for youth in our juvenile justice system. And I think that there was, you know, a little bit of discussion earlier today. Some of our stuff is, you know, whether it's our youth touching the justice system or our adults touching the justice system, how that works. So welcome to committee. Thank you so much.
to all of the representatives and speakers here today. I will say that I am here in my capacity as the new chairperson for the Juvenile Justice Oversight Committee. And I work for the state as the regional director for the Kansas City region for the Department for Children and Families. And something that just threads it all is children, and how, regardless of whatever system our children touch, they're experiencing some of the same concerns that we're seeing. And so the reason why I'm here today, you may be asking, how is this connected? And it is very much connected with what we're seeing with our children who are involved in the system. The reason why it's connected and how it's connected is because many youth involved in the juvenile justice system experience challenges in their mental health. So the Office of Juvenile Justice and Delinquency Prevention has stated that as many as 70% of youth involved in the juvenile justice system have a diagnosable mental health problem, particularly with the current situation of the upcoming elections and active civil rights movements and a continuing contentious political situation in the post-COVID-19, all of the repercussions of the pandemic. The Juvenile Justice Oversight Committee has every reason to believe that the number is accurate or even low for youth involved in the Kansas juvenile justice system. For that reason, we are taking and have taken mental health seriously as a barrier for youth living a complete and fulfilling life. It should really be a concern for all of Kansans. So this leads to the second point about delinquency and mental health. So contrary to popular belief, in most instances, having mental health concerns is not a driver to delinquency. Rather, mental illness is known as a responsivity factor, which is a barrier to actually getting the treatment one might need. So that means that while mental health issues don't lead youth into the juvenile justice system, it does make it harder for the youth and the family to actually exit the juvenile justice system. So for that reason, it's critical that juvenile justice staff assesses and assists with mental health. However, having those staff members doing assessments should not just be our end goal, nor the primary intervention of the justice system. It should be the role of experts in the mental health system. So I want to be clear in this point that often gets misconstrued. The collaboration of the mental health world and the justice system is extremely important. So experts in the justice field currently recognize the impact that mental health concerns have on youth, families, and society. However, people working in the justice system should not be expected to be experts in mental health. Rather, we need good cooperation and collaboration between the justice system and the mental health systems. And of course, not to mention education, physical health, child welfare, law enforcement, and a whole host of other systems, which is why I'm here today. So I'll circle back to this important piece, but I wanted to give you just some background information first. So the Juvenile Justice Oversight Committee was founded in 2016 following the passage of comprehensive juvenile justice reform in Senate Bill 367. I'm sure you probably heard of Senate Bill 367. It was supported with bipartisan support, and Kansas really was a leader in this effort. So the purpose of this was to increase the reason for the reform rather was the increased number of youth involved in the juvenile system for longer and in deeper ends of the system. So for example, kids were being placed out of the home, so taking kids out of the home versus them actually using probation as a tool. So increased costs to Kansas taxpayers as well. So in 2014 and 2015, a thorough system assessment was conducted by the Pew Charitable Trust and Crime and Justice Institute. And each decision point was analyzed to determine if changes were needed to produce better outcomes for youth and all Kansans. So the result was a lengthy and comprehensive reform bill that has, as expected, improved outcomes for youth and increased public safety across the state. However, the work is not done. Continuous improvements is necessary, and we continue to strive for better. And what better is what I'm hoping we can accomplish together and today. So one of the most important changes included in the Senate Bill 367 is the requirement for reinvestment. So all of the cost savings that came from keeping youth in the community and out of the out-of-home placements is to be used for youth involvement in the juvenile justice system and their families. So at first, in 2016 and 2017, we were unsure if there would actually be any cost savings at all. Fortunately, there were. So since we also know that reinvestment has to be meaningful and sustainable, we did not just want to throw money at the wall and see what sticks, right? We have it, so let's just spend it. Rather, we paused before deciding how to spend the funds. So we waited until we had the information needed to make appropriate decisions. And those decisions involve planning for evidence-based interventions needed across the state that could continue to be used into the future. So we have since instituted new grants to communities, brought in statewide programs to address youth and family needs, and are piloting a system to assist youth involved in the juvenile justice and child welfare systems in a cohesive way. So the reinvestment plan, as approved in August of 2019, is attached to the testimony handout. This shows what we have already done and what we plan to do in state fiscal year 2020 and what we want to do in the future, which is upon us now. So as you can see, we've already directed resources to mental health. In 2019, the funds were used to conduct a train-the-trainer process to assist staff who work with you to recognize mental health needs. We funded a technological update to the use of the MAYS2 mental health screener used for supervision, and additionally, reinvestment funds have been available for counties and judicial districts to implement interventions that assist youth in the juvenile justice system. Several of these grants have been used for mental health assistance. Other funds have been used to implement or extend cognitive behavioral programs, develop and build capacity with staff, and help families navigate and understand the justice process. Our next goals are to grow our assistance to families with substance abuse needs and mental health needs. That is how our work actually overlaps, and that's why I'm here today. So what do I want? Well, we are committed to making positive, lasting changes, as I know you all are as well. And I want us to work together on that. The JJOC does not have a designated mental health professional. The JJOC has set aside $2 million to work with relevant agencies to assist with implementation of increased mental health services for juvenile offenders. We have spoken with leaders from KDADS and the Children's Cabinet to gain a better understanding of what current services exist, as well as any interagency work occurring elsewhere. We intend to move forward with the Children's Cabinet to assist with issuing grants and/or other mechanisms to contract with mental health professionals. But upon learning of this subcommittee, we ask for the opportunity to speak with you. We want to work together to create the best system for you. We suspect you may have some ideas for us. So my ask is simple. Let's keep talking. Let's communicate with one another to ensure we are making the best choices and we can move forward in a way that is modern, beneficial, and helpful to the youth of Kansas. So I would absolutely extend the invitation for you to come speak to us at our next JJOC meeting in December or any future meetings. And I invite you to help the reinvestment subcommittee to help get in the weeds as we improve mental health of youth. Rather than having two separate groups or more tackling the same issue, we would like to continue to collaborate to get the best possible outcomes for you. Thank you for your time, and I will stand for questions.
Any questions? I've got, a couple here. Is on your second page, as you talked about, let's see, read the third paragraph down. The reinvestment of funds, and then also in the last paragraph talking about What were those? Were those grants?
It's the reinvestment plan. Do you have a copy of the actual plan?
Yeah, it's probably on the back here.
Okay, excellent.
What I was looking at is what are you using for measurable outcomes?
In regards to which one?
With the reinvestment.
Yeah, so in order to qualify for the grant or the program, it does have to be evidence-based. And so each program has its own measure in order to comply and make sure that we're making the best decisions.
So then the question becomes, what is evidence-based?
Well, right, it depends on what system you're looking at, because, you know, I'll speak to what's kind of near and dear to my heart, right? Child welfare. We have our own kind of systems that are considered evidence-based, but there's I think it's the California Clearinghouse, but I can make sure that that information is correct and I'm not just transposing child welfare and juvenile justice. Yeah.
Well, the reason I'm asking those questions is the one thing that we've learned over many years, and even in some of our new projects, that if we don't have something that's measured, I mean, literally, physically measuring the success, we truly don't know what's happening out there.
Well, I would absolutely agree with that, right? It's the concept of we have money, we're just going to spend it because this program sounds good. So you do have to have measurable outcomes, which is why it's taken some time to make sure that we are spending the money in the best way that's going to benefit children and Kansans, which is why also we're here, right? To draw upon your best thinking and the connections that you may have and the programs that you may know about in your respective counties, that we just don't have that insight and information.
Madam Chair.
Yes.
This is Senator Petty, and I would share that I've had the honor of serving on this committee on the Juvenile Justice Oversight Committee since the inception, and so is Senator McGinn. So there are two people that are a part of this mental health committee that are also on juvenile justice oversight.
Okay. You have something to add to what she was sharing with us?
Do I have something to add?
Yeah.
Well, the applications come through the judicial, through the Division of Justice within our state. So that's how they come to be approved for funding. And I would very much agree that with our chair that everything has to be evidence-based as it comes forward. And there's been a lot of effort made in the first couple of years for training within staff that works directly within juvenile justice.
Okay, but I think where I was headed, and I know Senator McGinn's got her hand raised here as well as Representative Carpenter, is that we've heard evidence-based for a lot of years, and then so it's defining what does that mean, and where do we go to look for what is the data that's collected to validate that evidence-based. That's kind of where we're looking at. Senator McGinn, did you have something on that?
No, mine wasn't exactly on evidence-based, and I know, Mr. Priest said that in your world you have certain evidence-based standards, and I'm sure, it'd be nice for us to just know what they are in this situation. My question is, if we were looking at this whole trying to reorganize or just improve the wheel, of the kids that come through Senate Bill 367 system that have been identified or treated for the mental health, are we tracking and identifying so that we can use that system with these other entities and providers that are on the Zoom or part of this process? It's back to the whole silo thing. are we collecting this data and not sharing it? Or is there a way that these kids that come through the 367 have a mental health issue, problem, whatever, and that if, say, one of these service providers, and I know you get into the whole privacy issue to some extent, but is there a way that these things can intermingle so that we can be more efficient?
Yeah, so what I hear you saying, Senator McGinn, is how are we identifying if a youth has a diagnosable mental health concern that needs to be addressed? And I can't say with certainty that it's happening on local levels and then that data is being shared. What I suspect is happening is the folks who are on the front lines working with these families are just working with the families and figuring out what needs to happen for the youth and the families. But whether there's actually a way that we're collecting this data in Kansas, I don't know if that's something that's actually happening. I know that there's national data, but just specifically, I don't know if we can say with certainty that Sedgwick County has 50% of the juveniles that enter into the system have a diagnosable mental health concern. So I can't say with certainty if that's happening or not. Do I think that would potentially be beneficial? Yes, because then we can figure out what services are needed for these families, and we may start to see some trends about what certain counties need.
I think that's part of our point, is that we can't rely on national data. We can't rely on just aggregated numbers out there. So I think, somehow we've got to get to where we have more specifics to know if we're truly getting, success and outcomes, so that if we're not, how do we tweak it? How do we, improve it and make it better? And that's one of the concerns that I've had as I've worked on different things in the mental health system. And I think we're going to have to get to that. So I think if you guys could, kind of start having that discussion, how could that actually be measured? I know you talked about having $2 million set aside to work with relevant agencies to assist with implementation of increased mental health services for juvenile offenders. So what does that mean? When I read that, and I'm not picking on you at all, I'm reading that and I'm like, okay, I've heard this for years.
I know, right? So
what's new? What makes this fresh? What tells me that this $2 million is really going to have an impact? And we know that all these kids that we touch, especially those that unfortunately touch our juvenile system, we're not going to be able to fix all of them. Right. But we can certainly fix the majority.
Absolutely. And we want to make sure that we're doing it in an equitable way that touches rural, urban, all the different counties. So the $2 million, there was actually an RFP that was put out by Kansas Department of Corrections, which is where, they are the entity essentially that is awarding these funds. So there was an RFP and it was for a crisis intervention center, because there were anecdotal and very real stories of families who, instead of a juvenile justice kind of intervention, the child doesn't need to go to jail. They're having a mental health crisis that needs to be addressed. And so how do we intervene in the very beginning so that this child and this family doesn't have to experience the juvenile justice system? And so there was an RFP that was put out, and unfortunately no one put in an application for it. And so we have the $2 million that's set aside for that. And so that's why we're here again, to really, we want to not just create things just to create them. We want to create solutions for communities that are struggling.
Okay, so then, and I know the revenue part that I haven't forgotten, I'm just going down my list. Yeah, so then this runs through the children's cabinet. Was it structured that way in law? Or?
No, so it doesn't yet. What we're saying is that's where we're leaning on going. It runs through the Kansas Department of Corrections, and so we've been having conversations with the children's cabinet, And now we're here to have just continued conversations about how to best use those funds for mental health.
Representative Carpenter.
Thank you, Madam Chair. Along with what Senator McGinn and you've been talking about. So we're using evidence-based treatments and we don't have outcomes. I mean, is there a box checked as far as outcomes? Can you tell me, okay, this is successful, this treatment's successful and evidence-based treatment, and how many youth were successfully going through the program and are now on their way to successful mental health?
Yeah, so for the different programs, there would be different measures, right? What is success? What does that look like for instance, the parent engagement training versus family functional therapy? And so with each program, there are going to be measures, and that information is collected and monitored, because some of these programs have already been awarded funds and they're working in those funds. They're building up capacity and they're beginning to take on clients. But regarding mental health, the only thing that has been, let's see, so if you look on your reinvestment plan, there's a section there that says underneath currently funded mental health training curriculum, right? So, and what success is for that is we have successfully completed the train-the-trainer process for mental health awareness for staff who work with you. Because we can't necessarily, if staff who are working with you don't know how to identify or don't know how to work with youth who are presenting these concerns, then we're missing something there. So we've successfully completed that training for staff across the state. So there are different indicators with each program regarding mental health. For family functional therapy, again, we're working with youth and families in the home to address risk and protective factors within and outside the families. So there would be, certain things that would be measured. Is there recidivism? Is the youth coming back into the criminal justice system? Or are they successfully able to maintain at home?
So to follow up on that, you're measuring that now, but you don't have those measurements yet?
No.
The outcomes?
Well,
I mean, you have the measurements, but you don't have the outcomes.
So I don't have the outcomes in front of me, but the different programs would have those outcomes, absolutely.
Okay. Well, could you provide that to the committee then?
Sure, it's gonna look different, of course, with each county and who has decided to implement this or that, but I will work on providing that information. Now, let me ask you, are you interested in just mental health, or are you interested in all of the programs? Mental health
for me.
Okay.
Senator Allen.
Thank you, Madam Chair. Thank you for being here today. The question I have in reading through the last page before your spreadsheet, basically it says that you have an annual revenue of approximately $17 million. Can you kind of give me a description where that comes from?
So that would be the cost savings that were realized by closing the different correctional facilities across the state of Kansas. So what happened was basically there were different milestones that were set, and the state of Kansas came together and said, we're committed. We understand that youth do better in their communities, and so we need to make sure that we're offering the less restrictive place for our youth. And we're not just going to say we're not going to put them in jail. What we're going to do is we're going to provide programs and community supports so that this child can be actually successful in their community. So the closing of those facilities is what provided a lot of those cost savings.
So what we're really doing then, if I understand it, is, and going back to Representative Carpenter's question about outcomes, we have taken the $17 million that from closing these facilities, we're no longer locking these youth up. But do we know, and maybe I'm asking a question that you can't answer here, but let's say we had 1,000 children that were in these locked up facilities are no longer, are they successful? Have we been successful with transitioning into this new program?
Yeah, so there is a report that we do every year, and it's the JJOC, Juvenile Justice Oversight Committee annual report. And in the report, it goes into great detail about the many successes. Of course, there are hiccups. It's a major change. There's been, just on the judicial aspect of it, there are certain things that judges can't do anymore. And so there's been definitely some growing and some learning surrounding that and what needs to happen. And so we would say absolutely yes, that we have been successful, that we've met what we set out to do. Is there work to do? Yes. Do we want to continue to provide supports in these different communities? Yes. Do we need to do that? Do we need the engagement of the community of all these different programs? Absolutely. But I can provide a copy of that just so you have just a full picture of the many different areas of success that are happening.
So without this program, what we would end up with, saying let's just use 1,000 children that were locked up. Without this program, we'd be locking up 1,000 children a year. With this program, we're keeping those children out of jail and they're moving on to something that's more positive. Is that?
Yes, we're keeping them in their communities, we're keeping families together, absolutely. You know, what people, however a child is removed from the home, it's traumatic. It's traumatic for the family, it's traumatic for the community. And so if we can reduce the way that we're removing children and provide supports for that family and that community and safely, right? Make sure that the community is safe, then that's what we want to do. And so that's what 367 has done.
That program needs to be told. That story needs to be told that we are doing that.
Yeah, we're
successful. We need to be telling that story.
Yeah, we are absolutely a leader in juvenile justice reform. We are.
Thank you very much.
Are there further questions? Representative Dowd.
Thank you. I'm gonna. I know you always do that. But it's okay. I want to follow up along the same lines. Okay, when I'm looking, this is a timeline clarification for me. Okay, so when I look on your second page, it indicates here that at first in 2016 and 2017, you were unsure about how to, save the money. So really, you wanted to really think about how we want to be able to save the money. Okay, so 2016 and 17 was planning it. Now we know that it has to be meaningful and sustainable, and that's where the reimbursement part comes in. So there's three parts to what you decided to do. And mine is, was it in 2019? Now, number one, it was you wanted to institute new grants for the community. Two, you brought in statewide programs to address youth and family needs. And three, it was piloting a system to assist youth involved in juvenile justice and child welfare in a cohesive way. Okay, now, when you put this three-part series, when did you actually start on it? And the reason I'm asking the question, because that also will say, were you able to get results? So did you actually start it in 2019 or before?
Yeah, so I have to get clarification in terms of when the first grants were awarded. But just like with anything else, you can create something and then you have to hire people, okay? And then you need to build it up, yeah. And then you have to spread the word and you need to make sure that you have people that are gonna be a part of that. And so, yeah, there's absolutely that kind of build up period that happens with any program that you institute. So I can get clarification. I don't want to speak out of turn whether it was 2017, 2018 when the actual first grants were awarded.
First grants actually were issued last year. This is Senator Petty.
That's what I was asking.
Thank you, Senator Petty.
Thank you. See, I was thinking it was 2019. So that does not give you a lot of time to do that because the grants are there. You have to be able to then set up the program, and then you have to be able to monitor it and then decide how effective that program was. So we're talking about a 3 approach, which I really like how you came up with it, with maybe less than a year that you can evaluate the results, right? Okay, so what I would ask on that is there any aspect of it that's promising that you see that maybe you're on the right track?
Yeah, so what I would say is that you have to build capacity first. So the training has been paramount. It's been so important that we make sure that we're all speaking the same language, that we all understand and have the same goal. And so that when we have these different programs that are implemented, and when you have the people on the front line that are working with folks, that will have an execution, will have a product that we're proud of, and that meets the goals that are stated in the legislation.
Well, then based on that, and that's what I was thinking it was, because I knew the grants hadn't been distributed before then. It says that if you follow the model that you have here with the 3 parts of what you really want to do, then I won't say it's easy, but it would be more efficient the way you're doing it. Number 1, to look at how 1 is working in terms of how 2 is working and how you get to the rest of it in order to be able to measure. And like you said, you got to hire, you got to get it straight, then you have to look at it. And most people know that in research, you can look at how it was going now for like a month, 30 days, 60 days, but we almost have to look at a 6-month schedule to see how we want to measure. And then you look to see at the end of the year, what were your goals and how close you have gotten to that. And you're probably just reaching maybe to the point now that you can really look at it because you've had less than a year to have those grants out and to invest that, you know. So I really like the model that you're using with the reinvestment because it gives you enough time to measure. And then I'm going to go with Senator Alley comment. After we get to that point, then we need to brag. We really need to talk about the results that we are getting so that we can be like that model out there in many ways.
Well, and I think that, you know, just to not take all the credit, because I was not a part of creating all of this, but it really goes to the concept that collaboration is key. And the makeup of the Juvenile Justice Oversight Committee, I mean, we have the Senator McGinn, Senator Petty, we have folks from, we have judges, we have guardian ad litems, we have the Kansas Department of Corrections. There are so many different experts that are on the committee that we have the technical expertise from the Criminal Justice Institute. And so that's why we need mental health in this mix. That's why we need that conversation so that we can continue to, again, bring our best minds and use the funds in the best way that's going to impact Kansans.
Very good. Thank you so much. Thank you, Madam Chair. Senator Alley. Oh, wait, I'm sorry, Senator. I actually have someone before you. I apologize. I have Senator Burke on Zoom that had a question.
Actually, I just wanted to make a comment, and Representative Ballard beat me to it. She talked about the iterative process of evidence-based practices, and I think we need to make sure that when we do say we're going to do evidence-based practices, that we are doing that iterative process of evaluation, not just looking at outcomes, but looking at the whole model and how it's staying true to the research that was done when it became an evidence-based model. So that's all I had to say.
Senator Allen.
Thank you, Madam Chair. So I'm gonna go back to the $17 million revenue a year, and you're getting that from savings from not having these youth in our correctional facilities. Is that correct?
Correct. That is
okay. Where would I find that $17 million in our state budget to be transferred?
That is a question that I don't believe I would be able to answer right now, but there is an answer to it, so I can make sure that I get that.
It's coming from somewhere, so we need to find out where that number is. And maybe we can get some help with that.
That's what I'm assuming. It would be from corrections, but I want to make sure.
We can have staff get that looked up, bring it back to us.
Thank you.
One of the other things that I had is that I know that there's been concern within the foster care community that some of these individuals are being placed in foster homes. They're not prepared to deal with some of the issues these individuals have. And the place setting probably would have been better in a group facility where there could be more strict monitoring and more strict rules in what the environment of a foster care home is. What have you guys run up against on that?
Well, I think that there is definitely a lot of anecdotal, there's a lot of stories about the impact of Senate Bill 367 and individual experiences that are absolutely valid. Is it a systematic concern? I can't say with certainty, yes, I can't say that. What I can say is that I have definitely heard some of those concerns as well. You know, that essentially children who may need to go through the kind of criminal justice route are being diverted and are in the now in the foster care system. And so that's where you get the crossover youth conversation. And there was lots of conversation regarding crossover youth, right? Children that kind of touch both systems and could be in either one. And I'm of the mind that regardless of whatever system our children touch, we need to make sure that they have what they need. And so not only that they have what they need, that whoever is caring for them, that they have what they need as well. And so something that is, I mean, there's many synergetic parts. For instance, family functional therapy is something that's happening in the criminal justice system, and it's also happening with the Department for Children and Families. So again, I can't say for certain. I do know that there are many different decision points in concern of where a child ends up, and we just want to make sure that, again, families are being served.
I think that goes back to our earlier discussion of what are we really tracking to show that we are improving these individuals' lives, that we can make them productive young adults at some point. So I think that's a kind of a major issue in this. Committee, are there further questions or anyone?
Madam Chair.
Who?
Madam Chair, this is Senator Petty.
Yes.
I might be able to clarify a couple of things. One, when we talk about reinvestment, it is important to realize that the rest have gone down consistently since there have been changes made in the law, and that the reinvestment actually began right away through training of staff on evaluation of students, evaluation of juveniles as they come into the system. And then the money in the budget is in the KDOC's budget. That was in response to Senator Alley's question.
It's in corrections budget?
Yes.
Are there any further questions or comments? I think it sounds like that, we probably need to make sure that, we stay in communication with you and vice versa, so that as we're moving forward, because we don't want to fragment what we're doing with mental health. And that's one of the things we want to take and get away from. We need to make sure that we have your agency in conclusion with this.
So much. I definitely appreciate the opportunity to come and speak before the committee. And I will get that information that I am charged with today.
All right, thank you very much for being here today. We appreciate it. Next, we have Matt Atterbury, the Executive Director of Levitt Center for Mental Health, on the role of community mental health centers during moratorium at Osawatomie State Hospital. Are you there, Matt?
I am, Madam Chair. Thank you. And thank you to the members of the committee for giving me this opportunity.
Go ahead.
I've been asked to provide testimony about how the moratorium and changes to admissions at Osawatomie State Hospital have affected community mental health centers and how different the current process is in comparison to how it has been historically. I've been a part of the Kansas CMHC system for almost 31 years. My experience predates mental health reform. When I first began at Labette Center, all that was required to have a person hospitalized at Osawatomie State Hospital after hours was a handwritten note on a piece of tablet paper stating that I had interviewed the person, believed that he or she was a danger to him or herself or others due to mental illness, and that he or she needed to be hospitalized. Mental health reform brought about much needed changes and improvements in this process. Through mental health reform, most individuals with a severe and persistent mental illness could and can be treated in their home communities. However, there are times when individuals need access to immediate inpatient care. A substantial number of these individuals cannot, due to their illness, make that decision and require a court order. The bar to jump over for that order is high, even at the preliminary level. Simply stated, if you are sufficiently ill enough to meet the statutory requirements for involuntary care and treatment, you need help immediately. The current moratorium on voluntary admissions to Osawatomie and the triage process for involuntary admissions have profoundly changed how mental health reform is understood and implemented. From the beginning of mental health reform until 2015, CMHCs functioned as the single point of admission for patients at state mental health hospitals. In addition, until 2015, the admission decisions made by CMHC staff were not questioned. The CMHC said a person needed to be admitted. That decision was honored by the state mental health hospital, and admission occurred as soon as the person could be transported. Once admitted, an evaluation took place to help determine if the person needed that level of care. The decision was intended to be mutual between the hospital and the CMHC. If there was disagreement, there was an appeal process. This is not the current practice. CMHCs have gone from being the recognized authority for admission to a referral source for the hospital that, at best, begins an admission process with multiple rules and policies developed, implemented, and enforced by the state. The decision to admit now rests solely with the hospital based on the hospital's sense of appropriateness, with no formal appeal process should the CMHC disagree with the decision. It bears noting why these changes came into existence. Osawatomie State Hospital consistently had more patients than the licensed capacity for the hospital. It was not unheard of for patients to arrive at the hospital in great medical distress beyond Osawatomie's limited capacity to treat physical illnesses or injury. These and other issues were occurring for years and finally were brought to a halt by the decertification of the hospital. While the issues that led up to the moratorium were measured in years, the announcement of the moratorium was measured in weeks. Essentially, in a matter of weeks, CMHCs were told to host community meetings with stakeholders to announce the moratorium, what it would mean, and to develop a plan to adapt. These were some of the most difficult meetings I have participated in during my career. For over 15 years, CMHCs, the consumers, and the community served knew that, when necessary, a citizen in need of the type and level of care provided at a state mental health hospital could and would receive that care. Quite suddenly, in the perspective of our communities, this was lost, and for most communities remains lost today. For a county like Labette County, the practical loss of timely admission to Osawatomie remains one of the biggest frustrations for law enforcement, the medical community, other community stakeholders, consumers, and their families. When asked, these partners list this situation as their greatest concern. At the time when involuntary admissions were at the greatest delay, it was not unheard of for an admission to take more than 5 days to occur. It bears repeating that these were involuntary patients who had been found through the court process to be so mentally ill that they required care and treatment at state mental health hospitals. CMHCs were forced to take the lead with the community partners to find some way to keep these individuals safe in a way that kept the community safe as well. This has brought about situations that would have never been foreseen nor believed in the years prior to the moratorium, or even in the years prior to mental health reform. Many a CMHC, hospital, and enforcement entity has been forced into the situation of deciding what they were willing to be answerable to in times when public safety and the safety of the consumer was at high risk due to having no ability and no resources to respond to a situation in a way we all would desire. So like other communities and CMHCs, Labette County and Labette Center have risen to the challenge as best we can. Labette Center sends staff to where the committed person is being kept while awaiting admission to Osawatomie. Labette Center staff providing this crisis attendant care and intervention volunteer for paid shifts. We seek and receive reimbursement for this as best we can and know how to, but generally speaking, this is a financial loss for us. It is important to note that the staff at Osawatomie are sympathetic to the dilemma communities face while the moratorium continues. The staff of Osawatomie strive to find a way to say, yes, the patient may be admitted. What is problematic in this is that until the moratorium, communities through their respective CMHCs were the ones to get to that yes. With the current reality, the necessary continuum of care for adults with severe psychiatric needs lacks an assurance that, when necessary, the upper end of that continuum will be there. Whereas prior to the moratorium, CMHCs and communities knew that individuals would be admitted to Osawatomie involuntarily when a court determined this was necessary. Now those same communities face the possibility that in any given situation, that admission may not occur for a significant amount of time or may be completely denied. Solutions to this situation can be found, but they will not be easy. While I cannot state this as fact, I do not recall any day during the span of the moratorium that Osawatomie has been at less than 100% of whatever number of patient beds the capacity at that time was. There have been times in calendar year 2020 that there have been over 20 individuals involuntarily committed for care by court process, waiting for a bed to become available, and at least one time when that number exceeded 30. These data show there is not enough capacity for this population. Possible solutions apart from expansion of current bed capacity at OSH may include increased crisis stabilization beds and services in communities. For this to work, however, there must be a legal process and resources that allow for an individual to be kept against his or her will for care at these facilities. While additional resources are needed, these resources will not help if there is no way to compel a person needing care to receive it. A person's right to refuse care should be zealously defended, but that right needs to be balanced against community safety and the individual's right to safety from themselves when, due to a mental illness, they are unable to keep themselves safe by their own actions. Thank you for your time and attention, and I would be happy to answer any questions that I can.
Thank you, Matt. Any questions? Anyone on Zoom with questions? Representative Carpenter?
Thank you, Madam Chair. Is there anyone from ks that can answer some of these questions that are in this?
Do we have anyone on KDADS on Zoom right now that can help answer questions for Representative Carpenter?
Well,
this is Andy Brown with KDADS, and I'd be happy to try to answer some questions.
Okay.
Well, I just wanted to see what KDADS answers to some of these questions. It may not be today, but if you could get it back to us in the future. These numbers don't match up quite with what we had in testimony last year in social services budget. So I'd just be curious as to hear the other side of the story. Thank you.
Yeah, and So what I would say is that we have presented sort of a plan for our intention to try to lift the moratorium at Osawatomie State Hospital. That does include some expansion at the hospital itself, as well as our development of state institute alternatives for a regional hospital model. And we've also been working to develop our crisis intervention center regs, which will allow for involuntary placement in a crisis intervention center or an involuntary hold. And we are also, I think the number you might be referring to is the number on the wait lists. So there's been some complications with the emergence of COVID-19 in order to manage our census at the hospital and implement the infectious disease control policies. We did move forward with expansion of another wing at the hospital, but we also had to reduce the double occupancy rooms that are in the Adair acute unit. And so that's led to an overall decrease in the number of available beds during COVID. And I think that that's part of the reason we saw a spike this year. So in 2019, we did have quite a few days where there were, 0 people on a wait list for Osawatomie. I do think that when we review those numbers, we can show you what the what the overall trends are and where those spikes in 2020 occurred.
Are there further questions or comments for Matt? All right, seeing none, Matt, we appreciate you being here with your testimony, and thank you, Andy, for stepping in there, and I'm sure you'll probably be hearing from Representative Carpenter. So,
yep.
Next, we have this is the role of law enforcement in assisting individuals with mental illness, and we'll welcome to committee David Groves, Sheriff of Cherokee County. Welcome to the committee.
Thank you, Madam Chair. As you said, my name is David Groves. I'm the sheriff in Cherokee County in Southeast Kansas. And I also have the opportunity to serve as the first vice president of the Kansas Sheriff's Association. And like you, I've chosen a career in public service because I want to help people in my community. So I just heard from Mr. Atterbury, and so I know you've heard testimony from community health, mental health professionals, but I kind of want to give you a perspective of law enforcement and kind of a boots on the ground, what we're seeing and facing in our communities. And so in that spirit, I want to tell you a story about a woman who lives here in Southeast Kansas in Cherokee County. But it's no different than stories that are absolutely true in the cities and towns that you all represent as well. So this woman, she is in her 40s. She has no history of substance abuse or criminal history, anything like that. And honestly, up until a few months ago, our office hadn't had any interactions or contacts with her. But this summer, we started having interactions with her, and they became more and more frequent. They started out with calls regarding anxiety and panic attacks, and then they slowly graduated to her hearing voices. She started to confess to crimes that she clearly hadn't committed or been any part of at all. She then, her behavior escalated to we would get calls from her neighbors where she would be standing in the middle of the roadway talking to her neighbors' mailboxes, beating on their doors or windows, talking to herself, things like that. And her conduct or her behavior continued to escalate. And during many of those crises, we partnered with our community health center, and they were able to start working with her on an outpatient basis. But as her behavior became more intense, it became more and more apparent that she desperately needed to be admitted to a mental health hospital. We worked with her parents, or we tried to work with her parents, but they were elderly and just honestly not able to provide much assistance in convincing her to voluntarily admit herself to get the mental health help that she needed. And eventually she became suicidal. This is where the current system in Kansas fails. And it fails Kansans in towns and cities across our state at a time when they need the help the most. Like I said, this woman that I'm referencing, she became suicidal, and to the point where we eventually took her into police protective custody, which means the deputies then transport her to our local rural hospital, because a prerequisite to, before you can get mentally screened or a mental health assessment, you have to be medically cleared. So we take her to the medical hospital. She's medically cleared. A mental health assessment is completed on her, and it's determined that she needs to be admitted to a state mental health hospital involuntarily. So we call the hospital, and this is where the frustration comes in. There's no beds available, as you all know. At that point, law enforcement across our state is in this situation is faced with a difficult decision, none of the options of which are good. So law enforcement has to then decide, do we keep this person in our local hospital, knowing that medical care is not what this person needs? In fact, they've been medically cleared. So that occupies a bed at your hospital. It requires from law enforcement a deputy or a police officer to stay with that person around the clock for an indefinite number of hours or days. And during that time, you're also incurring hospital-related bills because you're occupying that space. Another option would be, do you transport this person who needs mental health help to the county jail? And oftentimes, just like in this scenario that I'm referencing, the person hasn't committed a crime. And if they have, it's probably something like disorderly conduct that is a result of them experiencing a mental health crisis. It's not necessarily criminal intent. They're experiencing a mental health emergency, and their behavior is causing them to do things that might meet the statutory requirements of disorderly conduct. That's counterproductive, because incarceration is not conducive to good mental health. But law enforcement has to figure out what to do with this person while we're waiting on a bed to become available. Another option would be just to release the person. Take them out of protective custody, let them go, and hope for the best, honestly. This woman that I'm referencing, the third time within about a week and a half, we were finally able to get a bed available so that we were able to get her the treatment. But that's the frustration for law enforcement and mental health professionals from across the state, not to mention the families of these folks who are experiencing these emergencies. I think that there's a lot of reasons, and I'm sure you're fully aware of most of them. My understanding is that due to COVID, some beds have been restricted, so that should patient isolation be necessary at a mental health facility, they have capabilities of managing the patient flow. But it's also, again, my understanding that despite that plan of action, there have been very few, if any, incidents where those beds were necessary for isolation purposes. So we've already have too few beds available. Now we've made fewer available as a contingency plan for COVID, but we're not utilizing all those beds for that purpose. So that just further frustrates the system and those who are trying to help citizens in our community who are experiencing a mental health emergency. So I just wanted to share that story and thank you very much for the work that you're doing, and just let you know that law enforcement, mental health professionals, we are appreciative of your efforts, and we ask you to continue to do what you can to help those in our community, because we see them on a regular basis. They need help, and they're counting on leaders to provide that help. And I'd be happy to answer any questions.
Thank
Thank you, Sheriff. I appreciate that. Are there questions or comments for the Sheriff? One that I have for you, because we've heard stories that, you know, sometimes law enforcement has had to either handcuff the individuals to a gurney in the hallways of hospitals or put individuals into hotel rooms with a law enforcement person guarding them or monitoring them, watching them for 24 hours a day. Is that some of the things that you've experienced in your county?
Yes, ma'am. And so when we put somebody in protective custody, we're with them through that duration until there's a transfer of custody to the state hospital, which for many agencies is, I mean, it's not about us by any means, but it is a burden because we're taking somebody either off their regular patrol duties or we're calling somebody in on their time off to maintain that 24-hour, not necessarily cuffed by any means, but somebody just needs to be there with them because they're technically in our custody during that time. So it does put a strain on agencies, especially smaller agencies.
Right. Well, we're not saying that you're cuffing them to be mean. It's just sometimes that's for their safety as well as yours. So how big is Cherokee County Sheriff's Department on officers?
We have 25 sworn officers in our agency.
So when you have one of them tied up somewhere else, then that could run you shorthanded.
Absolutely. It's not uncommon for us to have we're fortunate. We consider ourselves fortunate if we have 3 deputies on per shift, but typically it could be 2. And if you take one out of commission, then there's a lot of other issues. Backup for the other officer, having adequate coverage to respond to emergency calls, things like that.
One other question I would have for you, and if you have an answer, that's fine, but you don't have to answer it, is, you know, one of the things that we've been visiting with through this process is the expansion of maybe having some more regional type beds available. So if you were to, would it be easier for where you're located if there was one that would say the southern central part of Kansas?
Yeah, that would be much more convenient. But honestly, at this point, because it's not a rare thing, honestly. We, as you all know, the mental health situation, it's very frustrating. So if we need to drive 2 hours to get somebody the help that they need, then that's not ideal, but we would gladly do it.
And I wouldn't say that you wouldn't, because I think one of the things that we also realize is that when we can have the family members, which are their support team, closer so that they can get to them, and that kind of helps expedite getting them out of the hospitals. So.
Yes, ma'am.
All right. Well, thank you very much for being here with us today. We certainly appreciate your time.
I appreciate the opportunity. Thank you very much.
All right. Next committee, we have integrated care panel discussion. We have Kim Nelson, Substance Abuse and Mental Health Services Administration, Greg Hennon, Fort County Mental Health Center, and Teresa Lovelady with Health Corps Clinic. Are you all out there?
Yes, I am.
Yes, I am.
I need one more. Okay, so she's going to join us later. We're a little bit ahead of our schedule, so that's fine. So who wants to start us off?
I will, unless you wanted to, Greg.
No, go ahead.
All right.
Make sure you announce the part so the listeners out there know.
Sorry.
Make sure you say who you are so that those that are out there listening on the web or YouTube, wherever we're at, will know who you are.
Great. Thank you, Madam Chair. So my name is Kim Nelson. I am the regional administrator for a division of Health and Human Services called Substance Abuse Mental Health Services Administration, or SAMHSA, we refer to it as. As the regional administrator for this region, I serve Kansas, Iowa, Nebraska, and Missouri. So that's who I am. Was someone talking?
No, you're fine.
Okay, great. just a little bit more about me for a second, and that's that I am a long-term Kansan and have worked in the behavioral health world in Kansas since 1992. I used to say for 20 years, and then I had to say like 25 years. And now it's like, oh my gosh, I'm going to almost have to say 30 years. It's a little scary. But so that's, I also have that history. So I am going to try to share my screen. I should have the ability to do that. So, and then hopefully you all will be able to see what's on my screen. I have some slides. Can you see that it says Certified Community Behavioral Health Clinic there? Can you see that slide? Anyone?
Yes.
Yes, yes. Okay, great. All right, so I just have some slides to kind of talk about. I was asked to talk about integrated care in general. And so let's see, there we go. So this first slide really is just to level set about kind of what the national data looks like around mental illness and substance use in America. So SAMHSA does the National Survey on Drug Use and Health, which produces vast amounts of national data related to folks that are diagnosed and treated, or the lack thereof, treatment for mental illness and substance use in our country. The most recent data was just released in September of this year, and it is the 2018 date, sorry, the 2019 data, so it was released in 2020. So on the far left there, you see kind of the rates of people that are 18 and older with a substance use disorder. And you see that almost 8% of folks in our country, 18 and older. Of those, in the square above that in green are more details about, 38.5% of those folks with a substance use disorder struggled with illicit drugs. As we know, alcohol is always kind of the highest in this area, and that's 73% struggled with alcohol. And then about almost 12% struggled kind of with both alcohol and drugs. On the right side of this graphic, you'll see people again above age 18 and above that had a mental illness in the last year. And that's almost 21% of Americans. Of those 20%, we know that 1 in 4, 25% had a serious mental illness, which is, disruptive to their daily activities, essentially. And then in the center there, you see that almost 4% of people had both a substance use disorder and a mental illness. So very high percentage of people with one or the other of these also have a co-occurring situation. Also important to note, in this data at the bottom there, you'll see we had almost a 6% increase of folks in our country that had a substance use disorder or a mental illness. And this year that was composed entirely of people that had increases in mental health issues, mental illness. So that's important to note. Lastly, about this graphic, this of course does not take into account any of the 2020 situation with our COVID-19 impact in behavioral health, which has been tremendous. We know that, one recent research study showed about little over actually 40% of folks reported experiencing, anxiety, depression, substance use, kind of at a disorder level. So, unfortunately, we have to keep talking about this because there's lots of folks out there struggling. I would just add that, this committee in addressing modernization of behavioral health, and when I say behavioral health, I mean mental health and substance use disorders, combine those, and we call that behavioral health, just so that we kind of have that language. So this committee addressing the modernization of the behavioral health care system, I just applaud you doing that at a state level. This is not a easy to solve technical problem. It's what Professor Heifetz at Harvard would call an adaptive challenge. which just means that, it's not a technical challenge. We don't just have knowledge that we can apply to this situation and solve it. This is a challenge that requires us all to learn, to experiment, to try to continue to have dialogues and solve this problem. So I just want to say that I'm grateful you're tackling it. All right. So why do we want to talk about integration? Because we know that people with mental health and substance use disorders die decades before the general population, mostly because of untreated, preventable chronic illnesses. So not necessarily of their mental illness, but of potentially hypertension, diabetes, obesity-related cardiovascular disease, etc. These things are aggravated by behavioral situations like inadequate physical activity, poor nutrition, etc. I would just, add in here that the behavioral health system has a really good track record of helping people with their behaviors. And that's a lot of what drives chronic conditions. So we're well situated to help folks that have these co-occurring chronic conditions. The solution really lies in integrated care. So when we say integrated care, what we really mean by that is substance use disorder, mental health care, and physical health care combined. So that is what we mean by integrated care. And that really has the potential to produce the best outcomes for people. So this is the next two slides are just infographics that graphically represent what I just said. And that is that people with mental illness, we know, die earlier than the rest of the population. 68% of folks with mental illness also have a chronic physical condition. So if you look down at these pictures here, you can see the red line is people with mental illness and the blue line is people without mental illness. So when it comes to high blood pressure, we have, almost 22% of people with mental illness have that versus about 19% of folks without it. Looking at smoking, it's a dramatic difference. 36% of people with mental illness are smokers versus 21% of the general population. And I'll just take a second to say in Kansas, there is a really good initiative happening, kind of led initially by NAMI and now by Rick Kagan, just around reducing tobacco dependency and issues among the behavioral health population, because we know that smoking rates specifically are going down, but not in the behavioral health population. They are continuing to go up. So there's an initiative in Kansas that's addressing this, that's doing a great job. It's an incredible team of people that's working and has been working on it for several years. All right, you can see the rest of those. This next slide just again reiterates when we say integration, we're talking about mental health care, substance use care, and primary care all working together. And then, you can look at the data on those graphics. I don't want to take up too much time. This next graphic really is kind of an early representation or visualization of what we mean, how integrated care kind of started. It's evolved from here, but across the bottom axis, you'll see physical health care risk, and then on the side, behavioral health risk. And then obviously the quadrant indicates, folks that are in that bottom left quadrant have low physical health needs, low behavioral health needs. They can be seen, at a physician on site, a behavioral health care, place, outpatient center on site, whatever the need is. And then kind of across the quadrant. If you just go across and look at the top right-hand quadrant, these are folks that have high physical health needs and high behavioral health needs. And really, they are best treated in what we would call an integrated care setting. And you'll see it says PBHCI on those arrows over there to the right. That stands for Primary Behavioral Health Care Integration. And those were SAMHSA's kind of early grants that we issued to states and then to providers to start setting up systems that looked at integrating behavioral health care and primary care. So that's a graphic of this. Okay, so then we have the demonstration project from 2014 that came out of the Patients Access to Medicare, or PAMA, Protecting Access to Medicare Act, the PAMA Act of Congress, and then the Excellence Act that came after. And this is where we see established in statute what we're going to talk about for the rest of this time, at least from on my slides, and that's the Certified Community Behavioral Health Program or project. This project was around enhancing Medicaid reimbursement rates based on kind of anticipated costs for care. And it's a 2-year demonstration program that was a combination initially of SAMHSA, Medicaid, and the Office of Assistant Secretary for Health Planning and Evaluation, who's doing the evaluation of this demonstration project. So those 3 agencies came together to implement this project. So why, now you're going to hear me say CCBHCs kind of throughout the time here, and that's Certified Community Behavioral Health Clinics. So why, why is this happening? Why did that happen in that act and in Congress? Well, it's trying to address the systemic issues, many of which you've heard about here. So I'm not going to spend a lot of time on that. People have very clearly laid out the fragmented system of care, the fact that we have problems with access to care for people that have mental health and substance use disorders. CCBHCs really are kind of our most promising systematic or systemic solution. And that's because they are all about providing a comprehensive set of services that respond to local needs. And then under this demonstration project, the reimbursement model changes, which covers costs, which allows this additional set of services to be provided because of the way we're paying CCBHCs. Just as a side note, Health and Human Services has several kind of agency initiatives that go along with and support the use of CCBHCs, one of which is the Interdepartmental Serious Mental Illness Coordinating Committee, which SAMHSA leads. Recommendations coming out of that committee are for expanding certified community behavioral health clinics. All right, so the next thing here is a timeline of the CCBHC model. Just so you know, kind of on the left here, starting at number 1, the Medicaid demonstration had a preparation phase. And so first it was authorized in 2014 through the Act. Next, we held national listening sessions. We, had places on websites where people could give their input, et cetera, and did a lot of culling through state Medicaid plans, et cetera, to kind of develop the certification criteria for these clinics. After that, the final criteria, of course, CMS really did the prospective payment system guidance. And so we'll talk a little bit more about what that means. That's the change in the way we fund behavioral health care. And then in 2015, the opportunity for funding was published along with the guidance. And then we come down to the second phase here, and that's the planning phase. And so in 2015, October, later in 2015, 24 state planning grants were awarded. Unfortunately, Kansas was not one of those, but several of our surrounding states were: Iowa, Missouri, et cetera. In 2016, the demonstration application came out after, these 24 states did planning for about a year. And then CMS kind of said, okay, now of those 24 states, we're going to award 8 demonstration states. And that came, December 2016. And then I gotta move this off to the side. All right, and then the next phase up there at the top on the right-hand side, the demonstration phase, from January to July of 17, the demonstration program started. And so in our region, notably, we have Missouri that is one of those 8 states. And so I'll talk a little bit more about what that looks like in Missouri since they're close by. And then as you can see, the demonstration program ends, demonstration evaluation. There have been some expansions and some extensions to some of this through Congress we can talk about that if you want to in detail, but right now that demonstration ends. It is set to end November 30th of this year. And then just the fourth bullet on this slide, or sorry, item number 4 toward the bottom there. Separately, SAMHSA was awarded dollars from Congress to do what's called the SAMHSA expansion grants, CCBHC expansion grants, or CCBHC-E, if you see that. So this is a separate project and program from the Medicaid demonstration, and it's discretionary grants that clinics or agencies apply to SAMHSA to be awarded as a CCBHC expansion grant. And then you can see here, we had a 2018 cohort and then a 2020 cohort. We'll talk some more about that in the coming slides. Now, if you want to, feel free to just stop me and ask questions, or, wait till the end, whatever works for you all, okay? Okay. All right, so these are just key provisions related to the PAMA Act as it relates to Section 223, which is where the CCBHC is in statute. Important to understand, I guess, are that CCBHCs are to provide services to everyone who seeks care, regardless of their ability to pay or where they are coming from. It was anticipated that CCBHCs will provide particular value, of course, to people that have serious mental illness, substance use disorders, co-occurring disorders, kind of our most severely, folks with the most severe behavioral health conditions. The statute directs that the CCBHC provider is patient-centered, family-centered, recovery-oriented, trauma-informed, basically that the whole person is getting all of their care needs met through the CCBHC. All right. This is the certification criteria for a CCBHC. These are kind of the components that start to make this look different from a community mental health center. So there are 6 program requirements in order to get certified. That's that there is a staffing plan that is specific to the CCBHC, the availability and accessibility of services so that there is access to crisis services 24/7, not just a crisis hotline, but access to crisis services 24/7. Care coordination, I would say, is probably and has been called the linchpin of this program. So we heard a lot of people so far talking about the need for navigation, care coordination, navigation. This is key to people staying connected to a location for care. Helping folks navigate the extremely complex kind of systems that people come into contact with and have needs when they have a serious mental illness or a substance use disorder. So it's very important. The scope of services, there are 9 required services. We'll talk a little bit more about that. The quality reporting is very important in this model as well, because the quality and other reporting can drive the payment system. And really what the quality reporting is about is trying to get at, is the patient healthier? Do they have a better quality of life? Not just are we serving more people, but are those people actually, are we having folks that have a better quality of life, have less time in a hospital, less time in crisis, et cetera, less time with law enforcement contact, All right, and then important organizational authority governance that we have consumer, so people that have lived experience with a serious mental illness or a substance use disorder, that those people are represented on the board of governance of the CCBHC. Those quality metrics that I talked about that are important, they're listed here. You'll see that there are 9 required clinical quality measures, 12 required state reporting quality measures. This is, kind of where the pedal's going to hit the metal. This is, once we start to see the data from these quality reporting on metrics, and I think it's the next slide, I'll talk to you about kind of the reporting that's going to happen on this demonstration project, and it has started happening already. But this is where we really start to see, are people getting better? having an integrated care setting where you get your care create health, and well-being for you. So those are the metrics. This is just a graphic that represents kind of that planning grant process and what each of those folks that had a planning grant looked at. And then this is a graphic that shows those 9 required services and how that has to happen in a CCBHC. So in the dark blue squares, you see that those are the required services that the agency itself has to provide. So a CCBHC has to provide treatment planning, crisis services, screening, assessment, diagnosis, outpatient, care. The light blue squares are services that could be provided through a formal relationship with what we call a DCO or a designated collaborating organization. They could be provided through that, or it could also, those services could also be provided by the CCBHC themselves. But we could have, for instance, maybe Greg will talk about this being one of these, but a CMHC that gets awarded a CCBHC grant collaborates with an FQHC in their area, for instance, or another provider, that could provide some of these services, but that has to be a formalized agreement with shared treatment planning and teams of people that are operating together. So anyway, the light blue are the services that can be provided kind of through collaboration. And then there's the referrals. So this is that report to Congress that I was talking about. So, here we are this is a demonstration program. It's a demonstration project. Its intention is to say, if we provide service and fund it in a new way for people with serious mental illness and substance use disorders, do we get better health outcomes for those people? And so these reports to Congress are what will show kind of the outcomes. So there has been, if you'll notice on third year there is a demonstration year 1 has been evaluated by this entity. Again, the Assistant Secretary for Planning and Evaluation, that's an HHS entity. They've done an evaluation of demonstration year 1. So if you're interested in what the initial outcomes look like for the CCBHC project, look at this report. It's 64 pages. It's not long. It's easy to digest. Missouri's got some, some great highlights from Missouri in there, as well as other entities. Okay, so then to shift and talk about the SAMHSA CCBHC-E grant program, which Greg's going to talk about in more detail, I know, but SAMHSA in 2018 had 64 grantees, a cohort. These are agencies that got awarded 2-year grants, $2 million a year to start implementing CCBHC-like services, to start transforming their organization into a CCBHC. There are some differences between the Medicaid demonstration program and SAMHSA's grantees. In 2020, we awarded 166, so another cohort of 166 grantees, which is thankfully the cohort that Kansas got a CCBHC award. Way to go, Greg, at Fort County. All right, so this is just, who was awarded these grants in 2018. I've highlighted the folks that are in our region that got these awards. So you can see that Iowa and Missouri got a couple of these awards in 2018. Here's the 2020 grantees from us. And this is where we see Kansas with 1 award. Yay, that's Fort County. And then just to talk a little bit about Missouri. So Missouri, if you'll recall, they are one of the 8 Medicaid demonstration states. Missouri, of all of the 8 states, I might just be partial because they're in our region, but they really have gone all in and jumped in with both feet and have are in the process of completely really transforming their community behavioral health care system using the CCBHC model. So this state represents all but the gray areas have a certified community behavioral health organization. When Missouri went to get their state plan amendment approved by CMS for this activity, they changed the language from CCBHC to CCBHO. Don't let that throw you. It's the same organizations. So you can see that they have very close to statewide coverage. Kansas City and St. Louis metro areas are down there in the bottom, just a little bigger so you can see them. They estimate that about 75% of the population of Missouri has access to a certified community behavioral health organization. That is dramatic, and that has taken a large effort of transforming every one of their systems. Addressing mental health conditions and substance use, as you all know, multi-system level issue. Here's a few outcomes from their kind of year 2 of their demonstration. And these are gathered by the Missouri Coalition of Community Behavioral Health Care Provider Organization. And so you can find these if you want more information, but we see dramatic increases in access. We see, CCBHCs have a special focus on the veteran population. And so we see, a 25% increase in veterans that are served in the community. You can look at each of those points here. One of the rural Missouri CCBHCs served 85% more people in, by year 2. So the first number you see is baseline. The second number is year 1. The third number is year 2 on those metrics. Providing, we heard some recommendations around medication-assisted treatment for people with mostly opioid use disorder, but also alcohol use disorder. One of the CCBHCs in the Missouri system, actually this metric is for all of them, they are seeing an 83%, they're seeing 83% more people with medication-assisted treatment. That's huge if you have a substance use disorder. Law enforcement collaboration is a key component to what Missouri has going on. They do great in terms of getting officers CIT trained, and so law enforcement was responsible for almost 40,000 of their referrals into the system. And then just more metrics here. I heard this committee talking about kind of school-based mental health, and you can see the increase of school services there, 81% increase. Those little concentric circles there, they started with, baseline year, and then year 1, and then year 2, an 81% increase in services to kids in the school system. Patient satisfaction looks good. Down at the bottom, I would just call your attention to reducing hospitalization and ER utilization. Again, capacity issues, this is a big deal. This also really illustrates people's wellness. If you are spending less time in an ER, less time getting admitted to a hospital, you are more stable. Your life is going better. So this is a really important metric, and you can see, a 38% decrease in ER visits, 28% decrease in hospitalizations. Pretty big deal. Here is a bunch of resources. SAMHSA has a lot of resources when it comes to integrated care. In addition to that, we fund a Center of Excellence on integrated care that's at the National Council. So there's a website. The National Council also has an entire CCBHC Success Center, part of the work that they do. So that was a lot. I know it was a lot of information, typical Fed. I just, threw a bunch of information at you. I'm so sorry. Happy to stand for questions. Happy to, do a deep dive or talk further about any of this stuff.
Thank you very much, Kim. Are there questions or comments? Senator McKinn. I'm not sure how to ask this question, but I was looking at, maybe you mentioned this, but the Medicaid demo page. And then I'm just curious if there's a relationship with Medicaid in Missouri. How are these grants that received? Is there a match, or how does that work? How are they financially able to expand Missouri?
So Missouri got an increased on the demonstration project side, they got an increased FFP to do CCBHC as a demonstration. On the CCBHC E or expansion side, those were just individual agencies that were awarded $2 million per year from SAMHSA for 2 years or 4 years, depending on the agency, to implement, to expand and, improve access to CCBHC. And now Missouri has a state plan amendment that they have done that makes CCBHC kind of their statewide model. Does that answer the question?
I guess,
Senator McGinn?
is there any state, did they have to put state funding in to get these grants? Sorry.
So on the demonstration project, there is a limited, state, it's the Medicaid program, but it's enhanced federal. So, I don't know that there was additional state dollars on that side. Now, the state did decide to put additional dollars into this system kind of at their own choice because they wanted to create a statewide CCBHC system, and the actual demonstration project doesn't require a statewide transformation, but Missouri chose to do that. So they did choose to add some dollars. On the SAMHSA CCBHC-E side, there is no matching required and no additional state dollars required.
Any further questions?
Madam Chair,
Yes.
this is Denise Sisman. I just have a quick question for Kim, and thank you for this presentation. It was very important and informative. Do you think SAMHSA is going to be opening up additional opportunities for CCBHC expansions?
Well, let me shake my 8 ball here and make a prediction because, who knows? This really is always congressionally determined and then implemented by SAMHSA. Everything I see, so for instance, that interdepartmental serious mental illness coordinating committee, which has representation from throughout the federal government, they are making recommendations for expanding CCBHC, and every thing that I can see in terms of what we are talking about is all about expansion of CCBHC. One last kind of piece of evidence toward that, the CARES Act funding that just came out through COVID, SAMHSA was awarded $425 million through that. $250 million of those dollars were dedicated to CCBHC expansion, which is what Ford County was awarded under. So that was very recent. That's just another example of, it looks like the trend is going that way. Do I know if it's going to continue? I don't know. Makes sense that it might. It's about as good as I can do.
Really, are there further questions? Seeing none, Kim, thank you very much for what you've provided here. I think there's been a lot of talks on what we could do on the 1115 side to, move us down this road. It was a shame that Kansas stopped the process when they did. So, thank you.
Yeah.
Now, do we have Greg presenting for us?
Yes, I am here.
Okay.
I was asked to talk just a little bit about our experience at the Mental Health Center with integrated care. And that is growing, obviously, with the last 4 or 5 months. We've had opportunity through the CCBHC expansion grant. But where we started out really goes back to some things that Kim was explaining early in her presentation. A dozen years ago, I saw a graphic that said severe and persistently mentally ill adults, their life expectancy was 25 years shorter than the general population. So instead of 77 or 78 years old as an average, these individuals were dying in their mid-50s, and that bugged me. And so I just got to wondering what we could do about that, and had opportunity to send one of our licensed therapists back to school to become a physician assistant. And we scholarshiped her to go get that training. I thought, my psychiatric staff didn't have any interest in trying to take care of primary healthcare needs. That wasn't their expertise or focus in training. So we sent a therapist back to school. She got her physician assistant degree. is trained in family medicine, but has also this master's in clinical psychology. So she understands the mental health side pretty well as well. And as luck would have it, while she was there at school, she encountered a classmate that was just a traditional student going through getting primary care, family practice trained as a PA, but had a strong interest in psychiatry. And we were able to recruit that person into our employment at the same time we got our own PA back. And then we established some relationships with 2 different federally qualified health centers, so the FQHCs in our catchment area. And that resulted in a couple of models kind of emerging before we even knew what a CCBHC was. So now we're refining things. But what happened is with Southeast Kansas, the Community Health Center Southeast Kansas, we had them come kind of expand their catchment area in overlapping into ours 5 or 6 years ago, and they opened a clinic down in Coffeyville. And Coffeyville is about 16 miles from Independence, which is where I'm located. And we embedded a couple of therapists in their primary healthcare clinics. They had clinics in the high school and junior high. They had clinic in an elementary school, community elementary school, and they had a clinic, just a freestanding clinic in the downtown area. So we had behaviorists, dual trained therapists, so both alcohol, drug, and mental health trained, embedded in their clinics. And that kind of started our relationship, where we were co-located into their clinics and doing kind of those SBIRT screenings and doing whatever kinds of assessments were needed to triage those patients and get them either treated on a short-term basis in the FQHC with our behaviorists, or because our behaviorists came out of our system, they understood the 43 different treatment programs that we offer, and they were able to refer then for longer term care if that's what was needed at the mental health center. And while that was going on, I did a little remodeling in our psychiatric wing here at the Independence office, and we put in 3 exam rooms and a specimen collection bathroom and a lab and a provider office or 2, and contracted my dual trained physician assistant, contracted that person to the FQHC, who set up a clinic in our building. So they were operating kind of a branch office of their federally qualified health center in our facility, using our practitioner that was trained in both mental health and primary care. So as people came in to get treatment in our psychiatry wing, so they're getting their psychotropic medications, they can step across the hall and see Virginia, and also have the diabetes and the blood pressure and whatever else may be going on monitored or treated with someone that understood kind of the blending of their treatment needs. And we also opened that FQHC clinic to the general population. So people that didn't have transportation to get to Coffeyville from Independence could instead just come to our clinic, even if they weren't a Fort County Mental Health Center patient, and see Virginia for their primary health care needs. And coincidentally enough, they also got some mental health screenings and kind of had those ties put together. So that has worked really well. And we've also done some care coordination. There was a health home program a few years back across the state of Kansas. We were participating in that. When that was disbanded, we kept those case managers functioning in that care coordination role, and they're continuing to do that under One Care Kansas now. But we saw great value in our case managers being trained to attend to those kinds of issues. And again, having Virginia part of our organization, she does a day of psychiatry and 3 days a week in primary care. Interacting with those staff really has, from an educational standpoint, helped push things along. The other relationship that we have, and we've established that with the second physician assistant that we recruited when Virginia came out of school, is over in Cowley County, so Winfield and Ark City area. Mallory Harris is our PA there. She works in our Cowley branch, does primarily psychiatry type of work, but with the Community Health Center of Cowley County, we have some behavioral health therapists, again, dual trained in SUD and mental health, that are embedded in that FQHC's clinic. And they are also embedded in a school over there, the Winfield High School, actually. And so we're doing the behavioral health work in their clinic. And if they're, again, severe and persistently mentally ill, we may refer for longer term care with the mental health center, but taking care of people kind of where they get their primary care. And then Mallory and Dr. Crable, who is again over at Cowley, is connected with the primary care providers within the FQHC. And we have blocks of time where we do case consultation. So Mallory doesn't leave our branch office, but she does psychiatric case consultation with the providers that are in the FQHC providing the primary care. Sometimes that's with the patient in the room, and the two providers and the patient have a conversation about what the overall needs are. And other times it is simply a provider to provider type consultation. But both of those models have given us opportunity to really have a larger impact on the lives of those that we're treating. I'll also mention that one of the things that's kind of nice in our Independence facility, where the FQHC has part of the wing, and we're of course doing all the mental health care, but we have an on-site pharmacy. So when people are able to come to this facility and get their care, it's really kind of that one-stop shop that we all kind of dream about or hope for. And we've seen increase, medication compliance, because they can get both treatments, both primary care and psychiatry. They come out into the waiting room, and there's a pharmacy there waiting for them that they can get their medications from. And if they have both of those needs addressed with basically one appointment time, and they can get to the pharmacy before they even leave our building, the medication compliance goes way up. So the health outcome is better. So we've seen that kind of benefit. We don't have an on-site pharmacy in Cowley yet. We're working toward that. And we're also looking at, and I'm not sure how this is going to play out, but looking at the opportunity to get more of an FQHC presence in our facility over there. Senator Alley had made a point earlier about how you really can't be everything to everyone. And that is absolutely true. We learned that. Mallory, who again was primary care trained and had a couple of years of supervision under psychiatry with our medical director, talks about the complexity of trying to live in both worlds as a primary care provider and as a psychiatric provider. And Virginia does that just a little bit, but she doesn't blend it in the course of her day too much. She has mostly her psychiatry patients on a Wednesday and everybody else's primary care throughout the rest of the week, although she's obviously sensitive to those treatments as they are delivered. And I think that really having providers that can speak each other's language and that will communicate freely about what the patient needs, and they have the freedom to click on the televideo and have a consultant available and prescribe for their patients according to those consultations, it has really been a neat thing to see. Now we're early on in that. And we're very early on in the CCBHC model. We got the capacity building grant. We're trying to shore up new programs to support kind of the philosophy behind what we've done in integration so far. So I don't have a lot of data to be able to share, but we are collecting that now. Actually, we started all of our data collection September 1st, so we're just getting rolling with that. The biggest challenge that we've got, and we've experienced this mostly with the CHC of Southeast Kansas because of our embedding therapists in their clinics in the schools, is we aren't able to recruit and retain the right credentialed individuals to really support those clinics. We have lost probably 7 therapists in the course of a year and a half to either school districts or the CCBHC across the state line in Oklahoma. It's only 20 minutes south of us, and they're pulling staff out of Kansas right and left. So we have some gaps with our arrangement with the CHC of Southeast Kansas down in Coffeyville, because they can't seem to recruit for an LSCSW, that's a clinical level social worker, and we can't find enough of those individuals. So we've got some openings and some unmet need from a treatment perspective because of that. And I hope we're able to close that gap in the next certainly year or two at the most. I don't know what else to say about that. Kim's presentation was very informative, and she was right on target with what the CCBHCs are doing. You know, our most recent growth opportunity has been with the veterans population. We're connected with the VFW and some gentlemen there that are strong advocates. And we have some partnerships building that have gotten us contracted with Topeka VA, and we're working on one with the Wichita VA. So I really see some of the needs that were being unmet previously. It's kind of exciting to see that start to materialize. And I know that they seem to appreciate the fact that we're attending to them as a special population. So anyway, I'll be quiet and stand for questions, but it's an exciting experience so far. And I think it's really just been foundational. We have probably done enough that helped us get noticed in our CCBHC application, but we do have a long way to go in that integration process. But some of the lessons we've learned in the last 4 years or so, I think will be very useful to us, and we can build on that rather quickly.
Thank you very much, Greg. We appreciate this presentation. It makes us even more excited about the idea of what we might be able to do with the CCBHCs in the future. Are there questions or comments for Greg? Anyone on Zoom?
Madam Chairman, I have a question.
Okay, go ahead, Representative Bishop.
Elizabeth Bishop, representative from Wichita. As I understand it, if I understand it correctly, part of the CCBHC process is to do away with waiting lists or minimize them to the greatest extent possible. And I'd like to know what your experience with that feature has been, if you've been able to meet it, and if there have been any bumps in the road.
Yes, there are bumps in the road. Some of that is just staffing. It's very difficult to staff the walk-in type clinics, and that is one of the models that we're using. So if someone calls in and says, I would like to get a mental health service, we say, come on down. We've got, open access, so you can come in the clinic and we'll see you that day. Well, some days we have 5 or 6 or 7 people that walk in addition to the scheduled appointments that we have. We have 5 or so walk-ins at this Independence facility anyway. And then there are days when we have 12 walk-ins or 13 walk-ins. And so just from a volume perspective, it's difficult to predict what's going to happen any given hour of the day, and making sure we have staff so that someone isn't waiting in the waiting room 2 or 3 hours in order for that to happen. We typically don't have a protracted wait, but that can happen on a heavy open access day. But the biggest issue is we will get you in and have some kind of an appointment and intervention within a 24-hour time period. And hopefully if you've walked in and kind of taken your number, if you will, it won't be more than an hour and a half or 2 hours for that service to get initiated. But just staffing for the unpredictability is a challenge.
Could I add a little bit to that? And yes.
Yes.
Thank you. Just to say that part of the CCBHC model is really about moving away from fee-for-service like we have been tied to in behavioral health, unlike any other healthcare system, part of the system, and moving into a prospective payment system or a PPS, which allows the staffing issues to be addressed because it's a cost-based reimbursement system. And so unfortunately, Greg, as you know, at Fort County, it's great that they have the CCBHCE grant, but that doesn't come with it, a PPS. It would be nice if it did, right, Greg? You know, that's kind of the thing. That's kind of the key, is that we be able to, you know, transition that payment part as well as the service part of the system. And in the demonstration states, that's happening, not so much with just the individual grantees. So in Oklahoma, a demonstration state, you know, them being able to pull people away has to do with them having that PPS payment so that they can hire more staff to see more people. Okay, just I wanted to add a little bit about that. Thanks.
I appreciate that clarification. Are there other comments or questions?
Madam Chairman, yes, Representative Elizabeth Bishop, again, if I might. I find that extremely illuminating, and I am very surprised. I was, you know, doing handstands and cartwheels when I learned that Kansas was going to get a CCBHC, but to get the responsibility without the funding mechanism that truly makes it possible is very disappointing to hear, to tell you the truth.
Madam Chair, this is Kyle Kessler.
Yes, Kyle.
If I could add to that, what you'll hear in a little bit about Texas's program brings that through in a waiver process. So that's what the opportunity going forward is. The Texas model with the 1115, and if Kim's more familiar with this or wants to correct me, that's fine. But my understanding is that is what Representative Bishop can bring this all together. Is that your understanding as well, Greg? Yeah. So the Texas model, and I think there may be another state that's doing it as well, but in the Texas legislators would know it as the 1115 SMI transition. And that's a game changer.
At least it's a step forward from where we're at today. Reverend Ballard?
Thank you, Madam Chair. Kyle, would you please explain that a little bit more? Because it seems like there's a discrepancy between what we think it will do, okay?
Yeah, so, and I'm going to take the risk of oversimplifying this and getting myself all messed up. But there's the demonstration grant that Kim talked about that Missouri and Oklahoma are taking part in, that was the Excellence in Mental Health Act that we missed out on. Then the second piece is the SAMHSA CCBHCE grants that Greg has one of, that you get a significant amount of grant dollars and responsibility, but you don't get the prospective payment system that gives you the cost-based reimbursement. The third thing is the Texas model, which is an 1115 waiver, that where you need to demonstrate cost neutrality and you need to be able to show that you can comply with fidelity to all of these different services. And that is what Texas has seen. In fact, at one point in time in Kansas, we looked briefly at doing something like this. But Texas has figured it out, and they've got it. In fact, it will probably, they're hoping will be completely implemented through all their mental health centers, will turn into CCBHCs, I think in the next year. But again, your last presentation of the day, I'm stealing quite a bit of their thunder.
All right, I thank you. That explanation is good. Because I wasn't sure, it's like there was a disconnect. But this one, I think you put it together. We can't exactly duplicate Texas though, right?
There's really nothing that I've seen yet, in having about 3 or 4 different presentations over this. And again, Greg has sat in on one of those with me as well. I don't see the similarities between our system and Texas's system is almost uncanny in terms of county involvement, state involvement, responsibility for the public mental health safety net, crisis services, and being able, I mean, there's potential. And again, I may be a little overly excited about it, but I think there's a hand in glove opportunity. Greg, you want to add anything to that?
Well, no, other than I would just say I agree with everything that you said. I think there is very good opportunity, and I hope we're able to build on that and take advantage of it.
And I will say I have hedged on this. I mean, Texas has been going down this road for 1.5 years, maybe 2 years. And I've kept thinking, yeah, we'll see how this goes. Yeah, we'll see how this goes. But every report back I've heard from either provider side or policy side has been really, really exciting, I think.
Well, thank you, Madam Chair, very much. And that makes me a little excited too, you know, we're not as big, we don't have the money they have, and we're not as far along as they have. But that's what we said is mental health modernization and reform. And so, I mean, that gives us room to grow and to do what this committee was tasked with doing. So thank you so much.
Are there further questions or comments for Greg? All right, seeing none, Greg, I want to thank you very much for being here today, and we appreciate the work that you do out there. Next up, we've got Teresa Lovelady with Health Corps Clinic.
Hello. Thank you very much for the opportunity, Madam Chair and the members of the special committee. Health Corps Clinic is a federally qualified health center located in Wichita, Kansas. And I submitted testimony also for the committee. But one of the things I want to point out is that federally qualified health centers have grown tremendously in their ability to support individuals diagnosed with a mental health disorder, and so that we could be recognized as part of the solution as we expand, as we try to attempt to expand and modernize our system so that more individuals do have access to mental health services. I'm going to talk a little bit of how Health Corps Clinic has expanded its integrated model to really support an extremely robust behavioral health program. We've been able to leverage funding, federal funding and state funding and traditional billing practices so that we can support patients, all of our patients that come to the clinic. Each year we serve about 10,000 individuals here at Health Corps Clinic. And I think what's really unique about our having FQHCs as part of the solution to expand access to mental health services is that we serve individuals regardless of their insurance status and their ability to pay. At Health Corps Clinic, almost 40% of our patients are uninsured, and they receive access to services, again, regardless if they have insurance or not. In our integrated model of care, what we've been able to do is provide access to behavioral health services through early screenings. For instance, we provide the patient health question, PHQ 2 and 4 and 9 for our patients to screen for depression, anxiety, and other disorders, as well as the SBIRT, which screens for substance abuse and other potential issues and concerns. And in real time, when individuals screen positive, we're able to get them connected to a behavioral health provider with a warm and fuzzy handoff. Meaning while the patient is there in the medical exam room and they screen positive for the need for behavioral health interventions, in real time, we have experienced and dedicated staff working together to make certain that patients have access to services and that they're seen and kind of earlier in the continuum. For instance, we're doing a lot of preventative and a lot of early screening to make certain that we get them connected to care. One of the important things that we do as well as an FQHC is really bring in a team-based, patient-centered approach for our patients. So our patients are seen as I would say the center of the medical team, and we wrap around that patient the medical services, behavioral health services, dental services, and pharmacy services. I'll give you an example of in our substance abuse program, what we've been able to do over the last probably 8 years is really expand that program to include access to behavioral health services and expand access for MAT treatment. Initially, when our response to the opioid epidemic and additional funding that we received, we were able to bring on a specific provider that not only provided access to MAT services, but we were able to screen our patients who were already coming into the clinic that were seeking pain medication, and they were and they had other types of issues. We were able to screen them and determine if they would fit for an best fit in the MAT program, or if we could provide other behavioral health services to help them overcome their issues. When a patient was referred into our MAT program, we were able to leverage behavioral health providers while also leveraging the medical team and also providing the pharmaceutical services that the patients would need so that they could gain access to those drugs. Through our 340B pharmacy, a lot of our patients were able to get access to the MAT medications at $20, $25, and/or we were able to really support them to get them medications free of charge if they could not afford those medications. We were also able to wrap dental into our substance abuse program. So sometimes when someone's diagnosed with a substance abuse disorder, and they're in recovery, part of their recovery is making certain that we give them back their smile. I like to say that at Health Corps, so that we can reduce or eliminate some of those telltale signs, or we can support them in their recovery so they can get a better job and they can do better in life. But being able to connect dental to our substance abuse program is just an example of kind of how robust and integrated and expansive having an FQHC being part of the mental health conversation could be. So we have patients that go through our programs and they're able to communicate with all of their providers because all of their providers are working together in the same electronic health record system. So we're able to track medications that different providers are prescribing, whether it's behavioral health providers or the psychiatrist, or if it's the medical providers and or the dental providers, to make certain that we're working collaboratively as a team to get the patients the support they need. Also in our behavioral health program, so substance abuse is one part of our behavioral health program, but we also have a psychiatric consultation model that we have here at the clinic. So again, with 40% of our patients do not have health insurance. And so sometimes a lot of these individuals hit our criminal justice system, they hit our child welfare system, but they usually have Medicaid. But we have individuals that go into our hospitals and they go in for crisis care and our for psychiatric services. And when they're released back into the community. And a lot of times they don't have the support they need. We work with the two major hospitals here in Wichita to make certain that patients that are released from psychiatric care and they don't have a primary care provider and or they're not sure if they're going to get the medications after they're released from the hospital, they're able to be connected with Health Corps Clinic through our psychiatric consultation program. And we actually share a psychiatrist with the hospital and with KU Medical School. So she really works with our team to help those patients get access to the care that they need, as well as making certain that that our providers are comfortable with prescribing certain types of medication. Something else we've been able to do with, we hired a pediatric nurse practitioner that works with children that need medication management. And she also provides evaluations for some patients, and she does this in coordination with KU Pediatrics. So as an FQHC, we have a unique structure to be able to really leverage different types of fundings and different types of resources to help improve access to behavioral health care across the system. In our alcohol and drug program, we also have aftercare, we have a 12-step program, we have case management and care coordination. So there is an extremely robust set of services that FQHCs can offer in different communities. Something else I'd love to talk about also is how FQHCs provide enabling services such as transportation. At Health Corps Clinic, we have a healthy food pantry. We also have different job fairs and other opportunities that we provide to our community. And it's kind of care, I call it care unusual, but we're there to really help our patients access those resources and other enabling services that they may need. I also like to think about FQHCs as a way to access the mental health system without stigma. The way Health Corps Clinic designed its facility is that a patient could access behavioral health services, whether they're there as a dental patient, they're there as a medical patient, and or they're there for one of our other various enabling services. We screen our patients. or anyone that works with, that comes to our clinic for services. And if they screen positive, then they automatically have the opportunity to get the referral over to our behavioral health services offered by the clinic. And when they come for their appointments, they don't have to come through the mental health door. They come through the front door, and in the medical exam room, you have the medical doctor that's also the therapist is right there in the medical department. So they're able to work together. And when they come in for their appointment, it's just like they came in for any other appointment. We've also been able to do some really cool things with dental and behavioral health. We have a trauma-informed dental room here at our clinic, where it's kind of an enclosed room where we're able to bring patients with severe and persistent mental illness in for their dental care so that they can access dental services at the clinic. And HealthCore Clinic serves a large refugee population. And so we're also able to provide kind of earlier intervention services for our community. When it comes to training, HealthCare Clinic has been able, along with other FQHCs, have been able to really, I know Greg talked about being able to identify that individual that could be cross-trained. But when you create an integrated environment, you create a group of people that work together and they share together and they eat together and they laugh together. So there's a level of cross-learning that happens. And we've actually had a therapist that also went back to school to become a nurse practitioner as well. And we also bring in different individuals, schools, students that are training, and we have them rotate through the clinic so that they can understand and look at the integrated model of care. And we'll have people that are very interested in, like, oh, I didn't even realize that, psychiatry or medical, coming from the psychiatry side or mental health side, could be an option for me. So I think, well, I know as a former patient and the CEO of this federally qualified health center, that FQHCs are able to really wrap themselves and their mission and their scope around individuals in their communities and help improve the health of that community. When it comes to quality, we're measured. We have federal guidelines that we have to look at for clinical quality measures, and that's public data. We're ranked against each other nationally, on a national level and on a local state level. I think I've talked about kind of everything there. Our integrated model of care, again, it's a very affordable model because we are able to leverage, again, those federal and state dollars and just our traditional billing practices. FQHCs do bill on a PPS rate, so we do get that prospective payment system cost-based reimbursement for the services that we provide. And those services really do help us provide access to individuals that are uninsured, which is very important that we're able to get those individuals into care as soon as possible. The continuum of healthcare, we know, is kind of a widespread, and to be able to really touch individuals earlier in their, I'll just say their mental health, just touch them earlier before a mental health crisis happens and their entire family and life is destroyed in that way, is something that FQHCs are able to do just by virtue of how we operate within our communities, because we do serve extremely vulnerable individuals, and we're able to touch them in a way, whether it's medical, dental, behavioral health, and or through some of our enabling and outreach services that will help engage them and empower them in their care. So that's kind of what I have there. I'm open for any questions or if anybody has any questions.
All right, thank you, Teresa. Senator McGinn.
Thank you, Madam Chair. Are you guys a safety net clinic or community care network? Are you categorized as that safe? I'm sorry, you guys are really having a hard time hearing out there. Are you guys categorized as a safety net clinic or the community network? Kansas, like Grace Med and Health Ministry?
There are 21 FQHCs across the state of Kansas. I hope I'm getting that right there. And just like Grace Med, Hunter Health, I know Greg talked about the Community Health Center of Southeastern Kansas. They're also an FQHC. Most of us, I believe all of us, receive funding through the Kansas Community-Based Primary Care Clinic program. So we all received some funding through there. I can tell you that Health Corps Clinic received, I think, $290,000 last year. Again, we served over 10,000 patients with that $290,000 grant. And we're also, we received about $2.6 million from the federal government. So as an FQHC, we have a $10 million budget. So the rest of that revenue came from, good old fashioned billing and hard work and really doing the work that we do for our community. I can also tell you that I know Greg talked a little bit about pharmacy, how important a pharmacy was to be embedded and incorporated in the FQHC, just in their setting, and how that really increased access to medications and medication compliance. Most FQHCs, or all of us, have 340B pharmacies that we're contracted with and that we work with. And those pharmacies really do help us help our patients gain access to the medications they need, especially those patients that are uninsured, because otherwise they would have to pay full price for medications. And we're really able to help offset those costs and even sometimes provide those medications for free to our community. Health Corps Clinic also gave back about $2.9 million in community, I call it charity care, to our community last year as well. And this was in the form of individuals who did not have to pay for their medical, dental, behavior health, or substance abuse treatment. So as a model, we do consider ourselves safety net clinics, just because we're there to make certain nobody falls off the net or falls through the hole or gets lost in the system. But Health Corps Clinic is categorized as a federally qualified health center or community health center.
So I just want to know if you were the same or different from like Grace Med.
No, we are the same. So each FQHC has their own mission and their own non-for-profit, but we are all tied to the federally qualified health center federal guidelines as a community health center.
All right, thank you. That's what I needed to understand. Thank you. Are there further questions for Teresa? All right, seeing none, thank you very much for being here. I appreciate it.
Thank you so much for the opportunity.
I hate to say this, is that I'm just not familiar with your clinics down in the Wichita area, so we're going to have to come and do a visit.
Yes. Well, we're 3 blocks west of where the Shockers win. So we're off of 21st Street, about 3, isn't that right, Representative Bishop? We're 3 blocks west of where the Shockers win on 21st Street.
Okay, you're right there by the Sonic.
Yes. They call us the little hospital now because we've added on a 40,000 square foot addition to our 5,000 square foot building. And so a lot of health centers have been able to expand their physical space so that they could support at kind of their integrated models of care. And Health Corps also has a mobile clinic. So we have an integrated mobile clinic that we take out in the community that has 2 medical exam rooms, 2 dental operatories, a mental health room, a small lab, and a restroom and waiting area. And so during the COVID-19 epidemic, we were actually out in the community providing testing, one of the first mobile response units in the Wichita community. So we did the big push at Wichita State's Metroplex to make certain that anyone that needed access to COVID-19 testing was able to get those tests, regardless of their ability to pay, regardless of their symptoms. And we tested over 4,000 people in the month of May and got them connected for care. And anyone that was uninsured and that tested positive, we provided care through our respiratory clinic that we set up to make certain that they had access to care. And also when other providers in the community had to shut down because of COVID-19, I know that we kept our dental going so we can provide emergency dental services to offset those individuals going into the hospital. We were also able to provide access to kind of a respiratory clinic if individuals thought they were suffering from allergies or if they thought they had COVID-19, and also providing drive-through services. So FQHCs, just by our mission and kind of our federal statute, we're there in the communities to be responsive to the needs of the community.
Okay, I just want to make a comment. So reason I didn't recognize the name. Arnita Martin was the one that started all this. And I don't know if she's still there or not, but you guys must, when you made that big expansion, did you change your name then?
We changed our name in 2015 from the Center for Health and Wellness to Health Corps Clinic.
Yeah, that's what it was.
And Martin, she's no longer in Kansas, but we so love her, and she's at the foundation of all that we do today with her focus on education and early intervention.
Okay. All right, now we're familiar with it. I did tour it when it first opened and stuff, so we'll have to come back out and visit you again. But thank you very much for being here today. Appreciate it.
We would welcome, and thank you guys in advance for the work that you guys are going to collectively do to help improve access to behavioral health services in our community and across the state of Kansas. It's that important. So thank you guys.
Thank you very much. Next committee on our agenda, we have Keith Rickard, Executive Director of the Guidance Center, to provide a history of funding and state grants.
Hi, I am Keith Rickard, and I'm going to share some slides with you here, if I've been permitted to do that by the leader there. I'm sorry, let me try this again. All right. Assuming then that you can see it.
Yeah, we're good.
All right. Okay. Well, thank you for the opportunity to share this information with you today. I've been the director of the Guidance Center for 30 years now. I came here in 1990, which was the advent of mental health reform. And prior to that, I spent 7 years at Horizons Mental Health Center in a clinical position, working with seriously and persistently mentally ill adults and working in middle management. And it was my experience there that I think prepared me for this position as the executive director of the Guidance Center. Because when I came, there was just an explosion of growth that was driven by mental health reform. And so I think as we talk about advancement of the system, modernization of the system, that we have a good working understanding of how the system got to where it is today, and that we understand collectively how the system of care, community mental health center system of care, is funded. So I'm going to walk through this, my slides to you. I'm going to try not to read it word for word, but I thought it's good to start just with the history of how CMHC's really developed. And they really had their foundation under President Kennedy in '63 when legislation was passed to create community mental health centers. There were provisions made within that act for mental health centers to provide community-based care in lieu of hospitalization or institutionalization. You know, some of those centers were built, some were not. None of them were fully funded, and the act didn't provide any long-term funding. So we can see that it was a well-conceived plan even back in 1963, but really didn't come to fruition until much later. So during the Reagan administration, those remaining funds were converted to federal block grant funds, which still are newer to the benefit of community mental health centers today. And so I just thought I would start with that. I want to build upon this slide to show you how mental health centers are funded in Kansas. And so all 26 mental health centers share this $2,377,000 as a part of our funding from the federal government. I think it's important to know how we're created here in Kansas, and Kansas statutes make it permissible for counties to establish mental health centers in one of three ways, either as a department of a county, quasi-municipal organization if two or more counties come together, or they have the option to contract with a private not-for-profit entity. And that's the case here at the Guidance Center. We are a private not-for-profit organization. The legislation is permissive. After they create a mental health center, they can fund it or not fund it based on their financial situation at the time. So it is indeed optional, but right now all 105 counties in Kansas do contribute to their mental health center, a total in 2020 of $36.6 million. think it's important for us to stop here just a second and just reflect that mental health reform and the establishment of the mental health center system was based upon local control, recognizing that all communities are different. And so what works in one community may not work in another. And therefore, we needed to have some independence as well as collaboration with the state of Kansas. But you can see that we've got federal block grant funding, and now we have counties that also provide a level of support. Upon establishment as a CMHC, an application is made to KDADS, what used to be SRS back in the day, for licensure, and they then contract with mental health centers as well for additional services that are of focus and specifically SPMI adults, SED youth, and those in crisis have been those that have been the focus in the last 20 or 30 years or so. I think it's important too to recognize that mental health center aid started with back in 1989 with something called state aid. There was state aid legislation passed that provided a base level of funding for CMHC basic services that didn't include any of the services that were identified in mental health reform, but were there prior to that time. And the total annual state aid to CMHCs since 1989 is $10.2 million. And I say $10.2 million is the entire 31-year history of funding. It's remained exactly the same over this period of time. Mental health reform legislation was passed under the Hayden administration, which brought $39.9 million to build a community-based system of care. There were 3 phases that moved across the state, the eastern, the middle, and the western parts of the state. Each were allocated funds. And each of those mental health center districts then decided how to distribute their funds based on a number of factors that were population, of which was one, current presence in the state hospital system was another. But anyway, those dollars were implemented initially into the system to downsize the state hospital system to create community-based care. This also expanded the state's budget share for Medicaid because it gave us the infrastructure to make it possible to bill additional Medicaid services. We were able to hire staff that were credentialed that we could then generate those dollars. And mental health centers did see tremendous growth from 1990 to the year 2000. When I came to the Guidance Center in 1990, we were serving about 1,300 people on about $1.3 million. And by 2000, we were up to about a $7 million budget, serving about 3,500 patients per year. So you can see that mental health reform was successful in creating community-based options and in providing community-based care. And state hospital beds were reduced from the then 1,300 down to the 238 beds that are present today. And I think it was mentioned previously in a report that state hospital did close, Topeka State Hospital closed in 1997. And also some community beds are now used as overflow for the hospital during the moratorium, which we also discussed a little earlier. The momentum created by mental health reform began to create some political and financial concern, quite frankly, on the part of the state, this new system of care. And in 2000, the state, through SRS at the time, came to CMHCs asking that all mental health reform funds be withheld to be used as match for Medicaid. I won't go into the very complex system of Medicaid matching that existed prior to the year 2000. It is very complex, but obviously the state has a share in drawing down Medicaid, and they wanted to use our state grant dollars to do that. But we did resist, mental health center directors resisted, saying that not all of our clients were Medicaid eligible, and even some in the target population. Many in the target population were not insured then and are still not insured today. So a compromise was struck, and we were able to retain some of those grant funds, while the majority were indeed added or allocated for Medicaid match. Today, mental health reform and contract dollars from the state of Kansas are about $53.8 million. So again, we're building the formula here, which I'm going to show in a graph, how that constitutes funding overall for a mental health center. The momentum that created by mental health reform, it obviously let's see, I don't think I changed slides there, did I? Let's see, in 2000, in order to assist the CMHCs to earn the same or higher levels of care, new Medicaid codes and rates were established for case management, for psychosocial group and individual, as well as attendant care. Those were new codes, essentially. Prior to that, weren't given a lot of attention to, but they were seen as the primary services that would help to keep SED and SPMI clients out of higher levels of care, along with medication management, which I heard Don Jordan mention a little bit earlier in the presentation. Those are the key things that help us to help people stay in their communities. But the rates of reimbursement for those three services that I mentioned above are still today a point of contention by all three Medicaid managed care companies. However, these rates have kept mental health centers from collapsing with the shift away from primary grant funding. So we CMHC directors, we knew that this new model for funding the system primarily upon Medicaid would be in jeopardy when managed care would come to Kansas. And so we were proactive at that time, and we worked with the state to develop our own not-for-profit managed care company, which we gave the name Kansas Health Solutions, wholly owned by the association. And during those years, we had expenditures for the mental health center system, not just mental health centers, but all mental health providers and inpatient care, total between $175 and $200 million per year. So the program was successful in ensuring that those programs were efficient, that Medicaid growth was controlled. And actually in the final year that Kansas Health Solutions managed Medicaid, we were asked by the state, they just came, so we need to save $19 million in Medicaid this year. Can you work with the mental health centers to achieve that? And so we did. We negotiated together how we would survive on a finite amount of Medicaid funds, and we did that, saving the state $19 million. So it was a successful system when we were managing it. This is the slide I think that is telling. I hope that you can see it well on your screen. But if you'll follow with me here, the red line across the bottom is state aid, which I told you has been the same since 1989. This makes up the full budget, less a few private dollars and donor dollars. But you can see the constant line of state aid has always been there. State and federal grants since the year 2000 have been fairly stable, with the dip in 2007 due to the economic collapse, and then some growth back since about 2013. But in 2020, we just returned to the level of 2006 level funding in grant and state and federal grant dollars. The purple line for us at the Guidance Center is our county tax dollars, which stayed constant, dropped again with a recession in 2007, which through a lot of hard work and education has begun to climb slightly for us, but you can see it represents a very small percentage of our overall funding. And this big blue space, obviously, this is what floats the boat of every community mental health center in Kansas. About 80%, 70 to 80% of all mental health center funding comes from Medicaid, and that's true for all 26 community mental health centers, perhaps with the exception of Prairie View, that has a lot of private pay and a lot of private work for hospitalization. But you can also see over this period of time, as we built this system of care, the client line continued to grow throughout this time. And clearly, I hope this is a good visual for you. We've grown from 2,400 clients in 2000 to 5,000 in 20 years, so an increase of 100% during that period of time. Every mental health center in the state of Kansas could create the same graph. For them, they might be slightly different. This is the one for Family Service and Guidance Center in Topeka. They're a subsidiary of Vallejo Mental Health Center. They provide just services to youth or to children. And you can see their county dollar line is very constant across the bottom. Their state aid line is very constant across the bottom. Their state and federal grants fluctuate or pretty much stay the same throughout. Brenda Mills, the CEO there, put also their self-pay and commercial insurance dollars into their slide. But again, the big blue is where it's clear that mental health center funding comes from the source of Medicaid. So if Medicaid is floating the boat and we're talking about changes in reimbursement systems, we need to keep in mind that the current system is heavily dependent upon Medicaid. Every year during our audits as mental health centers, we receive one of those little notes that says high concentration of risk due to a majority of your funding coming from only one source. So without Medicaid, or serious interruptions in Medicaid would cause many of us financial disaster and even bankruptcy. So to backtrack just a little bit, managed care did come to Kansas as we knew that it would. We planned for it for many, many, many years, and it did come to Kansas in a for-profit way in the year 2000. These are the three companies that originally were granted contracts. We know now that Amerigroup is out and Aetna is in. But one of the problems that contracting with three different MCOs created for mental health centers, that it created higher administrative costs for contracting, for credentialing, for billing, and for auditing processes. And if I can go back just a second, you can see that in 2015, just 2 years after the contracts with the MCOs were signed, you can see a reduction in the overall Medicaid funding for the guidance center. That's because of they began to assess quality and necessity criteria for our services. And so we began to see a reduction in funding. So additional costs and reduced funding obviously has created a problem and a conflict for us, but no question, growth in Medicaid was controlled under KHS, just as it is under the for-profit system. It should be noted that the behavioral health rates of reimbursement from Kansas Medicaid have not been increased since 2008. And indeed, we've suffered reductions in Medicaid during certain economic periods of decline in the state by as much as 4%. And I think Kyle reminded me that there was a short period of reduction of 10% at one point in time in the last 10 years. But regardless of constant or reducing funding, CMHCs have always been held to their requirement to see or to provide service regardless of ability to pay. And funding for the uninsured and underinsured is the ongoing concern for all communities and for all CMHCs. How do we pay for care moving forward? I said before, mental health centers report that 70–80% of their budgets are financed by Medicaid, and any major changes in policy must take this into consideration to ensure that the retention and the safety net system provider system is in place. These implications for future funding and payment models must take into consideration, in my opinion, the history of where we've come from, how we've gotten here, the quality of what's being delivered. And I know that we're talking about value-based care and getting paid for outcomes and not just time spent. I think we all look forward to those days, but we're going to need extensive discussion and planning with state government partners, MCOs, and CMHCs if we're going to launch into a new funding era for community mental health based on this. I know too, we're talking about CCBHCs. I know we're talking about prospective payment systems, but the ship has sailed on those being statewide implementations by the federal government. And so any kind of piecemeal implementation, center by center by center, could potentially create problems as well. For example, if Wyandotte Center and Johnson County Center in my area are granted a prospective payment, CCBHC, they're all awarded cost reimbursement. They're able to pay higher salaries for staff and better benefits. And I recruit from the Kansas City area. I essentially won't be able to recruit staff if I don't have a level playing field in that system of care in the CCBHC model of care. I know that there are some caveats to that. I know that there is some opportunity to contract with a CCBHC for some level of services, but again, we have to do that in a very careful way so that local control, local implementation of services are not interrupted. Again, we've been surviving on 2000 level 8 funding, and we have to have a funding bridge to get to the new models of service. Again, in my opinion, Modernization of the system involves ensuring that every client has a payer source and that costs are understood in advance of contracting for those services. I know CCBHCs are the wave of the future, but again, we have to have close coordination of efforts to make that happen. In my opinion, if we've been living on 2008 level funding from Medicaid, I'm trying to think of things that I was able to purchase in 2008 for the same dollar I'm able to purchase today. I did figure out I can still get a haircut for 15 bucks. I could get a haircut for 15 bucks in 2008. You still get one today, but that's the only thing I could think of that costs the same, except mental health services at a community mental health center. The reimbursement rate is exactly the same as it was in 2008, and that was 12 years ago. And I also believe that Medicaid expansion could be the financial bridge needed to get to that new system of care reimbursement. Obviously, I think 2000 was the year that we expanded Medicaid in Kansas the first time. So we do have a history of having done that by putting more eggs in that basket and financially supporting our mental health center basically in that way. And we've been partners with the state for the last 30 years, and we want to continue to be that. So we do provide service regardless of a person's ability to pay, just as the FQHC exec just shared with us. That's been our mission for the many, many years that we've been in existence in delivering care. But my final thought is that failure to acknowledge history and the current financial structure of the safety net system could jeopardize that system and the lives of many impoverished and high-risk Kansans. So with that, I'll just stand for any questions that you might have. I can walk back through any of those slides you might like to see again. I know I talked quickly because I know it's the end of the day and probably you're getting somewhat tired, but I think this is important information for all of us to have and to know as we craft a new future for community-based care where everyone has a payer source.
Thank you very, very much for that. Committee, are there questions for Keith about on Zoom?
Madam Chairman, I have a question.
Yes, Representative Bishop.
Is there a problem relative to the MCOs of not having consistent policies from one provider or from one MCO to the next?
I don't experience that. I can't be critical of the MCOs. They're doing what they were contracted to do. They're scrutinizing our work. They're helping to support our work. The problem really, I think at this point, is the rate of reimbursement, not necessarily. Initially, we squabbled quite a bit over necessary services and getting services approved. But I think today it's primarily the rate of reimbursement that is making life difficult. I've had a $9.5 million budget for 6 years. And people ask me how I've done that. Well, I've done that on the backs of my staff. We pay a bachelor level person right out of school less than what they can make driving a truck for a UPS or Amazon. And that's a shameful thing, but what am I to do when 80% of my fund comes from Medicaid and those rates haven't been increased since 2008? How can I pay more? So it is a constant challenge to keep good staff. I lost an APRN to the Missouri FQHC here just last 2 weeks ago. And I've lost staff to schools as well. Schools are paying about $10,000 more for a bachelor level teacher than we are able to pay a bachelor level case manager. So I think we are in crisis mode. Many of us are just treading water as mental health centers. And I've been on the technical assistance team for mental health centers for nearly 20 years, trying to go into centers that are struggling to help them understand the rules that we live by and capitalize and maximize those rules. But, I've run out of suggestions, except here's how you lay off staff. Here's how you reduce expenses. That's my recommendations of the last year or so.
Well, thank you for this report. And I would love to have a copy of it digitally, and if it's already been sent and I just haven't seen it in my email, I apologize, but I would love to have a copy of that because I think it's a very exhaustive explanation of the funding processes down through the years. And thank you.
You're welcome.
Beverly Carpenter, didn't we do like a 1 or 1.5% increase on reimbursement rates last year? And then that got cut in the allotments by the governor, correct? Okay. Are there any further questions or comments?
Madam Chair?
Yes, Representative Bishop.
No, it's Senator Petty.
Oh, Senator Petty.
I know it's late in the day, we're all sounding alike.
I'm going to blame it on Representative Ballard just because.
I did want to ask a question of Keith, and that had to do with, oh, just lost my, oops. Did you lose me? Because I lost you.
Now you can hear you.
Okay. I just was curious. I mean, I know what's being, the amount of funding that's coming from the state and how that's flat and hasn't changed. But what about the local levels? As we've had this increased interest in or discussion, whether it's in the counties or state or nationwide, about mental health and how it's impacting such a, you know, every part of our lives. Have you seen the counties in any way responding to maintenance of effort?
Well, certainly we have. You know, Leavenworth County for years and years and years was 105 of 105 counties in their annual contribution to mental health centers. So when I came, they were giving us 100,000, and until 5 years ago, they were giving us 100,000. So with some new elections and new administrator, we've been working closely with them, and so now I think we're up to about $260,000 on a $9.5 million budget. So there is greater interest by counties, but at the same time, the level of growth in Atchison County and Jefferson County, while there's been some, and I've been complimentary of the commissioners there for their contributions, it's still a very small amount. I think that the state average, we do a mill levy survey, so you can see what your counties contribute on a mill levy basis of that $36 million that's being contributed. But my counties, again, are handicapped financially, so we don't count on them for a big share of our funding. We do, some mental health centers do some charitable fundraising. We always do. We set a goal of raising $30,000 from our local community. For the last 10 years, we've been able to do that. But again, $30,000 doesn't go very far. And that hasn't increased either over the last 5 or 6 years. So we're not seeing any significant increases. There's certainly more interest. In Leavenworth County, we did create a mental health task force. We came up with some goals and identified some needs here. We were going to ask the voters to support about $1.2 million of growth. And then COVID hit, and we knew that we wouldn't be able to pass that referendum in August. And so we took it off, and we're going to prepare to do it again in April. But I hope that answers your question. I think there's interest, but it's an uphill climb.
Thank you. It does. I appreciate that.
Are there further questions or comments?
Yeah, this is Will Warrens. I had a quick comment, just that when I was referencing earlier this morning, some of the uncomfortable truths that are kind of highlighted in Keith's talk. I think Representative Bishop was saying, is there something about the MCOs being different from each other that is impacting the CMHC system? That's not exactly what I'm seeing. What I'm seeing is that we have systems that are working either cross purposes with each other or not. Since they don't understand the history of funding, they don't realize the effects of what they're doing, perhaps. When we have MCOs come in and try to right-size services for a particular member, and that member happens to have Medicaid, we don't realize that we are impacting a CMHC's budget much magnified from just that member. I think we have to remember that, case management that was referenced before, I'm the medical director for the guidance center. So, it was kind of confusing to me when I became medical director that I'm a money loser for the center. Well, it's because the fees have been structured that case management is going to fund the other services of the center. So you have select services funding other services in the center, and then you have Medicaid that is being tasked with funding a large portion of the population that's coming into the CMHC's doors. So any regulation of those Medicaid members, even if it's appropriate, if you look at just the member, is having wide effects across the CMHC system. And so I feel optimistic about this because I feel like there's things that we can do to, maybe restructure things and move forward. And I want to do that with the CMHC system because I practiced in Nebraska and Iowa. And I'll tell you, those states have nothing compared to the CMHC system in Kansas. The CMHC system in Kansas is something very special and very valuable. But I do feel like it is front and center on our plates as far as something to wrestle with.
Other comments, questions? All right, seeing none, thank you very much. I appreciate those additional comments, Will, and thank you, Keith, for being here today.
Thank you.
Okay, last but not least, and as we welcome Danette Castle, as Chief Executive Officer with the Texas Council of Community Centers, to give us an overview of the Texas Community Behavioral Health Clinic initiative. So welcome to Kansas via Zoom.
All right, thank you so much. I'm going to go ahead and see if I can pull up my screen and share. All right, so are you seeing my screen?
Yes. Well,
all right.
You're seeing several, you'll need to highlight your pages because we're getting all the pages at once.
All right, so I'm pulling it up now if I can. There we go. How's that? Is that better?
Yes.
Okay, all right. So thank you for having me here today. I appreciate the invitation to have a conversation about an initiative that is really important to Texas. I will say that I'll try to tee a little bit off of some of the previous conversations that I've been able to hear. And I particularly Keith, he was going through the history of the community mental health center system in Kansas. And I would say that he was telling our story. So fortunately, you will not have me trying to tell that again. But I will say that we have a really common background in Texas compared to Kansas. And I would say that Kyle has seen some similarities in what we're trying to do. And I think that's pretty likely to be an opportunity. I have with me today Lee Johnson, who is the Deputy Director for the Texas Council. We are the association that represents the 39 community mental health centers in the state. And I also have with me David Whedon, who is the Chief Fiscal Officer and the Chief Operating Officer for Integral Care. They are one of the community mental health center centers in Texas. And they're here with me to provide color commentary as may be necessary, to provide answers to questions that might be more of a technical nature, and I will ask them to step in at any time. I'll also say that if you have questions as I'm going, please feel free to let me know. You just have to make sure that you can talk over me a little bit. The presentation that you're going to see is a presentation that we actually put together for the National Council Conference that was to be held in last spring in Austin, and it was canceled as a result of the pandemic. When Kyle asked this week if we could do a presentation, I said yes, if it's okay if I just pull up that presentation and basically run through it. So you'll see a little bit of data in here that I would typically have updated to have data that's a little closer to the current time. But I think it's we're still gonna be able to tell the story with it. I am really, this probably made more sense last spring to talk about luck and to think about St. Patrick's Day happening at the time that we were planning to do this presentation. But what you would see as a theme throughout this conversation is the fact that we didn't set a course to become a CCBHC state back when we began our work to better integrate care for people with serious mental illness. But we were on a path to do that. And what ended up happening is that opportunity came our way. And because we were working toward a day when we could provide better care for people with serious mental illness, better health care overall for people with serious mental illness, that we saw in the work that the National Council was doing through the CCBHC legislative strategy, we saw great opportunity. You heard today from a leader of the FQHC system, and she was talking about what they've been able to do to invest in their system, having a PPS payment. Now that's an acronym for, really from our standpoint, getting to a place in which you are actually paid at a rate that is at a level that you can deliver care that is of high quality and that you can be proud of and that you can invest in development of the system. So the community mental health center system, as Keith was pointing out early on, there was a dream and a vision that we would be able to have a system that could enjoy the support of the federal government, the state government, and local government as well. And that we could in fact be in a circumstance in which we could move that system forward. And changes occurred primarily around the really around the funding piece and the federal government altering their investment in the development of this system. In Texas, we have enjoyed in the last several years a fairly substantial amount of funding and investment in mental health services through state funds. But really, we have watched the federal government funds, except through Medicaid, come down pretty rapidly over the years from the time when we were first envisioned to the point where we are today. A few things about our state. You're going to see some things in here that might feel similar. You'll see some differences. Those are all important as you consider what could make the most sense for Kansas as you move forward with opportunities to modernize the mental health system in Kansas. We have 39 community mental health centers. They are all members of ours. They have statewide coverage. You'll notice as you look at this map that the regions don't line up beautifully. They are very locally driven. So you'll see single county areas and you'll see multi-county areas. So when we followed on the 1963 federal act that Keith was talking about, when we followed on that in Texas, the legislation that created our system or authorized our system basically said that counties, local taxing authorities, counties, hospital districts, cities could come together and they could form this community mental health center system, and they could do it in a way that made most sense to them. And this is, when you look at this map, that's the way it turns out. You'll also see here that Texas has not expanded Medicaid. Keith was talking about the possibilities of Medicaid expansion in Kansas and what that might do in the mental health system. And what I would say is, caution, caution, caution. Yes, in fact, there is a great deal of value as we think about the percentage of people you'll see on that next point. 60% of the people who have serious mental illness in our state who we serve today are uninsured. So thinking about them having access to care and coverage is something that, you know, we would really like to see in a way that could make sense for Texas. But what we also know is that if we were to have an expansion today on the Medicaid rates that currently support our system, the public mental health system would crumble. Keith points out many years of being in a circumstance in which he hasn't seen a rate increase. In Texas, we have what we call a Medicaid shortfall, and that is a circumstance in which the Medicaid rate is not covering the cost of care. So part of what we're trying to get to in the strategy that we are moving forward with is to pull some of that value of that PPS system, the CCBHC payment that's associated with the quality of care, to pull that forward into the future so that we're not in a circumstance in which we're trying to deliver care on Medicaid rates that are not adequate to cover the cost of quality care. So when somebody asks us, would you like to see Medicaid expansion? Well, first of all, we say that is a decision that gets made at a level much higher than us. But the second thing we say is, if it were to happen, it has to happen with a different payment methodology, or we would not be able to cover the cost of care. We are currently augmenting the Medicaid rate shortfall with other sources of funds. And that's really important as we think about the future and how the future mental health system is funded and how services are provided. We do have in our state 90% of Medicaid services are in managed care. It sounds like that's pretty similar in Kansas, where the majority of the Medicaid system is managed through managed care organizations. We have quite a few MCOs that we work with. I think there are 20, 21 maybe. David or Lee might be able to step in with that. But we have definitely a managed care platform for the delivery of Medicaid services. But keeping in mind that about 40% of the population that we serve actually have Medicaid, and about 60% are currently uninsured. Texas does have the highest uninsured rate in the nation, and the subset of people who access care in our system have an even higher uninsured rate among the population that we serve. And then I just make a note here, and we give kudos to our legislature, because for the last several legislative cycles, and in fact, over the last 15 years, the legislature has been working really hard to make up for lost time by continuing to invest in the mental health system and ensure that people have access to care and access to the right care at the right time. So we are in a situation in which we have very few people who are on a waiting list to get access to services. That is very different picture. If you look back to 2013, we had a high waiting list, and our legislator started taking steps to fund up that uninsured population in a way that we could build out capacity and avoid waiting lists for wherever possible. The catalyst for action is really, if you look at these as stair steps and you think about the interlocking circles there of primary care, mental health, and substance abuse, what you would know, anybody who has been in the mental health system, cared about the mental health system, thought about it over the years, knows that we have been really lacking in our ability to ensure that people with serious mental illness are able to access the medical services that they need beyond mental health and beyond mental health services. And that we in Texas have been far behind really in terms of recognizing the need to fund substance addiction services in a way that ensures that as we look at that high percentage of people with serious mental illness who have co-occurring substance addictions, that the need for us to be able to come in behind traditional mental health services and ensure that we can cover that service as well is really important. And so we've done a lot of work over the years to set the stage for delivering better care all around for people with serious mental illness. And what we know is that it's taken a lot of work to get there. And particularly when you think about the fact that we have such a high uninsured rate. So people don't have access to coverage for other services, even if they can access the mental health system. So in Texas, you'll actually find quite a lot of work that's done in concert with, in partnership with FQHCs, so that we can bring our expertise together and we can ensure that when we are serving somebody who has serious mental illness and the FQHC has the ability to provide some of the primary care for people and other medical and serve other medical needs, that we're able to work in partnership with them. But what we each know is that there is a need for us to be able to develop the ability to provide a more comprehensive array of services and ensure that we are able to address those needs as they are emerging. So you can see at the bottom of our stair steps, we began to work on integrated care. We were looking at our state in 2009, we supported legislation that would set up a study so that the state would look at what are the barriers for people with serious mental illness in terms of getting access to primary care and getting access to substance addiction services. We were teeing that up because we knew that as we work toward a better future, and we didn't need a study, there was many studies done, but one in particular that talked about the fact that 25% actually people with serious mental illness die 25 years earlier in their lives than people who don't have serious mental illness. In Texas, that number was even higher. So we know that people are impacted in many ways by co-occurring mental health or conditions, medical conditions that actually cause them to die much earlier than the general population. So we were really working to begin to change that picture and to think about what it would mean to really be able to deliver care when needed. We had the opportunity, Kyle was talking about the 1115 waiver. The DSRIP program is that acronym stands for Delivery System Reform Incentive payment. So that is a different payment program that has become really important to us in addressing that uninsured population, because it has allowed us to leverage otherwise unmatched state dollars or other local dollars for federal dollars in order to provide coverage for that uninsured part of our population. So since 2011 and over the ensuing years, we have really been able to build out a higher level of care for people. That program is slated to end in October of 2021, and I'll talk a little bit more about that in just a moment. But just as you work through this, you can see then at the top stairs, in the top tier, the Federal Mental Health Excellence Act in 2014. You may have talked about that. That really launched the CCBHC. When SAMHSA actually released the grants in 2015, we were in session and we were successful in supporting a rider being attached to the appropriations bill that directed the state agency to seek that CCBHC model for Texas and to seek that grant. We ultimately received a planning grant for the CCBHC program, but we were not selected as a demonstration state. Fortunately, we had enough groundwork laid that our state was willing to continue to work on how we could establish a Texas pilot for CCBHC that would be outside of the demonstration states. So now we are to 2019, where we are directed by the federal government to develop a transition plan so that when the DSRIP program ends and we no longer have that financing mechanism of being able to leverage state dollars for federal dollars through the 1115 in the same way that we had through the DSRIP program, we needed an alternative. And that's what's really important. And I think what has caught Kyle's interest and the interest of others perhaps in terms of figuring out how to utilize other mechanisms that are available to us through the federal government to bring this financing model in that would allow us to continue to move forward with the CCBHC strategy and to continue to figure out a financing mechanism that will allow us to take advantage of federal dollars to provide enhanced services. So when the 1115 program first began, it began as a series of projects in 2011, and the delivery system reform incentive payment program were projects that were locally designed and locally driven and then approved through our state agency and then by CMS as projects that would be funded through this financing mechanism of the DSRIP program. And we have interlocking circles here that just basically say these are the primary strategies that were selected by local communities, by community mental health centers who were identified as entities that could in fact leverage IGT, that is an intergovernmental transfer where we could take otherwise unmatched state or other local dollars and use them to put in for the non-federal share of the Medicaid program to draw that federal dollar down. And what you would see across our state were primary care really revolving around a behavioral health home, much like you think about a CCBHC representing today. But in the early days, what we were looking at was bringing together those substance use services, the community support services, mental health, and primary care. And if you look at the projects that were selected, you can see that in our state, you think about 39 community mental health centers, and you can see 31 integrated physical and behavioral health projects. That was a primary project in the DSRIP program. 23 projects for establishing crisis stabilization services and getting those expanded in our state. 25 projects for evidence-based interventions is really looking at people who have high needs, perhaps high interface with criminal justice, really focusing on projects that would allow us to provide care when it's necessary and for particular populations. And then expanding community-based services in underserved areas, a lot of development of clinics into the rural areas, and as part of that, substance addiction services as well. There's a lot of built into this expanding substance addiction services for that population that had previously not been able to get access to that care. And then peer support services being also a really popular project, because we know the value of peers and people who have walked this walk in terms of helping people understand that there is hope and there's light at the end of the tunnel when you can access the care that you need and the support that you need in your life. This slide is really just to say, basically to paint a picture of how important that 1115 district program has become to us in Texas and why it's so important that we have a transition to a financing model that allows us to retain those federal dollars. Because what you can see if you look at this, if you just look at the pie chart on the left-hand side of the screen, you'll see that 40% of the state-funded mental health services today is made up of the federal dollar coming in through the 1115 program. So it's vital to our service delivery. That represents about 274 million here in fiscal year 2018. In fiscal year 2020, that figure is about $334 million in federal dollars that's brought in through the 1115 district program. And if you look at this, the right-hand side, so what does that mean for us? It means that we've been able to reach here, that you'll see this holding pretty steady if you were to look at 2019 and even 2020 throughout the pandemic, that we've been able to increase the existing people. We can increase services for people who are already in our state. So the 1115 district program was designed to do two primary things: to enhance services and expand services. So we were able to expand services to better than about 100,000 people, about 100,000 people who are existing clients being able to get access to enhanced services, and about 120,000 plus people who were not previously able to get access to care, able to access care with the 1115 fund. So it's really important that we figure out a transition to retaining and sustaining the achievements that we've been able to get to. Even though the federal government is discontinuing that district program come October of 2021. So this is just a timeline. I talked about the fact that HHSC received the CCBHC planning grant in 2015. That gave us enough time for our state agency to begin to recognize the value, because we were bringing that CCBHC model of care into our conversations, into our systems, thinking about what it would take to step up and meet those requirements. And by the time we then get to 2018, even though we were not selected as a demonstration state, the state of Texas said, we want this across our entire state. We're going to make it a part of our foundation in mental health service delivery, even though we're not part of the demonstration state. So when you see the language on this one, where it speaks to the Health and Human Service Commission directing MCOs to negotiate alternate payment methodologies with CCBHCs, and that occurred in 2018. So despite the fact that we did not have that PPS payment structure that has been talked about, the state of Texas directed managed care companies to work with those centers that had been certified already, that had been certified as part of the planning grant, and that were getting certified as the state continued to move forward with certification across the rest of the state. And so we have a variety of ways in which managed care organizations are contracting with those sites in different ways than they had previously, trying to move away from a traditional fee-for-service into a more value-based kind of payment structure that starts to get to closer to what the CCBHC PPS program is all about. And then as we were beginning to think about the transition plan, we knew would have to come, because we knew that CMS intended to discontinue the program, the DSRIP in 2021. They came out with guidance to the state that allowed for the development of a directed payment strategy that would allow for a class of providers to be identified. And for us, that's CCBHC, to have a payment structure that would direct managed care companies to pay in a way that is different than fee-for-service. It actually creates a mechanism by which the CCBHC payment strategy could be in some ways structured similar to the demonstration states, but within a Texas style. So this particular slide says 11 CCBHC sites have been certified. That number is today 19. We are on track to have all of our community mental health centers up and as certified by July of 2021. So that continue. This says August of 2021. We are actually planning for that to be accomplished by July of 2021. The state has given themselves a little bit of wiggle room, but we want that up and ready for any transition, for the transition that is set to occur after the discontinuation of that DSRIP program. All right, so I really talked about the state directed payments, and when CMS came out with their payment initiatives, they described that you needed to have payments that were based on utilization and delivery, that it advanced quality strategies, and that it must have a mechanism by which you could evaluate quality improvement going forward. The CCBHC model actually has embedded in it all of the mechanisms that meet that CMS test for having a directed payment strategy. So our work today is really, and when we talk about a little bit of luck, it is the alignment of the CMS direction to the state and what we want to achieve that would have been done through a CCBHC PPS, to use an acronym, but instead can be managed through the directed payment strategy. So it really means that you could have an opportunity to get to what you want to without being a demonstration state, without having that particular position. And that is our goal. So we took that rejection of being a CCBHC state instead of saying, oh my, we're not going to be able to do this, we said, all right, so how can we do this even without that particular position at the federal level? So it comes down to a strategy that says CCBHC is a class of providers and a directed payment. I haven't talked yet about this, the three boxes here, the targeted SMI population. What we are have embedded in our transition plan that the state is working on now. We actually have had a number of meetings recently that would have taken place last spring, but for the pandemic, but it's been kicked back up again, and working now at a really fast pace to get this moving so that we can meet those timelines that are ahead of us. But this targeted SMI population is really about transitioning that financing mechanism of the DSRIP program that's covering that uninsured population that I was talking about, and utilizing a mechanism by which that population of people would be targeted as having access to Medicaid benefits and getting access to that CCBHC model of care. So it wouldn't be a program that was just accessible for people who are in traditional Medicaid, but also for people who have serious mental illness, meet the state's requirement for meeting the assessment level, the functional level of need that is already part of our state system for getting access to state-funded services, and as well as meeting the fiscal eligibility requirements. But that population is that population of people that we serve today in that 60% of uninsured, so that they can get access to the benefit of the CCBHC model of care and other benefits if our state chooses to go for an additional benefit package above and beyond the CCBHC. And then we build in integrated care capacity building as well, because CCBHC sets the stage beautifully for having more integrated care. You've already talked about that, I'm sure, today. But we also believe that there are mechanisms available to us to allow us to continue to leverage state dollars for federal dollars in a way that could help us build out services and social determinants of health and various ways in which we can improve the consumer experience and increase the opportunity for people to get access to care and to do well and to be successful in their lives and to reach recovery. So I think I include this slide and included it when I was doing the presentation, or intended to do the presentation for the National Council, because it speaks to the fact that we move forward with this as a system of care. We have unanimous support of all of our community mental health centers in the state. We have unanimous support of our board, of the executive directors consortium in the state. That's really critical for us to be able to move forward with this in a way that will help lift all boats and help us achieve a statewide system that is one that we can all be proud of, continue to be proud of, and to continue to work toward a day in which people with serious mental illness are able to really access a full range of care that they need at the point at which it's needed. And so with that, I will close out the presentation, and certainly I can even pull this screen down if you would like for me to.
Yeah, we wouldn't mind seeing your face. That would be good. Okay, committee questions, Representative Carpenter.
Thank you, Madam Chair. Thank you for being here. Sort of. Couple questions. How did you get around budget neutrality on your 1115 waiver?
How did we get to budget neutrality?
Correct.
So with cost savings, so our 1115 waiver came about as the district program that I was talking about is one part of the 1115 waiver. The waiver itself includes managed care as well. And so as we as a state were moving more and more services into managed care, there were concerns about losing the uncompensated care available for hospitals, the upper payment limit programs. And so we were able to, as a state, negotiate with CMS for a program that actually assumed cost savings. So as fee-for-service, traditional fee-for-services were moved into the 1115, moved into managed care, cost savings being generated, and CMS was willing to allow those cost savings to be really invested back into the healthcare delivery system. And the part that we have had involvement in enjoyed the benefit of that. So the district program was funded off of those projected cost savings. And as we now look to the future, and we were able to participate because what we said is, look, we've got general revenue in our system that is not matched today for federal dollars. There's general revenue that if we were able to leverage that general revenue through the IGT, through the intergovernmental transfer, and if we were able to then draw federal dollars in and participate in this 1115, we could really expand and enhance access to behavioral health services. Our state saw the value in that. The federal government saw the value in that. So we were able to benefit from basically projections of cost savings as our system moved into managed care.
Very good. Madam Chair. So can we talk about performance and outcomes? How do you measure those? Have they been good? Do you have data to back up other than dollars? I'm talking about outcomes for people.
Yeah, absolutely. So the first round of the DSRIP that was based on the projects that I was talking about, that first round, and actually the second round as well, contain within it a menu of measures, performance measures and outcome measures that can be selected by providers that enable them to demonstrate to both the state and the federal government that they have met these certain measures, are eligible then for being able to draw down those federal dollars. And David, if you want to answer that as well, from a provider's perspective in terms of how that works for you?
Yeah, so in the first round, the first 5 years, those measures were by the individual projects and had to show the specific outcomes for the individuals on those individual projects that were financed. For these last 5 years of the waiver, it is based on your overall provider system. And to draw down the fund, you actually have to show improvement on each of those measures in order to draw down the full level of the funding. And there is a baseline that gets set, and then the improvement level is determined by CMS for each of those measures.
Thank you, Madam Chair. Thank you for the answers.
Committee, are there further questions? How about on Zoom? All right, seeing Donette, I appreciate you being here with us today. This was very helpful for us, and we look forward to maybe hopefully being able to do something with it. You'll probably hear from us in the future to kind of pick your brain a little bit more on what we're doing. So thank you very much for joining us in Kansas today.
Okay, great. Thank you so much. We appreciate being with you today, and good luck in your work ahead.
All right, thank you very much. All right, committee, we took care of our minutes. I don't think I've got anything else. I'm gonna look at my staff. Oh, we do have one more thing. See, this is why I look at staff. I believe that Will Carpenter had asked for a sheet on the funding, and David's just gonna give a brief explanation of what that is on our CMHCs. No, we get to see you one more time. It was a lot.
It was a trip to get up here. Thank you, Madam Chair. There was some questions in terms of mental health funding and especially funding for community mental health centers. I wanted to provide a document for the committee. This is a document produced by our office. It's a history of mental health funding, and this has been emailed out to the members that are on Zoom as well. This was something that was provided to the 2020 legislative body. It breaks down mental health fundings across the state by different types of service provided, specifically for funding for community mental health centers. It's a little complicated when you get into the funding, so it's probably a longer conversation what we have remaining for today, but the key things is that some of the money that goes to community mental health centers is through reimbursable services, and those would fall in terms of the Medicaid payments that were discussed earlier. There are also contracted services. For example, a lot of the community mental health centers provide those crisis center services. And so the amount of funding that they receive for those services are contracted through those community mental health centers and KDADs. And then there's the amount of funding that the CMHCs receive in terms of grants. So the legislature over the last several years has at times added money in terms of grant funding for community mental health centers. And you're primarily going to see that increase in the top few lines here, particularly for the grants for at-risk persons in terms of that amount of funding going up. So we're going to provide this document for the committee. It had been requested by Representative Carpenter. This generally is available when the Budget Committee reviews the budget for the Aging and Disability Services Department. So I wanted to go ahead and provide this for the committee and hope that it's helpful information in terms of funding statewide.
Everything down.
Thank you very much, David. This is why we're gonna miss you so much. But thank you so much. We keep talking about how much has the CMHC's been cut and where our funding is going and everything else. And I'm just doing it quickly here, but I think this really gives us a good picture of how our money has been spent. So thank you. And again, I just want to say thank you for your excellence.
Thank you. I appreciate that.
You have something, Representative Carpenter?
No,
Yeah, you do. Go ahead.
well, I just might add, this has been a document that has been, you've heard me quote this many, many times. And one of the reasons why I'm on the performance and outcomes with us spending $564 million annually on mental health, we just have to make sure that those dollars are spent where they need to go, where they can do the most good. So this just kind of brings that message home. Thank you.
Any further questions or comments on this report?
Madam Chair,
Yes.
this is Senator Petty. This is for David. David, which of your emails is this attached to?
Should be a separate one all by itself that came in what, the last hour?
The last 2 minutes, probably.
The last 2 minutes.
Send us an email.
Why I can't see it. Okay, thanks.
Right, yeah, no, it was a request as we were going through the funding mechanism that Representative Carpenter had requested to get. So, because not everybody sits on appropriations to see these numbers. Any other questions, comments? All right, seeing none, I thank everyone for their work today, and we are adjourned until the 11th and 12th of December. It's not